I also request Dr. Sanjay Pandey sir, HOD Department of General Surgery, Subharti Medical College, to chair the session. Now, I would like to request the speaker for this session, Dr. Madhubala Gaurna, currently working as a professor and head of general surgery at GS Medical College, Hapur. She has more than 20 years of experience in basic and advanced surgery with a specialty in minimal invasive approaches. Hand over the mic to Dr. Madhubala Gaurna.
Very good morning, Dr. Sanjay Pandey sir, Maheshwari sir, all organizers, faculty member and resident doctors. So today my topic is laser in varicose vein, that is EVLA. EVLA is endovenous laser ablation. So laser energy is used for ablation of saphenous vein. The procedure is called as endovenous laser ablation or endovenous laser therapy. EVLT is basically a trademark for laser kit. Initially, it was described by Navarro and Ming in 2001. It is an one-stop OPD or daycare surgical procedure done under local anesthesia following preoperative assessment with duplex ultrasound. Knowledge of anatomical variations of great saphenous vein and short saphenous vein is required. It is associated with less pain than traditional surgery, in which there is stripping of the great saphenous vein. Patient suitability requires duplex ultrasound confirmation of the site of venous incompetence. Not all patients with varicose vein due to saphenofemoral junction and saphenopopliteal junction competence are suitable for EVLA. About 70% of primary and 45% of recurrent varicose veins are suitable for EVLA. A very tortuous GSV or SSV is a relative contraindication due to difficulties in advancing the guide wire. Both veins are usually reasonably straight with varicosities confined to the tributaries. So very tortuous vein anterior to the ASV is unsuitable for EVLA. The laser type and mechanism of action. Diode laser with wavelength of 1470, 810 and 940 nanometer can be used. Literature suggests that various wavelengths are usually effective when the same amount of energy is utilized per treatment length, defined as linear endovenous energy density. Less pain and bruising with higher wavelength lasers, specifically the water-specific laser wavelength. Wavelength is based upon a hemoglobin absorption peak to red infrared light of 800 to 1000 nanometer. Heat generated by laser produces steam bubbles that cause thermal damage to the endothelium and subendothelial layer. It results in focal coagulative necrosis and shrinkage, leading to the thrombotic occlusion of the vein. Histological studies following EVLA indicate failure of endothelial regeneration and progressive damage to the muscle layer of vein wall, resulting in further shrinkage. The tip of fiber may be where focusing the energy in a very small area. It can be divergent forward firing, spreading the energy over large area, or it can be divergent side or radial firing. The last two designs allow a more even distribution of energy, reducing venous wall perforation. There is no clear evidence to support one design over the another. A position of patient. Patient is supine with leg to be treated flexed and externally rotated at hip, and the knees are slightly fixed. Great saphenous vein cannulation is facilitated by placing the patient in Trendelenburg position. Pillow under contralateral lower hip or lower back may improve the patient comfort. For the short saphenous vein, the patient is positioned in prone position. Skin over the vein is clean and painted and draped with sterile drapes. USG guided GSV cannulation is done just above or below the knee at the lowest point of the reflux. Site is mid-calf for short saphenous vein. A guide wire is then passed beyond the SFJ or SPJ. 5 French catheter is then passed over the guide wire and its tip is positioned under USG guidance 0.5 to 1 centimeter distal to the junction. Position can be confirmed by visualization of jet of saline flushed through the catheter. Table is now placed in horizontal position. Up to 200 ml of 0.1% lignocaine is infiltrated along the length of the GSV or SSV to be ablated under USG guidance until vein is surrounded by tumescent anesthetic solution. This tumescent anesthetic solution provides anesthesia, compression of vein around the catheter, absorption of heat, and also it prevents damage to the surrounding neurovascular bundle. The laser fiber then inserted as far as the tip of the catheter, following which catheter is withdrawn by 2 cm so that laser fibers protrude beyond the catheter. The laser fiber is fired during stepwise withdrawal of 2 mm. So 1 second pulse, 12 watt or 60 to 80 joule energy, 810 or 940 or 1470 nanometer wavelength diode laser, and 1 second interval allowing withdrawal by 2 mm. During the treatment, manual pressure is exerted over the vein. Following laser removal, the exit wound is closed with suture strip and compression bandage is applied for 1 week, followed by class 2 compression stockings for a further week. Patient is immediately mobilized and encouraged to resume the normal activity as soon as possible. Patient can be discharged 20 to 30 minutes following the procedure. The usual treatment time is 35 minutes per leg, and bilateral GSV or SSV ablation can be performed in a single visit. So controversy for position of fiber tip. Some surgeons keep tips several centimeters distal to the junction. This strategy protects the deep vein from inadherent damage or thrombosis. Some surgeons aim for a flush ligation. Proponents to this argue that neoreflux in junctional tributaries is a common pattern of recurrence and rate of deep vein injury and thrombosis is lower in experts' hand. Results of treatment in great saphenous vein occlusion. In a study by Mean and colleagues, GSV occlusion rate was 100% at 2 weeks, 98% at 1 month, and 93% at 2 years. Factors influencing the success rate of EVLA are GSV diameter, length of vein ablated, total laser dose, joules of energy delivered per centimeter of vein. BMI. BMI doesn't directly affect occlusion, but might affect the efficacy of treatment of compression, GSV diameter, or the total laser dose. Delivery of 60 to 70 joule per centimeter of vein results in optimum SSV or GSV occlusion. Results of treatment in short saphenous vein occlusion. Potential risk to the use of EVLA at this site is the effect of heat on the common peroneal nerve. Irreversible nerve damage may occur at temperature of 45 degrees. Tumescent anesthesia eliminates the potential for significant nerve damage. Risk of sural nerve injury may be minimized by cannulating the SSV at or above the midpoint of the calf, the point at which the nerve normally joins the vein. So success rate is 95%, 97%, and 100% in various studies. What are the complications of EVLA? Most common complication is phlebitis of the treated vein, and it can be minimized by NSAID TDS for 3 days following the procedure. Rarely, superficial thrombophlebitis in calf varicosities secondary to stasis, which requires more prolonged course of NSAID. Local freezing along the line of treated vein, numbness or paresthesia in the distribution of saphenous or sural can be resolved within 3 months. Very rarely, there can be arteriovenous fistula and endothermal heat-induced thrombosis or DVT. So there are studies comparing outcome following EVLA and surgery. So the parameter shows abolition of reflex is success rate is 91% and 100%, while in surgery it is only 88%. There is minimum time required to resume the normal activity, while in surgery patient takes 14 days to resume the normal activity. Also, analgesia requirement is less in EVLA than the traditional surgery. Complications like phlebitis, nerve injury, phlebitis is more common less common in EVLA than surgery. But nerve injury, there is almost no chances of nerve injury in surgery, while in laser EVLA, there are chances of nerve injury. Then complications like DVT, it is again more common in surgery, less common in surgery than EVLA. Then recurrence is more common in EVLA if energy use is less than 60 joule, while it is less in surgery. Wound problems again common in surgery. Again, there is comparison of EVLA and radio frequency ablation. So EVLA is done under local anesthesia, while radio frequency ablation requires regional or spinal anesthesia. Treatment for varicosities, delayed varicotherapy, sclerotherapy is done in EVLA, while in RFA, phlebectomy is done. There is no limitation of size of saphenous vein to be treated by EVLA, while RFA requires vein diameter less than 12 millimeter. More than 70% patients are suitable for EVLA treatment, while only 30 to 58% patients are suitable for radiofrequency ablation. Success rate is 94 to 100% in EVLA, while in RFA, success rate is 85 to 100%. Mode of action in EVLA is heat, steam, endothelial and subendothelial damage, while in RFA there is endothelial and collagen damage and vasoconstriction. Paresthesia is found in 7.8% of EVLA, while in RFA there is incidence of 13 to 16%. Thrombophlebitis is up to 12% in EVLA, while it is up 20% in RFA. DVT again almost comparable in EVLA and RFA. There are no skin burns in EVLA, while in RFA there are 20% incidence of skin burns. Cost: EVLA is less expensive and OPD procedure, while RFA is more expensive than surgery and it is IPD procedure. So take home message is EVLA is gaining popularity in the treatment of superficial venous incompetence. Minimally invasive, one-stop cost-effective OPD procedure and obviates the need for spinal anesthesia and general anesthesia, which is required both in RFA and traditional surgery. Procedure is faster, easier to perform than RFA without any limitation of size of saphenous vein to be treated. It is more cost-effective and is superior to RFA and traditional surgical procedure in terms of abolition of reflux, minimal complications, early return to work, and patient comfort. Overall, EVLA has an excellent safety profile and majority of minor complications can be avoided with the use of appropriate procedural planning and technique. I don't do this procedure, but I have downloaded the video from YouTube showing the EVLA. So first, with the help of Doppler scan, the path of the saphenous vein is delineated. Then at the point of lower reflex, the vein is punctured. Fiber positioning is done through the catheter. Local tumescent anesthesia, 0.1% lignocaine in 200 ml of saline is infiltrated in transverse and longitudinal plane. Then laser fiber is withdrawn by 2 millimeter and machine is set at the energy 60 to 70 joule. Patient is quite comfortable during the surgery due to the effect of tumescent anesthesia. This is the withdrawal of the laser fiber. So after removal of the laser fiber, suture strip is placed and compression bandage is applied. Patient can resume his normal activity within 2 to 3 days, can be discharged within 15 to 20 minutes. Thank you very much, the whole organizing committee, Pandey sir and Maheshwari sir, for giving me this opportunity. Thank you.
Always, as usual, very good presentation, I must say. Whenever you are giving so nicely to the dais, I really feel quite proud of myself.
Thank you, sir.
Subharti, because it is your alma mater. Very good to see here again. Yes, very good things. You went to EVLA. Definitely very good thing. But I don't know about study, you have been quite a big number of recurrences of there in this study. Very paradox with the open surgery. We were open surgery, we have done RFA and we should go to EVLA. The big paradox was when we were doing open surgery, the concept was of flush ligation. You don't give any tributary or pipe, you flush ligate it. But still, because this is not there, because as usually was said, some tributary must have been left. With this EVLA, we are not going up to the junction. We are moving proximal to it and then. But recurrences are not in that proportion. What has we have written onto it, what has emerged is the concept of neovascularization. Is so much so ischemia we are using that neovascularization will lead to recurrences. This is a new concept. So definitely, still we are not having a big data to support or suggest that saphenofemoral incompetence is more good for a flush ligation or a EVLA, but definitely the perforated incompetence, the recurrence is very low, almost negligible. That I must say. Anything?
Yes, ma'am. Ma'am, actually, there is in the slide, there is presentation, there is an obligation rate of DVT in EVLA is 0.29%. So, ma'am, I want to ask.
No, I have not mentioned 2.9%.
0.29, sorry, 0.29%. So, what precaution one surgeon should take so that the DVT complication cannot occur in an EVLA surgery?
Mainly, it should be done under ultrasound guidance, and energy setting should be fixed up to 60 to 70 joule only. And to prevent the neurovascular damage, role of tumescent anesthesia is very important.
Well, is there any role of a low molecular weight device in the post-operative period?
I think in no, because in EVLA we immediately mobilize the patient. It is daycare procedure, so there is no need of low molecular weight. But in high risk patient, cardiovascular patient with hypertension, diabetes, or cardiovascular patient CAD, we can definitely try. Thank you once again.
Thank you, ma'am, for the enlightening session. Now, I would like to request Dr. Sanjay Pandey, sir, to please felicitate Dr. Madhubala Gaur, ma'am, Thank you, sir. Thank you, ma'am. I would request Dr. Brain Singh, sir, to please felicitate Dr. Sanjay Pandey, sir. Thank you, sir. I would request Dr. Sandeep Kansal, sir, to please felicitate Dr. Rahul Dayal, sir. Thank you, sir.
Today, artificial intelligence is everywhere. It is empowering every field that it has become invincible.
But ma'am, surgery to हाथ का काम है. What can AI do for a surgeon?
The goal of AI in the OT is not to take the scalpel out of the surgeon's hand, but to put a GPS in surgeon's mind. So we can predict the risk before the first incision is even made.
Oh ma'am, like the third eye.
To chair this session, that is what our next session is about, role in AI. To chair this session, I invite on stage Dr. Uttam Jain sir, a renowned surgeon of Meerut with more than 10 years of experience in his field. Dr. Virender Singh sir, professor and current HOD of SMMH Government Medical College Saharanpur. Speaker for this session will be Dr. Anuj Sharma sir, Professor General Surgery, NCR Medical College.
Hi, good morning everyone. वो है क्या? मोबाइल में नहीं है. So I am Stephanie basically. ये presentation मेरे लिए था नहीं, and someone was not able to come, तो मुझे दिया गया, and it was an interesting topic. तो मैंने इसको I opted gracefully. So let's start with one scenario. ये पेशेंट है, मेरा ही पेशेंट है. I operated on penetrating injury, knife injury थी, and multiple perforations थे, and everything went well. ICU में ventilator में भी रहा, but discharge हो गया. After 1.5 months, he came back with subacute intestinal obstruction, vomiting, abdominal distension, all sort of features. And as usual, हमने आके डाली, MPO किया, and अपना usual treatment हम कर रहे थे. And suddenly, night around post admission का day 2 था, 1:30 RMO called me. He said ये ठीक नहीं लग रहा है और आके देखो. And this was the scene when I went there. मुझे कुछ समझ में आया नहीं. मैंने vitals देखे, vitals ठीक थे, तो I thought maybe anxious होगा. मैं थोड़ा sedate किया, वो सो गया. But something was in my mind कि कुछ तो है. Something मैंने अपने physician को बोला कि भाई एक बार देख लेना. फिजिशियन को उस टाइम पे तो कुछ था नहीं, एंड फिजिशियन वाज ओके कि नहीं सर सब ठीक है, ऐसा कुछ होगा तो देखेंगे. देन आई कॉल्ड माय साइकियाट्रिस्ट कि भाई एक बार देख ले, पीटीएसडी टाइप का कुछ लग रहा है, एंड जस्ट टेक केयर ऑफ इट. ही वाज आल्सो ही एडेड सम एंटी एंजाइटी ड्रग्स एंड थिंग्स वेंट ऑन. नेक्स्ट डे सिमिलर एपिसोड हैपेंड एट अराउंड सेम टाइम, नाइट 1 और 2. उस टाइम पे हेल्प होती नहीं आपके पास. एंड somehow मैंने उसकी फोटो खींची और मैं अपने रूम में आके बैठा, अगेन उसे सिटेट किया और मैंने आई जस्ट फिल्ड द हिस्ट्री इन चैट जीपीटी कि दिस इज अ पेशेंट, उसकी थोड़ी हिस्ट्री डाली और ये सिनेरियो हो रहा है, प्रेजेंटली है. द फर्स्ट क्वेश्चन वाज आर यू यूजिंग एनी एंटीबायोटिक्स. I wrote, yes, we are using AMSET also, we are using Paranorm also. So then the answer came, it is acute dystonia reaction due to toxicity of Paranorm. So that was a shock I received. What AI can do. So ऐसा नहीं है, there are a lot of controversies and this PPT is completely made by AI. So I'll start my presentation. कहाँ से आगे पीछे करना है? मैं चाइना गया था. चाइना में एक जगह है शेंजन, where I tried driverless car. It was a very terrifying experience. कि कोई बैठा नहीं है, गाड़ी चल रही है, क्या होगा? बट वहाँ पे जितने भी टूरिस्ट जाते हैं तो it is one of the main attraction कि भाई ये देखना है. So I was just thinking, एक ड्राइविंग करना और एक ओटी करना, मतलब क्या चीज ज्यादा करना आ गया? अगर आप एक्सीडेंट देखेंगे तो रोड में ओटी से ज्यादा होते हैं. बट देयर AI has taken over. They are driving the car, they are taking care of all things. कहाँ रेड लाइट आ रही है, कहाँ कोई एकदम से कूद गया, कहाँ ब्रेक मारना है, कहाँ डायरेक्शन चेंज करनी है. मतलब they did a test. उन्होंने AI को एक ऑप्शन दिया कि भाई आपकी गाड़ी में ब्रेक इज नॉट वर्किंग एंड इस साइड जो है देयर इज सम हर्डल, अगर आप उसमें टकरा गए तो जो गाड़ी में बैठा है ही मे नॉट सर्वाइव. और सामने एक यंग लेडी, एक ओल्ड लेडी और एक बच्चा. व्हाट विल यू डू? विल यू बिलीव इट? दे वर एक्सपेरिमेंटिंग कि भाई इस तरह के डमी रखे और क्या करेंगे. AI रिवर्स कर रहा है. सो दे हैव गॉन एट सो लेवल. अब हम यही सोचे कि भाई रोबोटिक तो आई है, हमने 10,000 सर्जरी करी है, उसमें 10 लाख सर्जरी डाल दो और उसको ऑटो मोड पे कर दो, तो क्या AI पूरी सर्जरी नहीं कर लेगा? चलिए देखते हैं इसको. I hope everyone is aware of this agent hospital in China. I tell you a brief. They made this hospital. It has 14 AI doctors and around 10 AI nurses. There is no human in this hospital. And they have made multiple hospitals like this. What they do? They triage. A patient comes with a fever, tells the complaint, they withdraw blood, they make reports, they give prescription. If they think that this thing is not feasible, triage में ये काम यहाँ नहीं हो सकता, then they will get the appointment book and send them to higher hospital. And they screen 10,000 patients in 9 days. 9 days. तो ये सब चीजें अब फ्यूचर नहीं रह गया है. These things are already happening. बाकी यूएस और वहाँ लाइसेंसेस का बहुत इश्यू है. Everything comes with time, but China is doing wonders. And there is a documentary over it. अगर आप लोग को इंटरेस्टेड हो तो YouTube में उसको देखेगा. हर्डल्स जब वो ओपन से लैब में शिफ्ट हुए थे, या हम लैब से 3D में शिफ्ट हो रहे हैं या हो चुके हैं या रोबोटिक में शिफ्ट हो रहे हैं, हर्डल्स हर जगह आई हैं. देयर एक्सेप्टेंस थी, कुछ लोग एक्सेप्टेंस नहीं थी, बट अल्टीमेटली यू हैव टू एक्सेप्ट इट. इट इज ऑलरेडी अ पार्ट ऑफ योर लाइफ नाउ. अब आपकी चॉइस है, आप उसे एक्सेप्ट करते हो या नहीं करते हो. अच्छा, जब ये मैंने बनाना शुरू किया था तो आई गेव अ वेग प्रॉम्प्ट टू AI कि मुझे एक ऐसा प्रेजेंटेशन बनाना है, बना के दो. उसमें मुझे बहुत कुछ दिया कि पहले मशीन लर्निंग बताओ, फिर AI लर्निंग बताओ, और बट मुझे लगा कि बहुत थ्योरेटिकल हो जाएगा. Then I made multiple prompts. This presentation is completely made from AI versions. तो अब चलते हैं AI हमें कहाँ हेल्प कर सकता है फ्यूचर में या प्रेजेंटली या मे बी. सबसे पहले ट्रेनिंग. अभी तक हम कैसे सीखते हैं? Anyone, अभी तक हम कैसे सीखते हैं? क्या मेथड बोलते हैं उसको? See1, do1, teach1. ACM नहीं करी किसी ने? चलिए कोई बात नहीं. तो द ट्रेडिशनल मेथड कैडेवर पे सीखते हैं हम लोग. ठीक है, वी डू हैव स्किल लैब जहाँ हम थोड़ा बहुत VR पे भी कर सकते हैं. एवरीथिंग इज गोइंग ऑन. अल्टीमेटली जो आप फर्स्ट सर्जरी करते हो अंडर गाइडेंस, वो ह्यूमन पे करते हो. बट व्हाट इफ यू गेट अ स्टिमुलेशन लाइक दिस गुड डॉक्टर देखिए किसी ने, डोंट टेल मी कि वो नहीं देखी एनीवन। तो व्हाट दे यूज्ड टू डू, एनी डिफिकल्ट सर्जरी, उसके सिटी एमआर एवरीथिंग वाज टू कम ऑन द स्क्रीन एंड दे गेट अ 3D मॉडल और वो उसमें ऑपरेट करते थे। एक बार फेल हुए, 2 बार फेल हुए, 50 बार फेल हुए, एंड वंस दे सक्सीड देन दे गो एंड अटेंड ऑन पेशेंट। तो these things are no more scarified, they will come soon। तो सबसे पहला it will help us in training। You will get the same environment, same tactile feedback, and it will not be like this कि आपका senior बोल रहा है, अरे तेरा हाथ कांप रहा है। It will tell you कि you took 5-minute delay in doing this thing, and there was vibration of 0.5 milliseconds, something like that। ऐसे गाइड करेगा वो आपको, आप इतने एंगल दूर थे सही चीज से। So again, they use some terms like kinematic analysis, every unnecessary movement quantified, force feedback, measuring subclinical tissue trauma, आपने आसपास कितना ट्रॉमा किया, पाथ एफिशिएंसी, आपके जो मूवमेंट थे वो सही डायरेक्शन में जा रहे थे या नहीं जा रहे थे। So it will eliminate the learning curve through black box analysis। I'll tell you what is this black box analysis। तो सेकेंड ईयर में क्या हेल्प करेगा? What all we do? Do we only operate? No, we do a lot of things, है ना। हमारा होराइजन बहुत बड़ा है, हम हर चीज याद करने की कोशिश करते हैं। अच्छा, how we say we are skilled, और आप बोलते हो ना कि यार वो मास्टर है, वो कर लेगा, कैसे? That is biological AI। सर है, सर ने अब 10,000 केस कर दिए हैं, तो सर ऑलरेडी है वो बायोलॉजिकल AI। सर बता देंगे कि भाई ये वाला केस डिफिकल्ट निकलने वाला है ना। नाउ वी मेक पैरामीटर्स, हमने कोई गाइडलाइंस बनाई कि भाई ये चीज देख लो, तो ये सब कैसे बनी? एक्सपीरियंसेस से, डाटा से। इसके पास क्या डाटा है? इट कैन बी मिलियंस, बिलियंस, देयर इज नो एंड, एंड ही रिमेंबर द एवरीथिंग, है ना। तो आर्टिफिशियल एआई, बायोलॉजिकल एआई है हिंड्रेंस। कभी बीमार होंगे, कभी आपका मूड अपसेट होगा, योर माइंड इज नॉट फोकसिंग, आप थक गए हो 10 केस करके, बट वहां ये सब चीजें नहीं है। सो रेडियोलॉजी, आप पता नहीं, हमको पता है एम्स में कुछ सेंटर्स में दे हैव स्टार्टेड जनरेटिंग एआई रिपोर्ट, नीचे लिखा होता है ये रिपोर्ट एआई से जनरेटेड है, एज सून एज वी विल गेट टाइम वी विल गिव यू अ फाइनल रिपोर्ट। तो दे हैव ऑलरेडी स्टार्टेड इट, देयर आर एप्स, कंप्लीटली एप्स, आप उसमें फिल्म डालो और वो रिपोर्ट देता है। एंड बिलीव मी, देयर आर मेनी सेंटर्स हु आर नॉट डूइंग वेरी गुड, जो अच्छी फिल्म लेते हैं बट रिपोर्ट ठीक नहीं होती। अगर हम लोगों को जिनको बहुत अच्छे से रिपोर्ट पढ़नी नहीं आती या कुछ ये मिस कर रहे हैं, ट्राई पुटिंग इट, वो सिटी और एमआरआई की फिल्म एआई में डाल के देखना, एंड यू विल सी वंडर्स। यू विल पिक अप कि भाई इसमें ये चीज शायद मिस है, आप एक बार रिकन्फर्म कर लीजिए। सो इमेजिंग रिकॉर्ड्स एंड ग्लोबल नॉलेज, दिस ऑल विल कम एट वंस। अभी तक हम बताते हैं कि भाई पेशेंट को कि भाई ये डिफिकल्ट सर्जरी है, 20% चांसेस है कि इसमें हमें लेप्रोटमी के बाद कोलोस्टमी करनी पड़ेगी, बट द टाइम विल कम, नाउ यू विल पुट द डाटा एंड ही विल गिव यू इसमें 12% चांसेस है कोलोस्टमी करने के। तो यू विल हैव द एक्यूरेसी, और एक्यूरेसी आएगी कहां से? जब हमारा डाटा वहां पे फीड होगा, इलेक्ट्रॉनिक मेडिकल रिकॉर्ड जनरल होगा, होने लग गया है। ये जो गवर्नमेंट की जो ABHM और ये सब स्कीम्स आ रही हैं, इसमें दे आर ट्राइंग टू मेक इट कंपल्सरी। व्हाट नेक्स्ट, व्हाट ऑल इट कैन डू? कितनी बार हुआ है आपके पास कि आपने कोई इमरजेंसी में पेशेंट आया, ऑपरेट कर दिया, फिर आपको पता चला आईसीयू में तो बेड ही खाली नहीं है, फिर वो पोर्टेबल वाले वेंटिलेटर पे उसको रखा हुआ है या उसको शिफ्ट करने की कोशिश कर रहे हो। तो दैट्स व्हाट इट विल डू, एनालिटिकल एनालिसिस। जब आप पेशेंट का डाटा फीड करोगे तो बता देगा कि भाई इसको वेंटिलेटर की जरूरत पड़ेगी, आईसीयू में आपके पास बेड नहीं है, डू यू वांट टू प्रोसीड। ये इन्फॉर्मेशन ऑब्वियसली हम लोगों के पास भी होनी चाहिए, बट उसके लिए हमें कितनी मेहनत करनी पड़ती है ना, और कई बार हम मिस कर जाते हैं। बट The time will come. The things are endless. But I just want to highlight what all things we can see in future. As I told you, good doctor, आपने सब कुछ 2D में देखा है, CT, MRI, लैप्रोस्कोपिक अब आने लगे 3D, बट अभी तक हम सब 2D पे काम करते हैं. But once you create these images, he will give you a 3D description and you can assess कि ये पीछे इसकी वेसल कौन सी आ रही है, इसको हमें कैसे बचाना है. This all can be done in pre-operative time before even touching the patient. So just think, it will like a virtual walkthrough. So ये तो हुआ बेसिक मैनेजमेंट. प्री-ऑप में क्या होगा, डाटा एनालिसिस में क्या होगा, आपको डायग्नोसिस में क्या हेल्प करेगा. नाउ ओटी. अगेन ओटी में सर्जन इज द हीरो. He is not the technical person who is operating. Anesthetists का अगर मीटर बज रहा है तो वहां भी पूछ रहा है क्या हो गया, ठीक है ना सर, है ना. क्वार्टरी मशीन नहीं चल रही तो वहां पे चिल्ला रहा है वो, क्या अरे इस पोर्ट में डालो, उस पोर्ट में डालो. तो दिस ऑल थिंग्स विल बी टेकन केयर ऑफ. एवरीथिंग, एवरी मशीन इज कनेक्टेड और जिसमें जो एरर होगा दैट विल बी डिस्प्लेड बिफोर हैंड. उसका करेक्शन जो होगा वो उसके बाद मैसेज पहुंच जाएगा कि भाई बायोमेडिकल इंजीनियर के पास मैसेज पहुंच जाएगा, इस मशीन में प्रॉब्लम है, यहाँ केस शुरू होने वाला है, आके देखो. इट विल मेक योर लाइफ soothed. And finally, as someone told, GPS during a surgery, suppose it will tell you wrong move and there will be an error, pay attention, or you are going in a wrong track. How will the surgery, जब आप डिसेक्शन कर रहे होगे तो ये बोल देगा कि भैया डिसेक्शन थोड़ा सा ऊपर कर लो, आप जरा सीटी की तरफ जा रहे हो. तो that thing will come. एक स्टडी हुई थी जिसमें बहुत ही रिनाउंड सर्जन्स को लिया गया और उनसे पूछा कि आप लोगों ने कितने परसेंट केसेस में, कुछ केसेस हुए, सर्जरी हुई, रिकॉर्डिंग हुई, वो रिकॉर्डिंग थी, कितने लोगों ने सीरियस क्रिटिकल व्यू ऑफ सेफ्टी अचीव किया था. 50% ऑफ द सर्जन सेड वी अचीव. एंड व्हेन दैट वीडियो वाज गिवन टू एआई, एनालिसिस वाज डन, दिस वाज द रिजल्ट. तो व्हाट वाज दिस? This is a misconception, misperceptions, ego, whatever it is. So now, if you are assessed like this, you will be more cautious and safety will increase. बहुत फेमस स्टडी है, अगर आप लोगों को किसी को पढ़नी हो तो. As I told you, it will be a GPS. ये आपको मार्क करके देगा कि भैया कहाँ जाना है, कैसे जाना है. So ultimately, again I am saying you have to accept the fact it has already come. जब कैलकुलेटर आया था ना तब लोगों ने बोला था कि भाई मैथ्स का वो मजा नहीं रह जाएगा, कि एवरीथिंग इज कैलकुलेटेड, क्या फायदा, इतना जो नॉलेज है वो कैसे करेगा. बट अल्टीमेटली एक्सेप्टेड. सेम कंप्यूटर आया, सेम नई टेक्नोलॉजी आई, अब एआई में भी देयर लॉट ऑफ कंट्रोवर्सीज. सो बट अल्टीमेटली यू हैव टू एक्सेप्ट द फैक्ट कि यू हैव टू बी the part of it. नहीं, at least in our lifetime, at least in our country, AI is not going to replace surgeons. But obviously, a person having a knowledge of AI will replace other surgeons. But there are hurdles. ये सब जो करता है AI, वो डाटा से करता है. अगर उसको गलत डाटा मिलेगा, तो obviously वो गलत डाटा आउट करेगा. मेडिकल लीगल इश्यूज, अगर आप उसको उससे कुछ डायग्नोसिस बना रहे हो या उससे कुछ हेल्प ले रहे हो, उससे वो गलत हो गया तो रिस्पॉन्सिबल किसको ठहराओगे? देयर इज अ केस गोइंग ऑन इन चाइना जिसमें एआई कार ने एक एक्सीडेंट कर दिया था एंड दैट पर्सन डाइड. एंड स्टिल उसमें जो कंपनी थी उन्होंने कहा था कि हमारा प्राइम इज आवर कस्टमर, वो सेफ रहना चाहिए. मैंने कहा थोड़ी कि सामने वाले को मार दोगे. अभी भी वो केस चल रहा है, there is still nothing, but ultimately things will come. तो ultimately what I want from you guys, अगर आप थोड़ा बहुत मतलब I am sure जो junior है they must be knowing much more than me. है ना, कि AI को कैसे यूज करते हैं. बट जो एटलीस्ट मेरी एज ग्रुप के जब तक यूज नहीं कर रहे हैं, तो आई वांट 3 थिंग्स जो एटलीस्ट आप स्टार्ट करिए. रिकॉर्ड ऑल योर केसेस, वेदर ओपन or laparoscopic, because ultimately we have to collect data, make electronic medical records, and start using AI for smaller things. Like मुझे अगर अपने प्रिंसिपल को कोई लेटर लिखना होता है, तो आई नो मोर मैं अपने क्लर्क को बुलाऊं और उसको बोलूं कि ये लिख, वो नहीं होता है ना. आई जस्ट गिव प्रॉम्प्ट कि मुझे just write a letter to the principal that I want to conduct the examination on this date and these are the examiners, and he will formulate it. I'll just copy and paste and print it. वो इसने मेरा कम से कम आधा घंटा बचाया. Isn't that half hour important? इस तरह के कितने टास्क हैं जो उसको डेजिग्नेट कर सकते हैं, बट उसको ढंग से करने के लिए you should know ABCD of prompting. So I just want you guys to do 3 things. ABCD of prompting सीखिए, इसको बेसिक कामों के लिए यूज करना स्टार्ट करिए और अपना डाटा इलेक्ट्रॉनिक करिए. बाकी जो टाइम बताएगा कि व्हाट वंडर्स इट कैन डू. थैंक यू.
Thank you, sir. After this session, I'm sure AI will not replace surgeons, but the surgeons who use AI will replace the surgeons who don't. Now, I would request Dr. M.K. Maheshwari, sir, to please felicitate.
I'd like to ask you,
Hello.
again, the point that you made, who's going to take the rap of something goes. That is again a question, because in today's scenario, no one is doctor friendly.
That's very
The judiciary, the lawyers and all.
That's very true, sir. But still, जब आपने उनको कार दे दी हाथ में, है ना, तो फिर ये सब चीजें तो बहुत सेकेंडरी हो गई. एक्सीडेंट्स आर मच मोर, मतलब अगर आप रेशियो देखेंगे तो रोड ट्रैफिक एक्सीडेंट वर्सेस OT एक्सीडेंट्स, रोड ट्रैफिक एक्सीडेंट्स आर मच हाई एंड यू हैव ऑलरेडी गिवन डेट परमिशन टू AI. तो अल्टीमेटली थिंग्स विल चेंज. हां, ये वाले पहले ब्लैक इश्यूज बोले, इन दिस थिंग मेकर हु विल हैव द रिस्पांसिबिलिटी. मे बी द person who designated the task, maybe the company who made the AI, maybe the government who allowed it, I don't know. That's why अभी भी चाइना में जिस लेवल पे यूज हो रहा है और कहीं नहीं यूज हो पा रहा because of these issues, ethical issues or medical legal issues. But ultimately time will come.
And second thing is, many times we make many decisions on the table. Like let's take anastomosis. Now it's all experience कि यार एक प्रोटीन देख ले इसका उपयोग में क्या था. अगर ठीक भी था 10 दिन पहले पेशेंट कुछ खा नहीं रहा है, इतना बड़ा पड़ा है, तो anastomosis करेगा नहीं करेगा. Now based on that AI, supposing AI says या anastomosis, आप
सर AI आपको कभी ये नहीं बोलेगा एनालिसिस कर दो. जब आप डाटा अभी भी डालोगे ना सर, एंड जस्ट पुट योर क्वेश्चन कि पेशेंट की आप स्पेसिफिकेशन डालो, रिपोर्ट्स डालो, हिस्ट्री डालो एंड पुट योर डिलेमा. What do you think? Whether I should do a primary anastomosis or a colostomy? Then he will give you a comparison table. कि भाई इस तरह के इतने केसेस में ये किया गया है, that was the success rate, और ये किया गया, that was the success rate. So I prefer to do this. He will give you options like this. Just try using it. मतलब जब आप एक colleague के साथ डिस्कस करते हो, it's just like if you don't have a colleague and you are discussing with some master.
See, what you are saying, sir, what Arjun has rightly said. What we do through digital or AI is machine learning. I think we must understand. Machine learning means we just feed the data and it says the outcome is this. This is the simplest thing digitally being done worldwide from in every field. What now newer has come in surgical aspects is deep learning. Deep learning means even if the computer is being set, even if you don't know or you are committing a mistake, even the data you don't have, you suggest to tell something about it. That is a deep learning. But the limitations are in all this thing is that data. Because millions and trillions data is required. And even today, we don't have millions of surgical data online. That is the problem. Japanese have developed a very good, they have named it Eureka. But they are not using, they are using it just for the teaching purposes. They predict everything. You see their work, what the best surgeons, 10 best surgeons have done surgery, and what the Eureka will see. Eureka is telling you where the nerves are going. It is giving them a green color. Wonderful. But they are not saying, but they are, except for China, they are not using just because of this problem. We don't have enough data for the deep learning. In the coming time, yes, definitely 20, 30 years, when everybody is doing the data, we will have billions and trillions. Then this problem, what we were saying, will not be done. That is true. That is the real reason.
So are we replacing our experience vis-a-vis AI?
That's what I
Are we handing over our domain to AI tomorrow? Because surgeons like who spend lifetime doing surgeries and have a lot of experience.
But once you have a mind of thousands of such surgeons,
Sir, actually,
what?
it is giving. If I am doing surgery for last 20 years, it is giving my knowledge to a new person too. Actually, once there is actually आप last 20 साल से सर्जरी कर रहे हैं, जो आपने गेन किया, इसके द्वारा AI के द्वारा वो एक नया बंदा भी नया पर्सन भी यूज कर सकता है. I think it is the advantage.
But आप अकेले नहीं है ना.
हाँ, multiple हाँ.
और उन सब का
Yeah.
डाटा वहाँ पे है और आप उसको यूज करना.
Collecting knowledge basically it is.
So there is no doubt it will do it. Obviously, there a lot of things comes in our question, but I'm telling you, once you start using it, then you will realize how simpler it will make your life.
Very interesting experience assumes individual experience decided override the decision or a suggestion that has been prompted by AI. Maybe individual experience.
Dr. Anuj,
I started with one case. and this is a lifetime experience for me. कि वो पेशेंट था and everyone took कि post traumatic stress disorder है, young है, vital stable है, कुछ नहीं है. And there was single click, I got the answer. The patient was discharged very next day, just by stopping Panadol. Nothing else was done. So what's this? Sir, मेरा physician ने देख लिया, मेरा psychiatrist ने देख लिया, 2 बार मैंने देख लिया. ऐसा नहीं है कि हमें नहीं पता था. Then we realized कि हाँ यार, we missed it. But that mind didn't miss. तो सर ये एक guidance है ना?
AI will assist you. AI will not replace you. It will assist you.
Sir, even after 100 years, it will replace also. We don't know, but we are safe.
Dr. Anuj, very nice presentation in very simple language and interesting. Make it just.
One medical legal issue on AI.
Sir, आप तो medical legal आप ही बताइए.
नहीं, अब एक लाइन. अगर आप AI से गाइड होके कोई ट्रीटमेंट करते हैं, लेटर ऑन 2-3 साल बाद कोई लिटिगेशन होती है, तो प्रिकॉशन नंबर 1, पेशेंट की कंसेंट लें कि AI गाइडेड ये है और मैं उससे प्रोसीड कर रहा हूँ. नंबर 2, जो भी एडवाइस मिलती है उसको देन एंड देयर आप स्टोर करके केस शीट का पार्ट बनाएं. क्यों? 3 साल बाद अगर सेम डाटा आप AI को फीड करेंगे तो रिजल्ट डिफरेंट हो सकते हैं. तो इसलिए देन एंड देयर 2 चीज़ें कीजिए. पेशेंट से कंसेंट लें कि AI गाइडेड ये चीज़ आई है, मैं प्रोसीड करूं या ना करूं. और दूसरा, जो रिजल्ट आए उसको आप केस शीट का पार्ट बनाएं, जिससे 3-4 साल बाद अगर लिटिगेशन होती है और सेम डाटा अगर पेशेंट का अटेंडेंट या आप भी फीड करेंगे तो रिजल्ट डिफरेंट हो सकते हैं.
Thank you, Dr. Anuj.
Thank you, sir. After this session, I'm sure AI will not replace surgeons, but the surgeons who use AI will replace who don't. Now, I would like to invite Dr. Uttam Chan sir to please felicitate Dr. Anuj Sharma sir. I request Dr. M.K. Maheshwari sir to felicitate Dr. Viren Singh sir. request Dr. Ritik Bansal sir to please felicitate Dr. Uttam Jain sir.
After our two enlightening session with the presence of our dignitaries, we proceed towards our inauguration. I, Dr. Sunidhi, Senior Resident, Department of General Surgery, Subharti Medical College,
And I, Dr. Akriti, Junior Resident, Department of General Surgery.
it is our privilege and honor to welcome you all to this prestigious academic gathering, Subharti Surgery Update 2026, dedicated to recent advances in art of surgery to refine our knowledge in order to improve patient care and contribute to evolving surgical practices.
Before we begin this academic endeavor, let us seek the divine blessings. Let us now bow our heads in front of Mata Saraswati to illuminate the lamp of our knowledge and proceed towards lamp lighting ceremony.
To illuminate the lamp of our knowledge and proceed, I would request our esteemed dignitaries, Dr. P.K. Sharma sir, Vice Chancellor, Subharti University. I request Maheshwari sir to escort. Dr. M.K. Mittal sir, Principal, Subharti Medical College. Dr. H.S. Minhas sir, SMS, Subharti Hospital. Dr. Sanjay Pandey sir, Chairman of the conference and HOD.
Right click, open with. एक बार डबल क्लिक कर दीजिए, फुल स्क्रीन हो जाएगा.
Now, for the start of the inauguration, we'll first request Dr. M.K. Maheshwari sir, organizing chairman of the conference, to have a few words for the audience and all the dignitaries.
Jai Hind, everyone. It is with great honor and immense pleasure that I welcome you all to Subharti Surgery Update 2026. It is a national level conference dedicated to the advancement of surgical science, education and innovation. On behalf of the organizing committee, I extend a warm and heartfelt welcome to all our distinguished guests, eminent surgeons, academicians, researchers, and postgraduate trainees who have gathered here. Your presence truly enriches this academic platform. Surgery, as we all appreciate, is a dynamic and ever-evolving discipline. From the refinement of operative techniques to the integration of minimally invasive and technology-driven approaches, the field continues to advance at an extraordinary pace in such a rapidly progressing landscape. Academic forums like this conference play a pivotal role in fostering knowledge exchange, critical thinking, and collaborative growth. The theme of this conference, Recent Advances, has been thoughtfully chosen to reflect contemporary challenges and emerging trends in the surgical practice. Over the course of this conference, we aim to engage in meaningful discussions, explore evidence-based advancement, and deliberate upon strategies that will ultimately enhance patient care and surgical outcomes. I would also like to acknowledge the tireless effort of the organizing committee, faculty members, and volunteers whose dedication and meticulous planning have made this conference possible. To our postgraduate students and young surgeons, I encourage you to actively participate, question, and engage. Conferences like these are not merely platforms for learning, but opportunities to cultivate curiosity, refine clinical judgment, and build professional network. As we commence this academic journey, I am confident that the deliberations over the next few sessions will be intellectually stimulating and clinically relevant. Once again, I extend my warmest welcome to all of you and wish you a productive, enriching, and memorable conference. Thank you very much.
Thank you, sir, for such great words. Now, I request Dr. M.K. Mittal, sir, Principal, Subharti Medical College, for the words of his blessings.
Jai Hind, Honorable Vice Chancellor Sir, distinguished faculty members, distinguished speakers, guests, students, and participating delegates. It gives me immense pleasure to welcome you all to this CLE on behalf of the Medical College. Friends, the CMEs are an essential part of the academic activities, and they really help especially the young faculty, students, and practitioners to enhance them with the newer ideas. I will compliment Dr. Maheshwari sir, Dr. Sanjay Pandey, and their team for organizing such an excellent conference. And I hope the delegates will interact with the speakers and will enhance their knowledge. Thank you.
Thank you, sir. Now, I request our SMS, Dr. H.S. Minhas, sir, for his blessings.
Jai Hind to everyone. respected VC sir, principal sir, delegates, Dr. Maheshwari and his team. Surgery, as we all know, has changed a lot ever since we were students during mid-70s. Since then, we have seen many advances in surgery, and aptly every year our department is organizing this update on the recent advances as the current CME being hosted today. Now, requirement of surgery these days basically is more precision, more accuracy, early recovery, integration of all the latest developments in, say, artificial intelligence and other things which have popped up, advances of the engineering and electronics to be integrated with the skill of surgery. These are the current challenges. And as I was going through the list of topics today, all these things are being addressed very nicely through the excellent galaxy of speakers. I wish the department all the success, and I'm very hopeful that the delegates will get benefited profusely out of this conference. Thank you and all the best.
Now, for the blessings of VC sir, I request Dr. Sharma sir, PK Sharma sir, to come on the stage.
Honorable Dr. Nikhil sir, Principal Subharti Medical College, Honorable Dr. Maheshwari ji, Dr. Pandey ji, all the eminent speakers, our very senior colleague, SMS Dr. Menaz sir, and galaxy of intellectuals and the students. Today I was very happy when I came over here. It is always my dream being a scientist. When I found one of the scientists was defending, another was asking the question, and the session was very interesting. Unfortunately, why it is not becoming is because we are making it every day. The deliberations are only one-sided. It should never be one-sided. When we get registered for any of the conference or for any CME or any workshop, we must be ready with our questionnaire. We must be ready with our thought process. Yes, I am doing this practice. What is wrong and what I learned from these eminent speakers which are available over here. Friends, you all are very learned colleagues. I am like a newborn baby before you because it is your field. You know much better than this. But do you think that when mobile came, everybody was scared? When it was to make the digital payment, everybody has refused that nobody will be able to pay that. And today, if you were any part of the country, and even if you go to the rickshaw puller and you just pay the fare of 10 rupees, he is ready to take it on Paytm or Google Pay. That time it was not like this. Artificial intelligence, yes, it is part of technology, but it is related with human being. Until unless there is no emotional intelligence, how you take the decision? It is a machine. This is a laptop or a computer science. I will put up a program. The program will start running it. So until unless I will not apply my brain, I will not be able to stop it. Where to take the decision? There it is the very real role of the human intelligence. So I welcome every one of you. My only request is to the Dr. Maheshwari ji also and to Dr. Pandey ji, very special request. I want to need to say this, that there should be interactive sessions. The budding surgeons who are sitting over here, they have came with a drill I just need it. Like morning it was happening. It should be. They should be. You should do the deliberations. I think most of the seniors will agree with me. Now in the international conferences, which you may need, the international means international. There is a session of only 15-20 minutes. You have to speak only for 15-20 minutes, nothing more than that. And there is a session of discussion for 1 hour. There is a complete deliberations. Until we will not discuss with them, how do they understand? It becomes a formality. Oh, I am going for the surgery conference, I'll get this. I don't know whether you will accept it or not. Being my position, please forgive me. Years back, I think 25 years back, one of the vice chancellor came to our university and he has seen our work and he asked, Dr. Sharma, please come with me and we'll be arranging the workshop for National Board of Accreditation, NBA. For the institutions are there. I went in with him and he was from America, University of Arkansas. He was there. He came over here in India and he joined as a vice chancellor. The conference started at 9 o'clock, the workshop. He has given the name workshop. It was started at 9 o'clock. We are sharp at 9 o'clock. The lunch time was 1 to 1:30. Exact at 1, the workshop was closed. At 1:30, none of the members were there. Only that vice chancellor was there in the hall at 1:30 sharp. Again, the session goes on. At 5 o'clock, it was closed. We were sitting ideal over there. And that vice chancellor directly asked me, so Dr. Sharma, tell me what is the takeaway from today's workshop? Very honestly, I'm accepting this. I was not able to understand what is the meaning of takeaway. And I was blank for 60 seconds. Then he understand that he is not able to answer. Then he told me, oh yeah, today we learn how should we apply for NBA, how should we prepare for NBA. Now, for a teacher, we need only a spark. Then we can answer everything. Earlier to that, what was my takeaway was a kit, a bag, a lunch, a interaction, a session with that. Friends, we are very fortunate, very, very fortunate that so much learned, eminent people are available here to guide us, to suggest us. Otherwise, nowadays, it is very difficult. People are not ready to come physically, and because you are the surgeons, you know how costly is your time. It is not only for the money, it is only for your talent also. And you are the lifesavers. How many are waiting in the queue for your wait? Let my surgeon will come, my surgery will be over. So how precious time they had invested to come over here, to spare, to interact with us. I very humbly urge every one of you, kindly interact with them, try to learn with them what is latest is going on and how it was the conventional earlier, the things are there. When robotic surgery came, I remember I was also part of that. Everybody was scared and doctors have told, doctors have told, sir, no job will be there. Everything will be done by robot. We will be jobless. Any person can, any engineer can start, they can do the programming of this, they will find out, they will put the CT and scan and all the things are there. But what has happened? Tell me how many robotic surgeons are there now in India? How many has adopted that? Again, that need a very, very skilled, expertised surgeon to run that robot also, to get the 100% results. So it is always there. Human cannot be replaced. Whatever the form of computer you use, whatever the technology you use, certainly human being is required to run that technology. With these words, I am thankful to all the organizing committee members. Subharti University welcomes and feel thankful to all the eminent speakers who are here for coming over here to guiding our students. All my learned colleagues who are from Subharti University and Subharti Medical College, that they are here for their contribution. Once again, thank you. Thanks a lot.
Now, I request on behalf of organizing committee, Dr. M.K. Maheshwari sir, to give a token of gratitude to Dr. P.K. Sharma sir.
I'm a home person. No.
It's just
आपकी मेरे बेटा मेरे अपने घर में क्या वेलकम कर मुझे कराया I'm sorry. I really feel right.
I request Sanjay Pandey sir to give a token of gratitude to M.K. Mittal sir. I request Dr. Sandeep Kansal sir to give a token of gratitude to Dr. H.S. Minhas sir. The organizing committee, Subharti Surgery Update 2026, welcomes you all again and will request you to now proceed for breakfast, and after that we'll continue with our sessions forward. Thank you. and HOD of General Surgery at Subharti, Dr. Sanjay Pandey sir says, if it isn't written down, it didn't happen. In the eyes of law and standard of safety, undocumented is undone.
To reduce this fear and brush up our documentation skills, we invite Dr. Rishi Bhatia sir, a senior medical legal expert and medical legal advisor, IMA, UP and UPNHA, to deliver a session on record keeping in surgery. He has been ex-national president of Indian Medical Legal and Ethics Association. Sir.
To chair this session, I invite the chairpersons, Dr. Shanti Swarup sir, pioneer in the field of surgery, Dr. Rudramani sir, Professor General Surgery, RML Lucknow, Dr. Anuj Sharma sir, Professor General Surgery at NCR Medical College, Dr. Sandeep Malyan sir, a renowned surgeon and a pioneer in the field of surgery,
I am highly obliged and thankful to the organization and Subharti Medical College for giving me opportunity to talk about medical legal problems, medical legal record keeping in surgical practice. Any case in the court, whether civil, criminal, consumer, the case revolves around the evidence. And the evidence can be prescription, case sheet, consent, and medical literature. Whatever I am detailing is from the various judgments of the court. The points I have taken from those judgments which have been decided by Supreme Court or National Commission. As an evidence, every medical record from prescription to medical literature is very important, and only that document is relied in the court. So I will elaborate, besides the record keeping in surgical practice, other issues which are very important to deal various court cases or complaint in medical council or CM office or any other authority. Albert Einstein has rightly said, intellectuals solve problems and geniuses prevent them. So don't try to be intellectual, try to be genius. Documentation is the most deficient area of the doctors and medical practice. हम मरीजों से बातें तो ज़्यादा करते हैं, लेकिन लिखते नहीं हैं. जब किसी फोरम पर, कोर्ट में या कहीं कंप्लेंट होती है, तो हम अगर मरीज से कन्फ्रंटेशन होता है तो वहाँ या कोर्ट में, अरे तुम्हें बताया तो था, उस समय हमारे पास कोई एविडेंस नहीं होता कि हमने वाकई बताया था, इसलिए हम बोलते ज़्यादा हैं, लिखते कम हैं. रिकॉर्ड कीपिंग इज आवर बेस्ट डिफेंस. लीगली व्हाट इज नॉट डॉक्यूमेंटेड नेवर हैपेंड. अगर आपने इलाज में कुछ किया है और लिखा नहीं है तो समझा जाएगा कि आपने वो नहीं किया. और अगर आपने लिख दिया है, गलती से कोई इंजेक्शन देना भूल गए हैं लाइफ थ्रेटनिंग पोजीशन में, और आपने डॉक्यूमेंट बाद में केस शीट में कर लिया, तो माना जाएगा कि आपने वो किया. सो व्हाट इज नॉट डॉक्यूमेंटेड नेवर हैपेंड. जैसा कि अभी होटलों में होता है, आधार कार्ड ले लिया जाता है, लेकिन अभी हमारे यहाँ मरीजों से आधार कार्ड ज़्यादातर नहीं लिया जाता. तो आइडेंटिटी वेरीफाई करनी चाहिए, वरना लिखना चाहिए आइडेंटिटी नॉट वेरीफाइड. ज़्यादातर लोग एक्सरे रिपोर्ट में, अल्ट्रासाउंड में या किसी और रिपोर्ट में लिख देते हैं नॉट फॉर मेडिकल लीगल पर्पज। ये अनलॉफुल है, इसकी कोई लीगल वैलिडिटी नहीं है। हमेशा जो भी प्रेस्क्रिप्शन आप मरीज को दें उसकी डुप्लीकेट कॉपी अपने पास या कंप्यूटर में रखें, और हमेशा प्रेस्क्रिप्शन के ऊपर पिछली हिस्ट्री, प्रेजेंट हिस्ट्री, क्लिनिकल एग्जामिनेशन नोट्स जरूर लिखें, सीधे सीधे दवाई ना लिखें। और कोई इन्वेस्टिगेशन रिक्वायर्ड है तो वो भी लिखें, कोई पिछला रिकॉर्ड है तो वो जरूर लिखें। अगर मरीज एक हफ्ते बाद बुलाने के बाद में 15 दिन बाद आता है या ये हिस्ट्री देता है कि मैंने दवाई 5 दिन में बंद कर दी थी, तो जरूर लिखें पुअर कंप्लायंस और डिफॉल्टर इन ट्रीटमेंट। अगर प्रिस्क्रिप्शन के पन्ने भरते चले जाते हैं और मरीज 10-15 बार आता है और 10-15 पन्ने हो जाते हैं, तो हर पन्ने के ऊपर लिखिए कंटिन्यू टू डेट दिस एंड दिस, और अगले पन्ने पर लिखें कंटिन्यू फ्रॉम डेट दिस एंड दिस, जिससे अगर कहीं कंप्लेंट होती है तो आपके मतलब का पन्ना मरीज निकाल ना सके। अदरवाइज मरीज बहुत चालाक हैं, वकील से मिलकर उन पन्नों को हटा लेते हैं जो आपके मतलब के होते हैं और बाकी पन्नों को लगा देते हैं। और हमेशा लिखिए इमरजेंसी होने पर तुरंत संपर्क करें। कहीं भी आप सिग्नेचर करें, चाहे प्रेस्क्रिप्शन हो, डिस्चार्ज कार्ड हो, इंजरी रिपोर्ट हो, कोई सर्टिफिकेट हो, वहाँ पर एनएमसी रजिस्ट्रेशन लिखें, अपने साइन करें और नाम भी ज़रूर लिखें। कोई भी मेडिकल सर्टिफिकेट दें उसकी डुप्लीकेट कॉपी रखें और वो परफॉर्मा मेडिकल काउंसिल ऑफ इंडिया एनएमसी ने दिया हुआ है उस पर बनाएं और उस पर मरीज के थंब इम्प्रेशन ज़रूर लें, उस पर मार्क ऑफ आइडेंटिफिकेशन और एड्रेस लिखें। कभी भी एडवांस में मेडिकल सर्टिफिकेट ना दें। मेरे पास आते हैं केसेस, क्लेम की फाइलें आती हैं, उनमें देखा तो मरीज आज है और मेडिकल सर्टिफिकेट 4 दिन बाद का दे देते हैं। इसलिए मेडिकल सर्टिफिकेट कभी भी एडवांस ना दें। बैक डेट का तब दें अगर आपने उस मरीज को देखा है, अगर उसका प्रेस्क्रिप्शन मरीज के पास है। ऐसे ही फिटनेस एडवांस में नहीं दी जाती, फिटनेस उसी डेट में दी जाती है। जिस सब्जेक्ट में आप क्वालिफाइड हैं और एनएमसी या एमसीआई में रजिस्टर्ड हैं, आप उसी में प्रैक्टिस कर सकते हैं। अगर आपने एमएस सर्जरी के बाद में एमसीआई में रजिस्ट्रेशन नहीं कराया है तो आप एमसीआई की नज़रों में और बाद में कोर्ट की नज़रों में आप पोस्ट ग्रेजुएट नहीं हैं। तो इसलिए अपना रजिस्ट्रेशन एमबीबीएस के बाद एंडोर्स कराएं एनएमसी में। जो विदेशों से पढ़ के आते हैं और एमडी लिख लेते हैं वो कंसल्टेंट नहीं हो सकते, वो स्पेशलिस्ट नहीं हो सकते। क्रॉस स्पेशलिटी ज़्यादातर देखा गया है कि सर्जन लोग हिस्टेक्टमी भी कर देते हैं, सीजर भी कर देते हैं। दे आर नॉट एंटाइटल्ड, क्योंकि हमारे कोर्स करिकुलम में वो नहीं है। कभी भी करने की नौबत आए तो केस इंचार्ज एक गायनेकोलॉजिस्ट को बनाइए, तब आप एज एन असिस्टेंट कर सकते हैं, लेकिन इंडिपेंडेंट आप उस केस में नहीं कर सकते। ऐसे ही ऑर्थोपेडिशियन हेड इंजरी ट्रीट करते देखे गए हैं, वो नहीं हो सकता। अपनी ही स्पेशलिटी का अगर मरीज नहीं है तो उसको कंसर्न स्पेशलिटी को रेफर कर दें। कोई भी व्यक्ति अगर आपको असिस्ट कर रहा है या आपके केस में इन्वॉल्व है तो देख लीजिए कि उसके पास जो डिग्री और एक्सपीरियंस है वो रिकॉग्नाइज्ड और क्वालिफाइड है या नहीं। रूबी हॉल क्लिनिक में एक एनेस्थेटिस्ट महोदय जो 2.5 साल तक आरएमओ एनेस्थीसिया का काम कर रहे थे, वो क्वालिफाइड नहीं थे। उनको एनेस्थेटिस्ट की तरह से केस कराया तो कोर्ट ने 10 लाख की पेनल्टी की। इसी तरह फोर्टिस हॉस्पिटल में भी अनक्वालिफाइड आदमी को एज ए नियम नोटिस रखा गया। तो आप देख लीजिए कि आपको जो एनेस्थेटिस्ट केस कराने आ रहा है वो क्वालिफाइड है एनेस्थीसिया में या नहीं। कोई लाइफ थ्रेटनिंग कंडीशन में आप मना नहीं कर सकते, ना आपको उसके लिए कंसेंट की जरूरत है और ना आपको कोई पेमेंट मांगना है टिल स्टेबलाइजेशन। इसी तरह से ये कहना कि वैकेंट बेड नहीं है, न्यूरोसर्जरी यूनिट नहीं है, आपको मरीज को अटेंड करना है, स्टेबलाइज करना है, फर्स्ट एड देनी है। स्टेबलाइज करने के बाद अगर उसको आपके यहाँ फैसिलिटी नहीं है और कहीं रेफर या शिफ्ट करना है तो सेफ प्लेस तक उसको ट्रांसपोर्ट करना भी आपकी जिम्मेदारी है। सिर्फ एम्बुलेंस में लाद के भेज देना क्राइम है। उसके साथ चाहे आप क्वालिफाइड एक आरएमओ भेजें और चाहे आप खुद जाएं, सेफ प्लेस तक पहुंचाना आपकी जिम्मेदारी है। क्लिनिकल एसेसमेंट एक्ट जो आया है उसमें भी यही रिक्वायरमेंट है। जब कभी भी मरीज भर्ती होता है तो ये जरूर चेक कर ले कि एडमिशन रजिस्टर पे जो एडमिशन का डेट और टाइम है वही केस शीट के ऊपर एडमिशन और डेट टाइम हो। डॉक्टर के देखने का समय डिफरेंट हो सकता है, लेकिन एडमिशन की डेट और टाइम एडमिशन रजिस्टर से मैच करेगी। हो सकता है एडमिशन सुबह 10:30 बजे हुआ हो तो 10:30 का टाइम डाले, डॉक्टर ने 12 बजे देखा हो तो डॉक्टर अपना टाइम 12 बजे का ही डालेगा। और एडमिशन रजिस्टर पे पेशेंट और अटेंडेंट के साइन जरूर लें, क्योंकि कभी कोई प्रॉब्लम होती है तो आपको पता होना चाहिए कि मरीज को किसने भर्ती कराया। भर्ती कराते समय एक जनरल कंसेंट लें जिसमें सब चीज़ें बतानी है कि इस अस्पताल में ये फैसिलिटीज़ हैं और ये नहीं हैं, इस हॉस्पिटल के ये रूल रेगुलेशन हैं, इस फैसिलिटी के ये चार्जेस हैं, और मरीज को ड्रिप इंजेक्शन दिए जा सकते हैं, इन्वेस्टिगेशन भेजी जा सकती हैं, दूसरे डॉक्टर को इमरजेंसी में बुलाया जा सकता है। कभी भी किसी डॉक्टर को आपको बुलाना है ट्रीटिंग डॉक्टर के अलावा तो आप मरीज की कंसेंट से बुलाएंगे। अगर आपने एडवांस में जनरल कंसेंट ली है कि इमरजेंसी में किसी डॉक्टर को बुला सकते हैं तो उस समय आपको अटेंडेंट से कंसल्ट लेने की जरूरत नहीं पड़ेगी। अक्सर देखने में आता है जब ब्लड की जरूरत होती है तो हमें नहीं पता जी आप ही अरेंज कराएं, तो एडमिट होते समय ही मरीज से कंसल्ट ले लें कि ब्लड अरेंज करने की जिम्मेदारी मरीज की होगी। और कई बार ऐसा होता है कि मरीज ऊपर से गिर गया या उसकी ज्वेलरी खो गई, तो हमेशा कंसेंट पे लिखवाइए कि सिर्फ ट्रीटमेंट की जिम्मेदारी अस्पताल की है, मरीज की सेफ्टी की जिम्मेदारी अस्पताल की नहीं है और वैल्यूएबल्स की जिम्मेदारी नहीं है। जनरल कंसेंट में एक चीज जरूर लिखवाएं कि मुझे बता दिया गया है कि मेडिकल प्रोटेक्शन एक्ट लागू है, अगर कोई हिंसा या कुछ मैं करता हूं तो उसके अंतर्गत मुझ पर कार्रवाई होगी। दिस विल एक्ट एज ए डेटरेंट। मरीज के दिमाग में भय होगा कि मैंने साइन किए हुए हैं और मैंने कुछ गलत काम किया तो मुझ पर कार्रवाई कानून के तहत हो जाएगी। केस शीट में हमेशा चीफ कंप्लेंट्स लिखें, हो सके तो मरीज से लिखवाएं। एक केस में मरीज एडमिट हुआ क्रॉनिक अपेंडिसाइटिस से, ऑपरेट हो गया, बाद में उसने कहा मुझे तो राइट यूरेटिक स्टोन था, आपने गलत ऑपरेट कर दिया। तो इसलिए डॉक्यूमेंट में चीफ कंप्लेंट अगर हो सके तो मरीज की राइटिंग में लिखवाएं। जो मरीज ने अभी रिसेंट मेडिकेशन लिया है या कोई प्रोसीजर करवा के आया है तो उसको भी लिखित रूप में मरीज से लें। मरीज की प्रेजेंट और पास्ट हिस्ट्री का कोई भी डॉक्यूमेंट इन्वेस्टिगेशन का, ट्रीटमेंट का, उसे केस शीट का पार्ट बनाएं। अगर उसके पास पिछला कोई रिकॉर्ड अवेलेबल नहीं है और हिस्ट्री दे रहा है तो मरीज से लिखवा ले कि मेरे पास पिछला कोई रिकॉर्ड नहीं है। एक डायबिटिक फुट एडमिट हुआ, बाद में उसका एम्पुटेशन करना पड़ गया, लिखित रूप में कहीं नहीं था कि पहले से ही उसको डायबिटिक फुट या डायबिटीज थी, उसने एलिगेशन लगा दिया कि अस्पताल में आने के बाद मेरा केस बिगड़ा और मेरा पैर काटना पड़ा। हर बार विजिट में सुबह शाम कभी भी आप वार्ड में जाएं, केस शीट के ऊपर उस समय की एग्जामिनेशन फाइंडिंग लिखें, और अगर आपने पहले कोई इन्वेस्टिगेशन भेजी है, उसकी रिपोर्ट देखी है तो देखना मात्र पर्याप्त नहीं है, उसको आप टाइम डालकर लिखें, वरना माना जाएगा कि आपने बिना इन्वेस्टिगेशन रिपोर्ट देखे मरीज का ट्रीटमेंट आगे बढ़ा दिया। इसी तरह से ये ज़रूर चेक करें कि ड्रग डोजेज वाइटल चार्टिंग जो आपने लिखी है वो ही स्टाफ ने लिखी है। यूजुअली क्या होता है कि सिस्टर एडमिट होते ही 6 बजे, 2 बजे, 10 बजे का टाइम शेड्यूल डाल देता है। कोई मरीज शाम 4 बजे एडमिट हुआ, उसमें भी दोपहर 2 बजे का टिक करके इंजेक्शन लगा देगी। कोर्ट ने कहा जब मरीज एडमिट ही 4 बजे हुआ, ये 2 बजे कैसे लग गया इंजेक्शन? तो इसलिए ये आप पहली बार जो चार्टिंग होती है उसको चेक करें कि जो आपने लिखी है वही चार्टिंग हुई है। कोई भी आप टेलीफोन पे एडवाइस देते हैं, उसके बाद वार्ड में शाम को या सुबह राउंड लेने जाते हैं तो वह साइन जरूर करें, और वार्ड में मरीज के पास राउंड लेने के बाद 2 मिनट जरूर दें कि आपको कोई बात अपने इलाज के बारे में पूछनी हो तो पूछें। ऐसे ही सिस्टर से पूछें कि जो मैंने ट्रीटमेंट लिखा है वो आपको पढ़ के समझ आ रहा है या कुछ पूछना है। अदरवाइज जल्दबाजी में IM इंजेक्शन IV लग जाता है, तो वो प्रॉब्लम हो जाती है। डॉक्टर एस.एम. कांतिकर हालांकि ENT सर्जन हुए हैं और नेशनल कमीशन में मेंबर हुए हैं, 2-3 जजमेंट उन्होंने दिए हैं, बड़े इंपॉर्टेंट जजमेंट दिए हैं। मरीज का ऑपरेशन कर दिया गया, ना तो एनेस्थीसिया वाले से फिटनेस ली गई, ना एनेस्थीसिया के नोट्स रिकॉर्ड था। चूंकि ऑर्थोपेडिशन केस का इंचार्ज था तो इसने पेनल्टी ऑर्थोपेडिशन पे भी लगाई गई। बाद में एनेस्थेटिस्ट भरी दौरान केस एक्सपायर हो गया, लेकिन अब जो रिसेंट नए कंज्यूमर फोरम और कंज्यूमर का एक्ट आया है, उसके हिसाब से अगर डॉक्टर की डेथ हो जाती है तो उसके परिवारजनों को पार्टी बना के उनसे कंपनसेशन लिया जाएगा। ये एक नया क्लॉज आ गया है। इसलिए जब कभी भी केस हो, हमेशा इंडेमनिटी इंश्योरेंस वाले को पार्टी बनाएं, जिससे आगे का खामियाजा भी वही भुगतेगा। इसी तरह से एक केस न्यूमोनिया का था, 2.5 साल का बच्चा था, रिकॉर्ड के अंदर चलता रहा वही जो सिस्टर लिखती हैं। मरीज 2 बजे के लिए एक्सरे में गया और सिस्टर ने 2 ही बजे के वाइटर डाले हुए थे और मरीज 6 बजे एक्सरे करा के आया, उस दौरान भी वाइटर डले रहे। तो कोर्ट ने ये कहा कि जब मरीज 2 बजे एक्सरे के लिए गया था तो 2 बजे से 4 बजे के बीच के वाइटल क्यों डले हुए जब मरीज था ही नहीं वहां। तो इस तरह की छोटी छोटी मिस्टेक्स कोर्ट पर करती है। स्टैंडर्ड प्रोटोकॉल केस शीट की स्टेशनरी का यूज करें, ना कि एक सादा सा पन्ना लेके उसमें आप कर लें। और टाइम और डेट एडमिशन की मैचिंग हो, जो मैं पहले ही बता चुका हूँ। केस शीट पूरी होनी चाहिए, मेंटेन्ड होनी चाहिए। उसमें कोई कमी पाई जाती है वो भी डिफिशियंसी ऑफ सर्विसेज है। कभी भी कोई ब्लैंक स्पेस ना छोड़े। डॉक्टर के नोट्स, टेलीफोनिक कंसल्टेशन सब कुछ लिखें। वाइटर ड्रग डोजेज चार्टिंग उसके अंदर हो, उसके अंदर इन्वेस्टिगेशन हो, मरीज का पुराना रिकॉर्ड केस शीट का पार्ट बने। जब कभी भी आप कोई प्रॉपर्टी खरीदते हैं तो उसके पिछले 12 साल के जितने ओरिजिनल बेनामे होते हैं आप जमा करते हैं, वो आपके पास रहते हैं। ऐसे ही पुराना जितना भी रिकॉर्ड मरीज का हो उसे जमा कराएं और वो केस शीट का हिस्सा बनेंगे, वो मरीज के पास नहीं छोड़ेंगे। कभी भी केस शीट की डिमांड आए किसी डॉक्टर के द्वारा, उसको दें। पेशेंट मांगे तो इन राइटिंग ले, उसके बाद उसको दें। कोई अथॉरिटी है तो इन राइटिंग लीजिए, पुलिस मांगती है तो इन राइटिंग लीजिए, कोर्ट से भी इन राइटिंग आएगा। दूसरे नर्सिंग होम को कई बार जरूरत पड़ जाती है, अगर मरीज आपके यहाँ से दूसरी जगह रेफर हुआ है तो आपने जो इलाज 2-3 दिन दिया वो अगर दूसरा नर्सिंग होम मांगता है तो एथिकली आपको देना चाहिए। दूसरे कंसल्टेंट को बुलाना मरीज की चॉइस पर होता है, और अगर एडवांस में जनरल कंसेंट में आप लिखवा लेंगे तो फिर आप अपनी चॉइस से बुला सकते हैं। कभी भी बाहर जाएं तो आपने गॉल ब्लैडर किया और आप MBBS के भरोसे छोड़ के चले गए, ऐसा नहीं होगा। जिस स्पेशलिटी का मरीज है उस स्पेशलिटी के क्वालिफाइड पर्सन को ही आप बाहर जाते हैं तो हैंड ओवर करके जाएंगे, मरीज को बता के जाएंगे, और पॉसिबल हो तो इन राइटिंग मरीज की कंसेंट लेके जाएंगे कि मैं बाहर जा रहा हूं और मेरी जगह ये देखेंगे। कंसेंट 18 साल से ऊपर का इंडिपेंडेंट व्यक्ति दे सकता है। 12 से 18 साल में मरीज और पेरेंट दे सकते हैं, 12 साल में सिर्फ पेरेंट दे सकते हैं, और वो मेंटली साउंड होना चाहिए। It should be informed and must be specific. कंसेंट रिटन लैंग्वेज में हो, रीजनल लैंग्वेज में। ज्यादातर देखा जाता है कि सब इंग्लिश में चलता है, मरीज को पढ़ना नहीं आता हिंदी भी, और कंसेंट इंग्लिश में हो रही है, तो इसलिए रीजनल लैंग्वेज में होनी चाहिए, और जिस लैंग्वेज में हो मरीज को समझ में आनी चाहिए। अगर कोई बाहर का तमिल या कोई और लैंग्वेज का मरीज आ जाता है तो आप कन्वर्टर को एविडेंस के तौर पर विटनेस बनाइए और उसको फिर लिखिए कि उसकी समझने योग्य भाषा में उसको बता दिया गया है। इसमें मेडिकल टर्म्स का इस्तेमाल ना करें। इसमें यह ना लिखें कि कोलेसिस्टेक्टमी ना, गॉल ब्लैडर विद स्टोन रिमूवल, लेमन लैंग्वेज का इस्तेमाल करें। और मरीज के खुद के द्वारा ये कंसेंट होनी चाहिए। ज्यादातर हम मरीज के रिश्तेदारों से ले लेते हैं कि उसके भाई से ले ली, उसकी वाइफ से ले ली, वो गलत है। और मरीज की राइटिंग में हो तो ज्यादा अच्छा है, और पेशेंट के साइन हो और विटनेस के साइन हो। काउंटर साइन डॉक्टर, हॉस्पिटल एडमिनिस्ट्रेटर, इनके भी हों। कंसेंट इज ए कॉन्ट्रैक्ट, कॉन्ट्रैक्ट बिटवीन पेशेंट, डॉक्टर एंड हॉस्पिटल, इसलिए तीनों के साइन हो और 2 विटनेस के साइन हो। और विदेशों में तो कंसेंट की एक कॉपी मरीज को दे दी जाती है जिससे वो पढ़ सके, ये ना कहे कि मुझे नहीं पता क्या साइन करा लिए, और उसकी रिसीविंग लीजिए। कंसेंट की कॉपी मरीज को देने से आप सेफ हो जाते हैं। स्पेसिफिक प्रोसीजर की स्पेसिफिक कंसेंट है। अगर गॉल ब्लैडर निकालना है तो उसकी कंसेंट अलग है, हिस्टेक्टमी करनी है उसकी कंसेंट अलग है, अपेंडिक्स करनी है उसकी कंसेंट अलग है, एंड इट शुड बी इन्फॉर्म्ड। मैं बताऊंगा इन्फॉर्म कंसेंट क्या होती है। इन्फॉर्म कंसेंट एक सिंपली पेपर नहीं है। इन्फॉर्म कंसेंट का मतलब है जब मरीज आता है और आप मरीज को एक्सप्लेन करते हो आपको ये बीमारी है, इसके ये ऑप्शन है ट्रीटमेंट के, इस ऑप्शन को मैं अडॉप्ट करूंगा, बाकी ऑप्शन इससे बेटर ये भी हो सकते हैं। ये सारी चीजें जो होती हैं ये लिखित रूप में जब होती हैं उसको इन्फॉर्म कंसेंट कहते हैं। उसमें बताया जाता है कि आपकी आज की स्थिति क्या है, आपकी डायग्नोसिस क्या है, प्रपोज इन्वेस्टिगेशन और उसके रिस्क क्या है, और करंट लेवल ऑफ सीवियरिटी मरीज की क्या है, और डिफरेंट ऑप्शन ट्रीटमेंट के उनके रिस्क क्या है, उनके सक्सेस और फेलियर ऑप्शन क्या है, प्रपोज ट्रीटमेंट और उसके रिस्क क्या है, कोई बेटर ऑप्शन है तो वो भी आप बताएंगे। अगर आप प्रोस्टेट करने जा रहे हैं, आप टीआरपी नहीं करते हैं तो आप बताएंगे कि मैं तो ओपन करूंगा, टीआरपी भी होती है, उससे छुपाएंगे नहीं कि और ट्रीटमेंट आपके पास नहीं है तो आप बताएं नहीं। और ट्रीटमेंट अगर आप मरीज को बताएंगे कि अडॉप्ट करता है तो उसकी प्रोग्नोसिस क्या होगी, और अडॉप्ट नहीं करता तो उसकी प्रोग्नोसिस क्या होगी, ये सारी चीजें एक इन्फॉर्म कंसेंट का पार्ट है। इन्फॉर्म कंसेंट 2 तरीके की है, एक तो यूएसए में फॉलो किया जाता है, एक यूके में किया जाता है। यूएसए में ये माना जाता है कि मरीज पढ़ा लिखा है, मरीज पढ़ा लिखा है तो उसको अधिकार है कि मेरे शरीर में क्या होने वाला है, मैं अपने शरीर के लिए कौन सा ट्रीटमेंट अडॉप्ट करूंगा, ये फैसला करने का अधिकार होता है। और आप मरीज को सारी चीजें बताएंगे, एवरी इंफॉर्मेशन, चाहे वो ज़्यादा कॉम्प्लिकेशन वाली परसेंटेज है या कम वाली परसेंटेज है, और कंप्लीट और करेक्ट इंफॉर्मेशन देंगे, कोई फैक्ट नहीं छुपाएंगे। वो इन्फॉर्म कंसेंट यूएसए ट्रेंड है। यूके ट्रेंड क्या है? यूके ट्रेंड है कि आप रिमोट रिस्क ही बताएंगे, रिमोट रिस्क ही बताएंगे, जो 10% वाले हैं वो नहीं बताएंगे। ये मानेंगे जैसे कि इंडियन सेटअप में है कि मरीज ज़्यादा पढ़ा लिखा नहीं है, सिर्फ सेलेक्टिव इंफॉर्मेशन देंगे, उसकी मरीज की मेंटल और फिजिकल कंडीशन को ध्यान में रखते हुए देंगे, और जो प्रिवेलिंग प्रैक्टिस है मेडिकल की आपके शहर में आप उसको ध्यान में रखते हुए उसको बताएंगे और फिर कंसेंट लेंगे। एक केस समीरा कोहली वर्सेस प्रभा वनचंदा बहुत मशहूर केस हुआ, उसके अंदर डायग्नोस्टिक लेप्रोस्कोपी की कंसेंट ली गई, लेकिन कंसेंट तो डायग्नोस्टिक लेप्रोस्कोपी की थी, प्रोसीजर करने की नहीं थी कोई, सिर्फ डायग्नोस्टिक की थी। जब डायग्नोस्टिक लेप्रोस्कोपी में पाया गया कि मरीज को एंडोमेट्रियोसिस है तो उन्होंने ड्यूरिंग प्रोसीजर ही उसकी मदर इन लॉ से कंसेंट लेके हिस्टेक्टमी कर दी, जबकि उसके अंदर प्रोसीजर करने की कंसेंट नहीं थी। बाद में वो कोर्ट में केस गया और कोर्ट ने गलती पाई। तो इसलिए कंसेंट जो होती है उतने ही काम के लिए होती है जितना आपको करना है। अगर आपको एक्स्ट्रा काम करना है तो उसका भी तरीका है। मरीज अगर कंसेंट देने के बाद भी मना कर देता है, अगर ओटी टेबल पे लेट के मना करता है तो आपको ओटी टेबल से बाहर करना पड़ेगा, और किसी भी समय भी वो अपनी विड्रॉ कर सकता है। मरीज ने कंसेंट देने से मना किया, इसको प्रूव करने का जिम्मेदारी डॉक्टर की है, तो इसलिए हमेशा अगर रिफ्यूज करता है तो लिखवाएं, अगर वो नहीं लिखता है तो अटेंडेंट से लिखवाएं, अगर वो दोनों नहीं लिखते हैं तो किसी और मरीज के अटेंडेंट को विटनेस बनाएं। हर बार कोई भी प्रोसीजर करना है तो नई कंसेंट दें। अगर आपने लेप्रोटमी की और बस्ट एब्डोमेन हो गया, आपको रिपेयर करना है तीसरे दिन 5वें दिन, तो दोबारा कंसेंट दें। ये नहीं कि पहली कंसेंट के ऊपर ही आपने दोनों काम कर दिए। कभी भी मरीज के वाइटल डिटेरिएट होते हैं पेशेंट के, तो नई कंसेंट लें। यूजुअली आईसीयू में रोजाना कंसेंट ली जानी चाहिए, क्योंकि मरीज बाद में कहता है मुझे मरीज के बारे में बताया नहीं गया, वरना मैं कहीं और ले जाता या किसी और डॉक्टर को बुला के लिखवा देता। इसलिए आईसीयू में डेली लिखवा लेना चाहिए कि मुझे मरीज की स्थिति के बारे में बता दिया गया है मुझे अस्पताल पे और डॉक्टर की टीम पर पूर्ण विश्वास है। कभी भी कंसेंट में डिले होती है उसको भी केस शीट में आप जरूर लिखिए। टाइम ऑफ कंसेंट इज वेरी इंपॉर्टेंट। अगर इलेक्टिव सर्जरी करनी है, गॉल ब्लैडर करना है, तो आज आपने कंसेंट ले ली और आप 2 दिन बाद भी सर्जरी करते हैं तो दिस इज मोर सेफ, क्योंकि आपने 2 दिन तक मरीज को सोचने का मौका दिया। लेकिन कोई इमरजेंसी सर्जरी है, आपको परफोरेशन करना है, सुबह 11 बजे कंसेंट ले ली और रात को 9 बजे ऑपरेट कर रहे हैं, तो आपके पार्ट पर ये डेफिशिएंसी मानी जाएगी अनटिल आप केस शीट में ये ना लिखें कि रात को आपने क्यों इतनी देर से सर्जरी की। उसमें कंसेंट तो हो चुकी थी सुबह, उसमें आप लिख सकते हैं कि ब्लड नहीं था या मरीज सेप्टिसीमिया में था या फिजिशियन ने क्लियरेंस नहीं दी, तो आपको कारण लिखना पड़ेगा। अनकॉन्शियस पेशेंट में कंसेंट की कोई ज़रूरत नहीं होती। अर्जेंट लाइफ सेविंग प्रोसीजर में भी कोई कंसेंट की जरूरत नहीं होती। पोस्टमार्टम में कभी कंसेंट की जरूरत नहीं होती। यूजुअली क्या करते हैं लोग, मरीज के अटेंडेंस से लिखवा लेते हैं हमें पोस्टमार्टम नहीं कराना और बॉडी दे देते हैं, बिल्कुल गलत है। पोस्टमार्टम में आपका काम है पुलिस मेमो भेजना और बॉडी को पुलिस को हैंड ओवर करना, उसके बाद वो पुलिस जाने और अटेंडेंट जाने, आप उसमें पार्ट मत बनिए। अदरवाइज बहुत सारे एलिगेशंस कोर्ट में लगाए जाते रहे हैं कि डॉक्टर साहब ने पैसे लेके मरीज को छोड़ दिया, उसके अंदर क्रिमिनल ऑफेंस बनता था। तो सेफ्टी इसी में है, पुलिस मेमो भेजें, बॉडी को पुलिस को हैंड ओवर करें और उन्हें डिसाइड कर लेने दीजिए। आप तो पोस्टमार्टम एडवाइस करके अलग हट जाइए। एक कोई यूनिफॉर्म कंसेंट का फॉर्मेट नहीं है। जनरल कंसेंट में आपको बता ही चुका हूँ कि उसमें क्या क्या लिखाना चाहिए। स्पेसिफिक कंसेंट बिल्कुल अलग होती है। आपको कोई स्पेसिफिक सर्जरी करनी है, लंबर पंक्चर करना है, उसके कंसेंट अलग होती है। ज़्यादातर लोग क्या करते हैं, खाली पन्ने पे साइन करा लेते हैं, वो बिल्कुल गलत है, वो भी एक क्राइम है। एक सुप्रीम नेशनल कमीशन ने एक केस डिसाइड किया था प्री प्रिंटेड कंसेंट, वो भी डॉक्टर कांतिकर ने ही तय किया था। उन्होंने कहा कि प्री प्रिंटेड फॉर्म जो है जिसमें ब्लैंक स्पेस दिए हुए हों और उसके अंदर आप प्रोसीजर का नाम भर लें और डॉक्टर का नाम भर लें, वो प्री प्रिंटेड कंसेंट इनवैलिड है, वो अनफेयर ट्रेड प्रैक्टिस है। ये केस हालांकि अब सुप्रीम कोर्ट में लंबित है। उसमें उनका ये कहना है कि हर सर्जरी के अलग कॉम्प्लिकेशन होते हैं, तो इसलिए आपको ये तो आप लिख सकते हैं कि बेहोशी की हालत में इनकी सर्जरी, फिर सर्जरी का डिस्क्रिप्शन और कॉम्प्लिकेशन, लेकिन ये नहीं हो सकता कि आप सिर्फ सर्जरी का नाम लिख दें और नीचे डॉक्टर का नाम लिख दें। तो इसलिए प्री प्रिंटेड कंसेंट हर केस की अगर स्पेसिफिक है तो वो वैलिड है, एक जनरल प्री प्रिंटेड कंसेंट वैलिड नहीं है। कंसेंट में एक चीज जरूर लिखें, सारी चीजें लिखने के बावजूद, कि मरीज की तरफ से कि मैंने सभी प्रश्न डॉक्टर साहब से इलाज से रिलेटेड पूछ लिए हैं और उनका जवाब मुझे मिल गया है, और जो कुछ भी ऊपर कंसेंट में लिखा गया है वो समझने योग्य भाषा में मैंने पढ़ लिया है, सुन लिया है, समझ लिया है। ये लास्ट लाइन होनी चाहिए। कभी भी ऑपरेट करते समय आपको कोई एडिशनल प्रोसीजर करना पड़े तो आप सिर्फ एक कंडीशन में उसे आगे बढ़ सकते हैं कि ये लाइफ थ्रेटनिंग था, टू सेव द लाइफ, टू प्रिजर्व द हेल्थ। इसलिए आप नहीं कर सकते कि मरीज के पैसे बचेंगे, इसलिए नहीं करेंगे कि मरीज का टाइम बचेगा या मरीज का दर्द कम हो जाएगा। अगर आपको कोई एडिशनल प्रोसीजर करना पड़ जाए तो इन एडवांस आप स्पेसिफिक कंसेंट जब लेते हैं मरीज के किसी प्रोसीजर के, तो उसमें ही 2 लाइन लिखवा लें कि प्रोसीजर के दौरान अगर कोई एक्स्ट्रा प्रोसीजर करना पड़ गया तो उसकी भी मैं कंसेंट देता हूँ। तब आप देन एंड देयर प्रोसीजर से अलग जो फाइंडिंग मिले उसे कर सकते हैं। इन्वेस्टिगेशन चाहे ब्लड रिपोर्ट हो या रेडियोलॉजी की हो, वो मरीज की चॉइस पर भेजें तो ज़्यादा अच्छा है। अदरवाइज कोई गलत रिपोर्ट आ जाएगी तो उसमें आपको भी पार्टी बना दिया जाएगा कि आपके सजेशन में गई। अगर रिपोर्ट मरीज तक नहीं पहुंचती है वो भी डिफिशिएंसी ऑफ सर्विसेज है, इसलिए मरीज की जिम्मेदारी है कि वही रिपोर्ट कलेक्ट करे और वही अपने हिसाब से पैथोलॉजी या रेडियोलॉजी में जाकर अपनी इन्वेस्टिगेशन कराए। अगर कोई टिश्यू या ऑर्गन बॉडी से रिमूव करते हैं तो हमेशा उसकी रिसीप्ट लें और एडवाइस हमेशा बायोप्सी करें। ज़्यादातर मरीज कहता है मुझे बायोप्सी नहीं करानी है, लेकिन आप इनवेरिएबली हर टिश्यू, हर ऑर्गन मरीज को रिसीव कराएं और लिखें बायोप्सी एडवाइस। उससे एक तो आपके पास सबूत आ जाएगा कि हमने तो बायोप्सी कराने की एडवाइस दी थी, क्योंकि कोर्ट में जब केस जाता है तो कहते हैं जी डॉक्टर साहब ने हमें बताया ही नहीं, और ना बायोप्सी करा लेते। दूसरा, कभी किडनी चोरी का केस भी लगता है तो आपके पास मरीज के पास किडनी की रिसीविंग भी है और उसकी बायोप्सी भी है। तो इसलिए हमेशा कभी भी टिश्यू बॉडी से निकालें तो मरीज को हैंडिंग ओवर करें और उसकी रसीद लें और उस पर लिखा हुआ, उसकी डुप्लीकेट कॉपी पर रिसीविंग लें, उस पर लिखा हो कि हमें टिश्यू प्राप्त हो गया और बायोप्सी की सलाह दी गई है। ब्लड ट्रांसफ्यूजन के लिए हमेशा 2 सैंपल लें। एक तो पैथोलॉजी लैब को जाए जो बताए कि ब्लड ग्रुप क्या है, HIV, HCV ये सब क्या है, और एक ब्लड बैंक हो जाए। ब्लड बैंक के ऊपर अगर O पॉजिटिव का बिल्ला लगा है तो आपको कैसे पता लगेगा कि मरीज का ब्लड ग्रुप O पॉजिटिव ही है, जब तक कि दूसरी पैथोलॉजी लैब से भी O पॉजिटिव की रिपोर्ट नहीं आएगी। तो इसलिए कंपैरिजन के लिए, मैचिंग के लिए, जिससे गलत ट्रांसफ्यूजन ना हो, एक सैंपल पैथोलॉजी में भेजें, एक ब्लड बैंक को ब्लड अरेंजमेंट के लिए भेजें। कई बार ऐसा होता है कि एन मौके पर, ये कोर्ट ने भी कहा कि डॉक्टर साहब ने ब्लड टेस्ट करके नहीं लगाया, और मरीज भी अर्ज कर देता है कि हमने तो ब्लड का इंतजाम नहीं किया, ना हमें सैंपल मिला। तो इसलिए कभी भी ब्लड का सैंपल ब्लड अरेंजमेंट के लिए दें तो मरीज को रिसीव कराएं कि मुझे ब्लड अरेंजमेंट के लिए ब्लड सैंपल दिया गया है। वो एविडेंस होगा कि मरीज खुद ब्लड अरेंज करके आया है, आपने अरेंज नहीं किया। दूसरा, ये भी लिखवाएं कि मैं ब्लड क्रॉस मैच और टेस्ट करा के उस ब्लड बैंक से लाया हूं। तो आपके ऊपर ये एलिगेशन नहीं लगेगा कि ब्लड टेस्ट करके ब्लड नहीं लगाया। एक कोर्ट में स्टेट कमीशन ने कहा कि डॉक्टर साहब ने ब्लड टेस्ट कर, जबकि जिम्मेदारी तो ब्लड बैंक की है उसे क्रॉस मैच करके देने की, फिर भी जज ने कहा। तो उसको सेव करने के लिए जरूरी है आप लिखवाएं मरीज से कि मैं उस ब्लड बैंक से अपने मरीज का ब्लड टेस्ट करवा के लाया हूं। हर यूनिट की इन्फॉर्म कंसेंट लें। एक बार कंसेंट लेके 3-4 ब्लड लगातार लगा देना गलत है। हर यूनिट की अलग से लें, उसका बैच नंबर सब कुछ नोट अलग चार्ट पे करें, उसकी चार्टिंग करें, और खाली बैग को प्रिजर्व जरूर करें जब तक मरीज की छुट्टी नहीं होती। अगर कोई ब्लड रिएक्शन है तो वो बैग ही आपको बचाएगा। अगर मरीज को जॉन्डिस हो गई, कुछ और है, तो वो बैग ही आपको बचाएगा। इसलिए वो उस बैग को प्रिजर्व करके रखें जब तक मरीज की छुट्टी नहीं होती। अगर सर्जरी के पहले आपको पता लग जाता है कि इसमें ब्लड की रिक्वायरमेंट होगी तो लास्ट मिनट ओटी में क्राइसिस ना बचाएं। इस पर भी कोर्ट ने कहा कि अगर आपको पता था, आपने एडवांस में ब्लड क्यों नहीं अरेंज करके रखा। तो इसलिए ये भी आपकी जिम्मेदारी है ब्लड को एडवांस में अरेंज करके रखना। रिकॉर्ड मेडिकल काउंसिल 3 साल के लिए कहती है, कंज्यूमर फोरम के लिए रिक्वायरमेंट 2 साल की है, बाकी PCP, NDT और इन सब की है। इनकम टैक्स की 7 साल की है। मेडिको लीगल केस को हमेशा रखें। और एक इंडेमनिटी इंश्योरेंस है, वो कार इंश्योरेंस नहीं है जो हर साल की तरह फेंक देंगे। इंडेमनिटी इंश्योरेंस हमेशा के लिए संभाल कर रखें, पता नहीं कितने साल बाद आपके ऊपर मुकदमा हो जाए। और जो प्रीमियम आप देते हैं उसका 7.5% अगर आप एक्स्ट्रा पे करेंगे तो आपका अनट्रेन्ड स्टाफ भी कवर होगा। अगर कोई प्रॉब्लम उसकी वजह से हुई है तो वो भी उसमें कवर होगी। सिर्फ 7.5% ऑफ द प्रीमियम। विद इन 5 डेज, ये NMC ने कहा था, लेकिन अभी उस पर रोक लग गई है। अब विद इन 3 डेज है कि आपको पेशेंट का रिकॉर्ड देना है और मरीज से इन राइटिंग लेना है, और मरीज को ही देना है। ये नहीं है कि मरीज के रिश्तेदार को, अगर मरीज जिंदा है तो मरीज की रिक्वेस्ट लेटर पर ही देना है और उसकी रिसीविंग लेनी है। कोर्ट को हमेशा डिमांड पर अपना रिकॉर्ड दें। हम RTI में कवर नहीं होते। कोई भी व्यक्ति हमारे मरीज का इलाज RTI में नहीं मांग सकता, सिर्फ और सिर्फ मरीज मांग सकता है, वो भी मरीज की रिक्वेस्ट पर। अगर मरीज जिंदा है, डेथ हो गई है, तो उसके ऊपर जो वारिस होगा उनमें से कोई मांग सकता है। कभी भी आप डिस्चार्ज कार्ड दें, रेफरल लेटर दें, लामा दें, ज़्यादातर देखा है कि लामा की कोई समरी ट्रीटमेंट की लोग नहीं देते हैं। डेथ सर्टिफिकेट दें, बर्थ सर्टिफिकेट दें, यूनिवर्सिटी रिपोर्ट दें, हमेशा डुप्लीकेट कॉपी अपने रिकॉर्ड में रखें और मरीज से उसकी कॉपी पर रिसीविंग लिखवाएं। पुराने और नए रिकॉर्ड अगर मरीज मांगता है तो इन राइटिंग रिक्वेस्ट लें और तब दें। और डेड बॉडी को रिलेटिव्स को दें अगर मेडिको लीगल केस नहीं है, डेड बॉडी की भी रिसीविंग लेनी चाहिए। मेडिको लीगल केसेस की लंबी लिस्ट है, इज नॉट एग्जॉस्टिव। कोई डोमेस्टिक वायलेंस है, रोड ट्रैफिक एक्सीडेंट है, इंडस्ट्रियल एक्सीडेंट है, ट्रॉमा। अगर मरीज ये कहे कि घर पर ही मुझे चोट लगी है, तो भी उसको मेडिको लीगल मानिए, उसकी इंजरी रिपोर्ट बनाइए, पुलिस को मेमो भेजिए, वरना 1.5-2 महीने बाद आपके पास सम्मान आ जाता है कि घर में मारपीट से मुझे चोट लगी थी। तो इसलिए हर ट्रॉमा को आप मेडिको लीगल मानिए, इलेक्ट्रिकल इंजरी को, केमिकल इंजरी को, अनडायग्नोस्ड कॉमा को, बर्न स्केल्स को, सेक्सुअल ऑफेंसेस, क्रिमिनल एबॉर्शंस, अटेम्प्टेड सुसाइड, एस्फिक्सिया, डेथ ड्यू टू स्नेक बाइट, फायरआर्म इंजरी, ड्रग ओवरडोज, ब्रॉड डेथ भी आप मेडिको लीगल मानिए। और बिना पोस्टमार्टम के कभी भी आप मरीज को, अटेंडेंट को मत दीजिए। और ब्रॉड जिस किसी का भी आप पोस्टमार्टम एडवाइस करें, कभी भी डेथ सर्टिफिकेट ना दें, कभी भी डेथ सर्टिफिकेट ना दें, क्योंकि आप पोस्टमार्टम इसलिए एडवाइस कर रहे हैं कि कॉज ऑफ डेथ आपको जानना है, और डेथ सर्टिफिकेट इज नथिंग एक्सेप्ट कॉज ऑफ डेथ। डेथ सर्टिफिकेट कॉज ऑफ डेथ है, और कॉज ऑफ डेथ आपको मालूम नहीं है, इसलिए आप पोस्टमार्टम करा रहे हैं। तो कभी भी पोस्टमार्टम वाले मरीज का डेथ सर्टिफिकेट इशू ना करें। मेडिकल लीगल केसेस में पुलिस मेमो भेजें, इंजरी रिपोर्ट देन एंड देयर बनाएं। एक हफ्ते बाद पुलिस इंजरी रिपोर्ट लेने आती है, डॉक्टर साहब को कॉल जाती है, तो उसमें भी अगर पुलिस वाला चाहे तो इंजरी रिपोर्ट रजिस्टर जब्त करके ले जा सकता है, जो ब्लैंक पाया जाएगा और आपको उसके लिए पनिश किया जाएगा। इसलिए ये मौका ना दें, कभी भी साथ के साथ इंजरी रिपोर्ट बनाएं। कोई भी बुलेट या फॉरेन बॉडी निकलती है, उसे सील करें और पुलिस को हैंड ओवर करें। यूजुअली क्या होता है, बुलेट या फॉरेन बॉडी सील करके ओटी में रख ली जाती है रिकॉर्ड में, 3 साल 4 साल बाद ढूंढ बच जाती है। तो आप जिम्मेदारी तभी खत्म कर दीजिए ना, जब निकली है तो पुलिस के हवाले करें, पुलिस अपने पास जहाँ मर्जी रखे, आप मीमो की तरह से उसे लिख के भेजें और रिसीविंग लें, आपकी जिम्मेदारी खत्म हो जाती है। वरना 3 साल बाद कोर्ट से सम्मन आ जाएगा कि वो फॉरेन बॉडी आपने निकाली थी, उसे लेके कोर्ट में उपस्थित हो। तो ये जिम्मेदारी से बचने के लिए पुलिस के ऊपर जिम्मेदारी डालिए, वो कोर्ट में लेके जाएगी। इंजरी रिपोर्ट पर साइन करें, अपना नाम लिखें, अपना MCI रजिस्ट्रेशन लिखें। पोस्टमार्टम के लिए मैं पहले ही बता चुका हूँ, पुलिस को मेमो भेजें। बड़ा इंपॉर्टेंट है ये OT रिकॉर्ड। OT रिकॉर्ड सर्जन अलग लिखे, एनेस्थीसिया वाला अलग लिखे। ये नहीं कि एक ही जगह दोनों लिख दें, क्योंकि सर्जन का प्रोसीजर अलग है, एनेस्थीसिया का प्रोसीजर अलग है। एनेस्थीसिया वाले अपने इवेंट्स लिखेगा, सर्जन अपने इवेंट्स लिखेगा विद डेट एंड टाइम। उसमें उस रिकॉर्ड में इम्प्लांट, प्रोसेसेस, डिवाइस, मैच सब कंपनी के एविडेंस के साथ लिखे जाएंगे। पोस्ट ऑपरेटिव नोट्स, वाइटल नोट्स, OT में क्या थे वो लिखे जाएंगे। और एक बहुत बड़ा नेग्लिजेंट पॉइंट है जो मैं अक्सर देखता हूँ, ऑपरेशन थिएटर में नोट्स डाल दिए गए, केस शीट वार्ड में भेज दी गई, मरीज शिफ्ट हो गया और डॉक्टर साहब वहीं से चले गए। हमेशा वार्ड में जाइए, मरीज शिफ्ट होने के बाद एनेस्थीसिया वाला भी और सर्जन भी दोनों मरीज को देखेंगे, अटेंडेंट को उसका कॉन्शियसनेस लेवल डिस्प्ले करेंगे और केस शीट में डेट, टाइम और वाइटल दोबारा डालेंगे। वरना कोर्ट ने ये कहा कि आप तो OT से चले गए थे। तो इसलिए इस आरोप को गलत साबित करने के लिए डॉक्यूमेंटेशन पूरा करें। डिस्चार्ज कार्ड में मैंने देखा है लोग आधा अधूरा लिख देते हैं, इन्वेस्टिगेशंस हैंडेड ओवर टू अटेंडेंट, वो गलत है। इसलिए कंप्लीट केस शीट लिखें, मरीज की पास्ट हिस्ट्री, प्रेजेंट हिस्ट्री, क्या हॉस्पिटल में हुआ, क्या एडवाइस किया गया, सारी चीज A to Z लिखें, लिखने में चाहे आधा घंटा लग जाए, हम टाइम नहीं देना चाहते ना, हम मुंह जवानी मरीज को बता के चले जाते हैं। 4 लाइनें डिस्चार्ज कार्ड पे लिखी, अधूरा डिस्चार्ज कार्ड डिफिशिएंसी ऑफ सर्विसेज है कंज्यूमर में, आप पर मुकदमा चल सकता है। और उनमें सर्जिकल नोट्स पूरे लिखें, सारी फाइंडिंग लिखें। डिस्चार्ज कार्ड पर एक चीज मैं अब बताने जा रहा हूँ, वेरी 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 इंपॉर्टेंट। आपने एक लेप्रोटमी की, 6 साल बाद उसमें इंसिजनल हर्निया हो गया, कोर्ट में केस गया, अस्पताल ने तो अपना रिकॉर्ड डिस्ट्रॉय कर दिया क्योंकि उसकी लिमिट 2 या 3 साल है। कोर्ट में आप कैसे अपने को डिफेंड करेंगे? मरीज के पास एक ही रिकॉर्ड है, डिस्चार्ज कार्ड। उसने डिस्चार्ज कार्ड जमा करके कह दिया कि इस तारीख को ये प्रोसीजर हुआ था और ये सर्जरी हुई थी, उसका ये कॉम्प्लिकेशन इंसिजनल हर्निया मुझे हुआ है। तो आपको डिफेंड कैसे करना पड़ेगा? आपको सिर्फ और सिर्फ डिस्चार्ज कार्ड डिफेंड कर सकता है। इसलिए डिस्चार्ज कार्ड में लिखें कि भाई 4 एलिगेशन लगते हैं डॉक्टर के ऊपर कोर्ट में कि बिना जांच की ऑपरेशन कर दिया, बिना बीएससी क्लियरेंस का ऑपरेशन कर दिया, बिना मुझे कंसेंट इन्फॉर्म किए सर्जरी कर दी, बिना प्रोग्रेसिव बताए सर्जरी कर दी। इन चारों से बचने के लिए हमेशा लिखिए कि cholecystectomy और appendicectomy और लेप्रोटमी was done after investigations, PSC clearance, informed consent, explained prognosis। इन 4 चीज़ों को लिखने से जो इंसिजनल हर्निया का केस चलेगा, आप कहोगे जी हमने तो पहले से बता रखा है, इन्फॉर्म कंसेंट एंड एक्सप्लेन्ड प्रोग्नोसिस, इनको बता रखा था कि हर्निया हो सकता है। तो इसलिए डिस्चार्ज कार्ड इज वेरी इंपॉर्टेंट टू डिफेंड इन द कोर्ट। Take home message is better to be safe than sorry. Prepare and prevent rather than repair and prevent. No record, no defense. Good record, good defense. Thank you all for patience. एक इन्विटेशन आप लोगों को देना चाहता हूँ। 31 मई को IMA हॉल में हम एक पूरे दिन की मेडिको लीगल कॉन्फ्रेंस अरेंज कर रहे हैं। IMA मेरठ और इंडियन मेडिकल लीगल एंड एथिक्स एसोसिएशन दोनों मिलकर, तो आप लोग इनवाइटेड हैं, आप अटेंड कीजिए। बहुत सारी नई नई जानकारी अपडेट मिलेंगे मेडिकल लीगल पर, ज़रूर आइएगा। थैंक यू।
थैंक यू सो मच सर। सर मेरा नाम विकास है सर, सर्जरी में प्रोफेसर हूँ RML में। आपका जो टॉपिक था वेरी रेलिवेंट एंड यू टोल्ड इट वंडरफुल। शायद ही कोई आपसे बेहतर इतने प्रैक्टिकल अप्रोच से आपने बताया। जस्ट वन क्वेश्चन, कई बार पेशेंट्स आते हैं घर में चोट लगी और हम उसे अटेंडेंट से लिखवा लेते हैं कि मेरी गलती से चोट लगी है और मुझे पुलिस कार्रवाई नहीं करनी है, एंड वी गो फॉरवर्ड। इज दैट राइट और रॉन्ग?
नो, मैंने अभी मेंशन किया है
ट्रॉमा के केस में सपोज उसके पेरेंट्स या बच्चा माइनर है और पेरेंट्स लिख के दें कि नहीं मुझे कोई पुलिस कार्रवाई नहीं करनी है, इज दैट वैलिड?
नो, फिर भी लिखना,
that has to be done.
मेमो भेजना है, ये रिपोर्ट बनानी है, फिर पुलिस जाने और वो जाने, वो पुलिस को लिख के देंगे कि हमें कोई कार्रवाई नहीं करनी है।
ओके।
आर्म फोर्स में अगर कोई मिलिट्री का जवान उनका ऑफिसर इंचार्ज लेके आता है तो कंसेंट की जरूरत नहीं है। वहाँ जरूरत है, मरीज की कंसर्न की जरूरत नहीं है। हाँ
डॉक्टर भाटिया, एक सवाल पूछना चाहूँगा, बल्कि जवाब भी है कि कई बार हम लोग लिख देते हैं। मैंने एक बार एक नर्सिंग होम में घटना देखी थी, मैं पोस्ट ऑप में बैठा था कि मरीज अंदर टेबल पे लेटा हुआ था, एक अटेंडेंट आया, डॉक्टर साहब उसी समय अंदर घुस रहे थे, तो अटेंडेंट ने कहा डॉक्टर साहब ऑपरेशन कब करेंगे? उन्होंने कहा अभी करेंगे। बोले दिखा दीजिएगा। बोले हाँ, पथरी निकाल के आपको दिखा देंगे और पित्ता भी दिखा देंगे। तो उसने कहा क्या मतलब, पित्ता भी निकालेंगे आप? बोले हाँ। बोले कंसेंट में तो आपने लिखा है कि पित्ते की थैली का ऑपरेशन होगा, आप पित्ता कैसे निकाल सकते हैं? मुझे तो नहीं निकलवाना। और मरीज को टेबल से उठा के ले गया। तो ये लिखना बहुत जरूरी है कि पित्ते की थैली की पथरी और पित्ता दोनों निकालेंगे। अमूमन लिख दिया जाता है कि पित्ते की थैली का ऑपरेशन होगा, विच इज नॉट राइट।
सर एक मैं डॉक्टर रुद्रमणि हूँ, मैं RML इंस्टीट्यूट लखनऊ में सर प्रोफेसर की पोस्ट में सर्जरी में। एक क्वेश्चन ये पूछना था सर कि in the cases whenever we hand over the foreign bodies or bullets, because I work in a government system, so usually we hand over it to the sister and sister does all the formalities. So what is the right procedure? Should all these things should be to the police? For example, body भी अगर जा रही है या foreign body जा रही है, तो जो पुलिस के लिए information जा रही है, that to be signed by the doctor himself or that to be sent by the sister in charge of the ward?
जो मीमो जाएगा पुलिस को इंफॉर्मेशन के लिए, वो हॉस्पिटल के सुपरिटेंडेंट या वार्ड इंचार्ज से जाएगा और उसमें जिक्र होगा इस मरीज की इस डॉक्टर साहब ने जो फॉरेन बॉडी निकाली है उसे प्राप्त करें।
ओके,
उस पर वो प्राप्त करेंगे। जब कभी भी कोर्ट से आपके पास समन आएगा, आप उस पेपर को लेके जाएंगे कि ये पुलिस ने इस डेट में इसने रिसीव की है।
थैंक यू सर।
नमस्कार सर, ये बहुत ही अच्छा आपका प्रेजेंटेशन था। मेरा एक सवाल है सर, जैसे ब्लड ट्रांसफ्यूजन पे आपने बताया, तो कई बार ब्लड अगर अब लिया गया है और विंडो पीरियड में चल रहा है, स्पेशली फॉर HIV, जिसके 2 वीक लग जाते हैं एंटीबॉडीज को डिटेक्ट करने में, ऐसा ब्लड ट्रांसफ्यूज अगर पेशेंट को हो गया, उस पर न्यूक्लिक एसिड टेस्ट नहीं हुआ था और सब्सिक्वेंटली पेशेंट HIV पॉजिटिव डायग्नोज होता है, उस सूरत में सर्जन की क्या रिस्पॉन्सिबिलिटी बनेगी?
ब्लड लगाने से पहले आपको मैंने कहा लिखवाइए मरीज से कि ब्लड का इंतजाम हम ब्लड सैंपल लेकर गए थे और हम खुद करा के आए हैं, नंबर 1। नंबर 2, जो ब्लड लगेगा उसका एक लेवल केस शीट के ऊपर लगेगा। ये दोनों डॉक्यूमेंट ही आपकी डिफेंस हैं। जिम्मेदारी पहली बात तो मरीज के अटेंडेंट के ऊपर डाली कि वो अरेंज करके लाया है। नंबर 2, ब्लड बैंक ने टेस्ट करके दिया, वो एविडेंस आपके पास है, तो सर्जन की कोई जिम्मेदारी नहीं।
सर एक छोटा सा क्वेश्चन आता, जैसे कई बार क्या होता है कि आप डॉक्टर हैं, मोहल्ले में आस पड़ोस कोई बूढ़ा आदमी है, कोई एक्सपायर हो गया, या तो ऐसे में लोग बोलते हैं जरा आके देख लीजिए आप कि भाई ये बूढ़े थे गुजर गए हैं, ऐसे में आपका रोल क्या होना चाहिए? क्योंकि मैं इस सिचुएशन में हो चुका हूँ।
ऐसे में अगर वो डेथ सर्टिफिकेट मांगते हैं, जी तो प्रॉब्लम है।
हाँ, मतलब वो बोलते हैं कि
डेथ सर्टिफिकेट मांगते हैं ना, या और कोई प्रॉब्लम है?
नहीं, और कोई प्रॉब्लम नहीं। मतलब सर जैसे कोई बहुत ओल्ड
देखना मनाही नहीं है
जी,
लेकिन उनको डॉक्यूमेंट और सर्टिफिकेट देखने में एहतियात है कि अगर आपको पता है कि मरीज जो है उस बीमारी से पीड़ित था जिसमें डेथ हो सकती है, तब आप डेथ सर्टिफिकेट देंगे,
दे सकते हैं सर।
अदरवाइज ये केस हुआ है, एक डॉक्टर साहब ने डेथ सर्टिफिकेट दे दिया बिना ये जाने कि मरीज को पहले कोई तकलीफ इस लायक थी। उसके बाद में उनकी संपत्ति के बंटवारे का केस चला, विदेश से उनके बेटे आए, उन्होंने डॉक्टर को पार्टी बनाया कि ये मरीज को मार डाला गया था प्रॉपर्टी के विवाद में, डॉक्टर साहब ने पैसे लेके डेथ सर्टिफिकेट दे दिया है। तो इसलिए एक लिटिगेशन ऐसे भी डॉक्टर में इन्वॉल्व होती है।
थैंक यू सो मच।
सर मैं डॉक्टर संजीव मेडिकल कॉलेज से। सर कभी गॉसिपायमा निकालते हैं सर लोग।
जी जी जी।
तो गॉसिपायमा पहले तो सर सीक्रेटली हो जाता था, लेकिन आजकल लीक होने लगा, बॉडी से कवर लीक हो जाती है गॉसिपायमा का। तो इसको कैसे डील करना है सर? इसकी बायोप्सी करानी है?
वेरी डिफिकल्ट। आपको अपने प्रोफेशनल कोलीग का ध्यान भी रखना है और आपको ट्रांसपेरेंसी भी रखनी है। तो इस तलवार पर कैसे चलेंगे? पहले होता था, आप ठीक कह रहे हैं कि किसी तरह से
अभी एक इन्वेस्टिगेशन में शामिल था, तो इसमें सर ये बात लीक हो गई, गॉसिपायमा निकला। तो ये बात ये आ रही है कि सर बायोप्सी पर नहीं करेगा, तो इसके बारे में सर आप
नहीं, अगर आपने उसको अपनी केस शीट में रिपोर्ट किया है, अगर आपने अपनी केस शीट में रिपोर्ट किया है तो ड्यूरिंग सर्जरी फ़ोटो लें, आफ्टर सर्जरी फ़ोटो लें और उसको फिर बायोप्सी के लिए भेजें। अगर आपने एविडेंस बनाया है तो पूरा बनाएं या कहीं भी ना बनाएं। अगर बात निकल जाती है निकल जाने दें। अगर आपने केस शीट में नहीं लिखा है, आपने कोई फ़ोटो नहीं लिया है और आपने उस फॉरेन बॉडी को अपने लेवल पर जेब में रख के ले गए हैं अपने कुलीग को बचाने के लिए, तो जो मर्जी लोग कहते रहें, लेकिन कैमरे में रिपोर्टिंग ना हो, कैमरे के अंदर ना आए वो। यही तो मैंने कहा, अगर सिटी में आ चुका है तो आप कुछ नहीं कर सकते। अगर किसी डॉक्यूमेंट में आ चुका है तो उल्टा आप फंसेंगे बचाने में।
नहीं, कॉम्प्लिकेशन भी तो हो जाती है ना सर, उस फॉरेन बॉडी की वजह से फिशला बन जाए, बिलियरी लीक हो जाए, तो
उस कॉम्प्लिकेशन को फिर मरीज कहेगा कि सर्जन ने कराया तो उसकी वजह से वो है। मतलब ऐसी सूरत में जब आपने तो गुड फेथ में निकाल दिया, पर उससे बाद में जो है सीक्वलिस डेवलप हो गई, कॉम्प्लिकेशन आ गया उसमें, अब मरीज जो है इस सर्जन के पीछे लग जाएगा कि आपके सर्जरी के बाद ये दिक्कत आई है, उससे पहले तो ठीक ही था मरीज हमारा।
अगर आप अपने कोलीग को बचाकर फॉरेन बॉडी नहीं बताना चाहते तब ये प्रॉब्लम होगी।
हाँ,
तो ऐसे में आप एक कदम और आगे बढ़ जाइए, आप मरीज को बता दो कि आंतें अंदर से गली हुई थी, किसी समय उनमें से कोई भी आंत फट सकती है। मरीज के अटेंडेंट को लिखित रूप में बता दें कि अंदर से आंतें गली हुई थी और कभी भी वो फट सकती है। क्योंकि अगर आपने अपने कोलीग को बचाना है तो आउट ऑफ वे जाके बहुत सारी चीजें करनी पड़ेगी।
अगर सीटी पे है तो
फिर नहीं बचा सकते,
फिर तो बताना पड़ेगा
ना,
क्योंकि सीटी वाले ने लिख दिया,
फिर नहीं बचा सकते ना। पीछे मुझे पता लग गया है कि एक दो केस थे जो मेडिकल कॉलेज गए।
थैंक यू सर।
सीटी वाले को देख सकते हैं, 2 से बयान कराओ, कोई अल्टरनेट ट्रिब्यूनल यूज की जा सकती है। क्योंकि सर होता क्या है कि
खूब आते हैं,
सेम सर्जन के पास आता है तो साथ सीटी भी नहीं कराएगा वो।
हाँ,
तो सीटी कराता है दूसरी पार्टी के पास, दूसरे हॉस्पिटल में जाता है, वहां पे सीटी वाले रेडियोलॉजिस्ट लिख देते हैं। अगर वही कोई टेक्नोलॉजी कुछ ऐसा लिखे कि अल्टरनेट कुछ होना सर, पॉसिबल हो गई तो सर आपको बता दूं बहुत भारी हो जाता है।
ये तो रेडियोलॉजिस्ट से डिस्कस करके मैं अगली टॉक में दूंगा।
और सर ये बहुत ही कॉमन है, मतलब मैं अब तक सर अपने 15 साल के करियर में सर 16 निकाल चुका हूँ, 60 एंड थैंकफुली सर मैं आज तक कोई डिस्क्लोज भी नहीं हो गया। बट ये मतलब बड़ी कॉमन सी प्रॉब्लम है।
नहीं डॉक्टर भाटिया, अगर सीटी में आ गया तो क्या ऐसे केस में बायोप्सी कराना जरूरी है? बायोप्सी कराना कंपलसरी है सीटी में अगर रिपोर्ट हुआ है तो?
नहीं, अगर सीटी में आ गया है, आपने डॉक्यूमेंटेशन भी लिख दिया है तो बायोप्सी करानी चाहिए।
नहीं तो सीटी में अगर आ गया तो डॉक्यूमेंटेशन तो आपको कुछ तो करना पड़ेगा।
हाँ। थैंक यू, थैंक यू,
थैंक यू, वेरी इंटरेस्टिंग सर।
Thank you, sir, for the wonderful session.
रही आज आपकी, थैंक यू।
I would like to invite Dr. Sandeep Swarup sir to please felicitate Dr. Rishi Bhatia sir. I request Dr. Dhanesh sir to please felicitate Dr. Shanti Swarup sir. I request Dr. Gyanen sir to please felicitate Dr. Sandeep Balyan sir. I request Dr. Aditya sir to please felicitate Dr. Rudramani sir. I request Dr. Anshul sir to please felicitate Dr. Anuj Sharma sir. Please felicitation. Please felicitation. Proceeding further, Ma'am, why do you think people say that surgeons have God complex?
Because for us, surgery is easy. We see, we cut, and we fix. Cutting and fixing is my forte, but seeing gets difficult in complex cases. And there is where technology helps. It amplifies visualization and enhances the precision of the surgeon. The theme of our next session is fluorescence guided surgery. To chair this session, I invite Dr. Dheeraj Balyan sir, ex-HOD, LLR Medical College and Secretary ASI Meerut, Dr. Anurag Bijliwan sir, HOD General Surgery, SGRR, Dr. Poonam ma'am, Associate Professor, Department of General Surgery, JIMS, Greater Noida. The speaker of this session is Dr. Vikas Singh sir, Professor General Surgery at RML Lucknow. Handing over the mic to Dr. Vikas Singh sir.
A very good morning to the elite audience out here. Poonam, finally you are here. You were late in the morning. And thank you for having me, Gyanendra. This is the 4th time in a row that we are participating in this. And I must congratulate the organizing team, Sanjay Pandey sir, Maheshwari sir, and Gyanendra and others, that things have been improving year by year. And congrats and keep it up for the future as well. In regards to the topic, the previous topic was really very nice, something which we all need to revise at multiple times because we just go with our enthusiasm in treating the patient and in a way we forget about these small nuances. So thank you for clarifying not many issues, sir. Okay, coming to my topic, the fluorescence guided surgery. The fluorescence we all have been seeing in all the clubs and everything, that we do wear fluorescent bands and everything so that we are better seen. Same technology has come into our surgery. This is nothing new. This has been very old, time immemorial, but only a certain select specialties were using it. And the first specialty to use it was ophthalmology, in which they were mainly doing the retinal vessels and the vascularization of those areas. What came up that we also wanted, and we all have been big fan of this particular person, that he gets to do much more than a normal human being. And that is what we also feel, that once we utilize this, maybe we would be better something like him. So it has been used in ophthalmology for quite a long time. The thing is, we focus, or most of us, we know that it's being used in gallbladder surgeries only, or maybe in other cases also, like oncology or oncosurgeries, they go in for sentinel lymph node mapping and removal, very specific removal in those cases. But there are many other, कहते हैं एक बार आप कार सीख लीजिए तो उसके बाद उस कार से आप left, right, even bike से wheelie and everything you start doing it. The only thing is you need to know about its usage, and then the spectrum can be increased to a very good number. So that is what I'm trying to focus for, that if you know it, you will be able to utilize it. One more thing before that is going to the end point of it, let me reiterate before. We all are into the young surgeons, they go out. Money is not a trouble mainly in opening up of setup, and most of us, we require a good visualization system. And it is always said, the complications happen in 3 parts. Either the initial part of a career or at the time when we are at the helm of our career. These 2 times. There are only 2 types of surgeons. एक वो जिनसे complication हो चुका है, दूसरे वो जिनसे होने वाला है. There are only 2 types of surgeons. There is no third variety. तो जिसके नहीं हुआ है, wait for some more time, do more cases. You will be in the first group, better off. So talking of this, that I will just delineate exactly what does it mean. Because in the era of laparoscopy, we always say, never cut what you cannot see. That is the first. Visualization is the key. बाहर जो लोग खड़े हैं, थोड़ा सुन लेंगे तो अच्छा लगेगा, हमें भी और आपको भी. So sorry, Professor अंदर वापस आ जाता है sir. This is the guy what we are looking at. This comes in India by the Oro Labs, that is the Oro Green dye, which is the only one dye which is available as of now. It comes in 25 milligrams one, and with that you can dilute it with distilled water. That is how it comes up. The only thing is we need to know about that because it is indocyanine green, iodine-based dye, so sensitivity has to be done in every patient without doing anything. And if there is a history of previous sensitivity to any iodinated compounds, then it should never be utilized. That is very, very mandatory. And once the sensitivity has been cleared, then only you are allowed to use it in an IV or IM format, or even the local format, means into the bladder as well. What is important is, this is one particular compound, indocyanine green, which does not metabolize. This is simply goes into the circulation. It a lyophilized powder. Once you put in, it is water soluble. Once you put in, it gets bound to the albumin, and once it is bound to the albumin, it can go in all of the places of the body, and it is excreted, not metabolized. It is excreted through the liver into the bile only. It does not go or gets into the kidneys or any other places, and without any alteration it goes off. And that is one of the beauty of it, that you can repeat the dosage if required intraoperatively as many as times you want. Doesn't matter. What matters is it is said to be as many as times, but usually it is not required much. You can do it in 1 or 2 shots. Then comes on the dosage. 0.1 to 0.5 milligrams per kg is the dose required. 25 milligrams is the vial. You dilute it with 10 ml, so that is 2.5 per ml that comes up. And accordingly, you can utilize it in that particular patient. So it has to be given in that proper dosage. Again, coming on to the dosage, it is variable. I would again say it is said to be as milligram per kg, but it is variable depending on what case are you taking up and what are you trying to see in that particular case. Because it can be repeated, so yes, you can give it without much unless and until the sensitivity has been positive. So it is a sterile, anionic, it is water soluble. Peak absorption, the only thing is again, the compound, whatever it is, indocyanine green, the compound, it has that illumination property if a particular wavelength is shown on it. And then that illumination comes up, and that is seen as, depending on what wavelength are we putting in, it can be seen as a green or as a blue overlap, depending on the system with which you are trying to see. So you do need a special camera for that, and that camera is more of that a particular wavelength of the light is shown on it, and the crystals in it, they shine out. Once they shine out, that is what is seen through the tissues or through the vessels, and that can be picked up in a certain variation of that particular special camera, and onto the screen we can see. Half-life is again 3 to 5 minutes. Again, this half-life means that it is there in the body. The only thing is 3 to 5 minutes is the time once it comes into the circulation. It comes immediately, but 3 to 5 minutes it is all over in the body. That is what the 3 to 5 minutes mean. It is cleared in 5 to 7 minutes. Again, this line is a bit more controversial. It is not completely cleared in 5 to 7 minutes. Lot many riders are onto it. I will discuss again that in which cases, in what time does it come. It is still under lot many research projects that this is going in. So I urge you, please, in case if you have those systems, please utilize it and see exactly for your own benefit. Especially in the initial part of the career, this dye can give you wonders. Routes, again, intravenous, interstitial, and the local also. When I say local, either intrauteric or even inside the bladder, directly it can be given in as local staining. Interstitial, when I say, like previously, whenever we are going to go in for, let's say, a breast lump and a sentinel lymph node is supposed to be seen, previously it was a dye which was the gamma scan or a gamma camera was required. Similar thing in this, you give it peritumoral, and the sentinel lymph node, whatever is in their axilla, that is going to get illuminated. But for that, what you need is the open type of a camera system. There are two types. One is the laparoscopy, other one is the open. And that is being utilized by many head and neck surgeons and the vascular surgeons. When I say vascular, I mean the plastic surgery persons, because they can see the vascularity or the perfusion of the flaps which they are raising and trying to anastomose back. This is one chart. There is still an association which gave these multiple figures. I will not delve into what exactly is written, but it is a whole list. This list is ever changing. The more you use, the better you understand. And in what consistency of that tissues is there, depending on that, you can variate the dosage and the timings as well. And what is important is, see the green list out here, and you will see that hardly there is any case or any system in which the dye has not been utilized. That is what is the main frame out here. It is not just gallbladder, it is multiple systems and multi-pronged therapy or utility which can be utilized. There are various modes. Once you get a camera, whenever there is a live surgery, maybe it can be shown better. There are various modes. When I say various modes, again, the usual camera mode that you have seen, that there are shades of something which can be seen. Shades means the colors are supposed to be as natural as possible. And now once the dye is there, that dye stains, especially the extrahepatic, and wherever there is going to be blood oozing in. So in that area, it does. There are 2 to 3 formats which can be done. The overlapping can be done. Once you switch on that special camera, the overlapping can be done. I will showcase this video as well. So these are various, whether it can be monochromatic or the spy mode. Spy mode is mainly the open camera systems that we are referring to. Or it can be a simple overlay, either green overlay or blue overlay. So wherever the dye is going to reach, that is going to shine as shades of blue or shades of green. Various literatures, again, it is not just the literature. What I am trying to show is the various, already it has been proven in many literature for many years in various organ systems which has been utilized. In the colorectals, the oncology, the head and neck surgery, the breast, the plastic surgery, and the general surgeons. And even many in pediatric surgeries also, after especially the abdominal pull-through or the perineal pull-through operations to see the vascular status of the colon which has been pulled out, that is one of the best ways. Or I would say, objective assessment of the perfusion is best given by them. This is again 25, the guidelines for fluorescence imager guided surgery using ICG dye, which was there. And if you notice, strong recommendation has been there for primary tumor identification, lymph node identification, and left-sided colorectal cancers. For them, it's a strong one. Conditional again, distant metastasis, esophageal anastomosis, because the places where the only thing which we depend on is the perfusion status of the cut ends of the bowel. That is very important. And reasonable intraoperative, that is expert concern, but that is the one which is growing up and coming into the strong part. So the more number of studies, the larger study samples are required for us to shift in the first group. Key surgical applications, I did tell regarding the vascular assessment. Like I give you one more example. For all the residents, you all must be doing some kind of resection and anastomosis in your emergency cases. Once you do that, once you cut the bowel ends, you try to see, and once you release that bowel clamp, bleeding is there from the cut surfaces. Once there is bleeding from the cut surfaces, we take it to be that this is vascularized. But remember, the term which we use is, as the blood oozes out from those capillaries, it is said to be as it is vascularized. But for anastomotic integrity later on, for it not to cause any dehiscence, what is required even more is perfusion. That perfusion word is the utmost important. But there is no way that we can assess perfusion with our naked eyes. So whatever we do, the objectification or the objective analysis of that vascularity is done by perfusion. And that can be done by this ICG type. So if in emergency setup, if these things are available, once we have resected, before you are going to anastomose, you can always check whether it is homogeneous green coming in right through the anastomotic line or not. If at all it does not come in, or after anastomosis, there are patches where the green cannot glow up, that means your anastomotic line is going to dehiscence later on. So that's why objective assessment of the perfusion is very, very good with this particular type. Biliary mapping. When I say biliary mapping, what I mean is extrahepatic biliary tree, because one of the most dreadful complications or one of the main bread butters for all the general surgeons is gallbladder surgeries. लड्डू gallbladder है, पर लड्डू कई बार गले में फंस जाता है, and then patient loses the life and the surgeon loses the career. These two things are very, very common. So beware of that. Rather than overconfidence, it is always good to see the biliary status. Not just notify the gallbladder, it is salvaging what is supposed to be there with the patient once the patient goes home. So that is very important. So exact biliary mapping can be seen. Tumor identification resection, depending on how good number of cases you are doing, that is very, very essential. Urological procedures, especially partial nephrectomies if you are planning. Then the perfusion of the kidney, the part of the kidney which you are leaving behind is important. Ureterostomy, neo-ureter formation, or the bladder part which has been removed, whether that is good or not. In those cases, it can be providing as a very good entity. And finally, the tissue viability, because what you are leaving behind is the utmost importance. Because what we need at the end of it, that sham ko sukoon se reh paye, and that is the peace after the surgery. That evening, that night is very important. So agar hame lag raha hai ki technicality mein gabad hai, we can always improve on. But if we have just done it and we are saying Ram 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 ho jayega, तो make sure वो राम का उल्टा वो भी हो सकता है. तो इस वजह से once you say Ram 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 Ram, at times the sound comes in as something else also. To avoid, you have to be certain what you are trying to do in. I would just show a couple of videos. This is the biliary channel. The point I was given, whatever we have tested, I will just try to tell that. Extrahepatic biliary tree agar mapping karni hai, so the best time duration is that you give it a day before. Various literature says 20 minutes before, 2 hours before, and all those. But what imagines is, what we have seen is, once you give in, the whole of the liver also becomes green. Against that green, to see the biliary ducts, it's a bit more troublesome. So what is advisable is, you give it a night before, maybe once the final PAC is being done by the anesthesia resident at around 11, and you are certain that this patient is going to be taken up for a gallbladder or a hepatobiliary surgery tomorrow, you give it at 10 or 11 in the night. And you are going to do it, the surgery, within the next 12 hours. So next 12 hours means tomorrow in the morning, before 12, you are definitely going to put in a laparoscope inside and see. By the time, all the dye from that liver is going to be excreted in your biliary system. And once it is only in the biliary system, it is going to be visualized nicely. And you will see exactly what do I mean by this. This is the intensity map. So this was my resident was doing. He was not sure that which map is supposed to be on. That's why this is what we say, क्या बोलते हैं उसको, autism में जो नहीं करना होता है, वो किया जा रहा था. This is the green that I am talking for. Once you see these greens, this is only in the bile. And once you go close, and in this case, you can see that it is coming up. The biliary duct can be seen very clearly. And once you have a nice pull, you can easily see even the confluence above and the CBD down. This is one of my associates is doing it. So I'm just standing outside, telling him to push the liver so that I can see the hilum part of it. And if you notice, the hilum part that part also can be seen as green just below the liver, the upper part. That is the portal part or the porta hepatis part. And you can see the CBD out here, the supraduodenal part, and the thin bile duct can be seen. So once you are seeing it clearly, I don't feel that you are going to damage it. Because if you are doing that, then nobody can save you. So what is required is the right biliary mapping. The technique you will have to practice much more. So now again, see one more point before I go it for the last. The distance from that particular structure does matter. So you need to be close enough. Close means 8 to 10 centimeters your camera is going to be, then your illumination is going to be better. That is very, very important. So if you are staying far off and seeing a panoramic view, maybe things will not be so clear. So you need to learn where do I focus it on, and then only things are going to be better. And in this, you can see that dissection is being done around the duct. And once you can identify the ducts, you will definitely be able to salvage them, not cause any injury behind. So that is very, very important. So that is our extrahepatic biliary channels. This was an interesting case. I did one single incision laparoscopic cholecystectomy. I do it on a regular basis, only with 2 ports. But complications do happen. There was more likely, because MRI was obviously not done for a simple gallbladder. She was a young female. Later on, came back again. So I did a wonderful single incision cholecystectomy. Patient came back a couple of weeks later saying, I still have pain. So we thought, young female, maybe some component of peristeria. Got one ultrasound, a stone is there. And what we found, gallbladder was dumbbell shaped. They reported in the first one single stone, and we did remove with the gallbladder, single incision. But later on, we found there were 2 stones. One was more long cystic duct with that stone was on to the CBD side. And this was a difficult case. So we went in again, we put in 1 extra port for that. And we were able to do, so that is the reason stump cholecystectomy, completion cholecystectomy was done in this case. And because all the safety parameters are supposed to be followed. So you can see the rubeus sulcus, and the area with which we are dissecting is above the rubeus sulcus, as we say that R4U line is there, and we are supposed to stay above it. So those safety parameters are supposed to be taken care, but still giving in ICG, now we'll change it to ICG mode, and you will see that it comes in beautifully so that we can salvage it from the CBD very nicely. So that is a lymph node which is there, which is going to be removed. And see this. Out here, and now see this. The liver is also green, and you notice we can see the cystic duct and the stump with the stone in situ. What is important is whatever area is going to be close to your camera, that is going to glow up more. So you need to really focus on the area which you want to be glued on. Once you start seeing those things, your precision of dissection improves a lot. So that's what I'm trying to push in for all, especially the young surgeons. In usual cases, do it in usual cases so that you are more adapted and you are better versed with how it is better for you, and then you can utilize it in your difficult cases as well. But you really need to do it in your regular cases, because one vial costs only 1,800 rupees to 2,000 rupees, and you can use it in 2 to 3 patients as well. In a gallbladder patient, because you need just 2 ml in one case after 10 ml reconstitution has been done. So just 2 to 3 ml is required in one patient in a gallbladder surgery, and you can see it wonderfully. So maybe 2 to 3 patients in one evening you can utilize it, and you will not be having any complications. And you can see that this is the duct which we are trying to see. And once we see the anatomy, things can be taken up from there. Perfusion analysis.
This was a case of all stoma, and along with the stoma, there was obstruction. So what we, and it was a hernia as well, so we needed to put it down. So it was just the ICG was being routinely used. What we wanted to see is how does the bowel look like. So this is our experimental case, and you can see that the bowel can be seen. The only thing is that distance from the bowel of the camera is important. So once you go near, you are able to see the better perfusion. So in case if there is a trouble, it will be evident as a non-green area. So it is only dense adhesions. We wanted to see if at all there is any patch which is not glowing up, so that we can be better delineating that particular patch. Again, this was a case of an obstructed hernia, and it was done in emergency, and you can see the chunk of the bowel which has gone up, and you can see I have already reduced approximately 5 millimeters or 7 millimeters. I have pushed it from my external maneuver, and you will see this is the site. This was the site which was constricting at the hernial orifice, and the reason that it has turned green is because there is a reperfusion once we have pushed it down, and that reperfusion can be seen with green. So once you are seeing green, means it is going to be revascularized. We can always wait and watch, do a dialysis carefully, and finally, because once we are in a lap surgery, we cannot put mop and remove. So what we require is this particular maneuver. Once we are confirmed that what we are leaving behind is a viable, perfused bowel, you can sleep at rest. That is what is very, very important. And while doing even adhesiolysis also, remember the fibrotic adhesions will not take up the green color, or they will be less green than the bowel. So once you are seeing it more, the more you see, the better you understand the usage or the nuances of it. This is the colon which is being done, and you will see that how does it change. And you see this. So it comes in the vascular channels immediately at the time of induction, means at the time once you are infusing it, it comes into the channel. And you can see the anastomosis has been done. Everything is beautifully green. Once everything is beautifully green, I can be assured of if technically I have done it proper, if serosa to serosa continuity has been maintained, at least it is well perfused, and there might be less chances of technical leakage from it. There can be multiple other causes. Maybe patient goes off in the post-operative period, hypoalbuminemia is there, or maybe malnutrition, or there are other causes also. But at least on table assessment, and this picture can salvage, and patient, it can be as in a court of law also, that this is what the intraoperative picture was there. The colorectal procedures, once we have ligated the vessel, because we always go in for the vessel first and later on the bowel. Once we have ligated the vessel, we can get to know where exactly is the line of incision of or the margin where the resection is supposed to be done. And once we know that, we can be more precise in our approach. This is one more thing which we use. There is going to be a lecture by Dr. Rudmani of ETEP approach of bilateral inguinal hernia. What we come across is, maybe the residents will be knowing it better now, that there are going to be neurovascular bundles or the neurovascular channels, if you ask, within the rectus coming from the linea semilinaris medially. And you can see these are the channels which we are talking of. This is right at the level of the pubic symphysis, the corona mortis, that veins were being seen. The deeper down, the muscle above what you are seeing is that the rectus abdominis muscle, and we are in the retrorectal plane. ETEP for bilateral hernia is being done. The floor below is your rectus sheath, and these are the vessels. See, once I go close, I can see this neurovascular bundle beautifully. Because what is said is, while putting in the lateral ports, at every cost, you are supposed to prevent any trauma to this neurovascular bundles. If you are doing a good hernia, especially the ETEP approach, if you traumatize them, the whole rectus muscle is going to lose its density and become atrophic over a period of time. So once you identify them, you get to know where do they belong, and then you will be more routinely, you'll be more less problematic or causing less damage to these things. Pelvic and bladder. This was an interesting case which we did around a month back. Post-abdominal perineal hernia, there post-abdominal perineal resection, there was a large perineal hernia in around 55, 60 years male. And the whole hernia, and this is what we are trying to dissect, the hernia. We did put in an intraureteric catheter and injected the dye in bilateral ureters. Obviously, that will come into the bladder as well. Because what was important is there were dense adhesions down into the pelvis. And you can see the one on this is the ureter at the pelvic inlet, which can be seen. Because while doing dissection, you are not only supposed to prevent any injury to the bowel, but also to the bladder. And enthusiasm over things can result in injury, unforeseen injury to your ureters as well. So in endometriosis, in which or any retroperitoneal surgeries, this ICG, just putting inside the intraureteric catheter and pushing the dye, and it stays for 3 to 4 hours. Wonderfully 3 to 4 hours, and you can do your surgery very well. So during the procedure and after the procedure, you can document it on video that things were pretty safe out there. So that is one of the very important points in this cases. Troubles. Again, when I say troubles, I mean you might be having a Ferrari, but if you do not know how to get in, how to get out, you do not know कि कितना पैडल प्रेस करना है, तो बाहर निकालते ही सबसे पहले रोड के बाहर आ जाएगी, and it will hit up onto one of the things. So that's why you must know that how do we use it, when do we use it, and कितनी देर में किस चीज पे उसका इफेक्ट आने वाला है. Unless and until you know the hardware, you will not be able to run even a Ferrari also. So one, the area of the focus, which is important. When I say area of the focus, see exactly, maybe you may notice it, you may not notice it. See exactly, the camera is more closer to the liver. It is not shining the light in the deeper part, that is darker than what is required. And one more thing, if you notice, camera is too close to the falciform ligament. The light is getting shown on the falciform ligament. And ligament is in the view, light. So it has to be in the center of the screen, and the camera is supposed to be pretty close enough if you want to see. See, again, I would not call this as good illumination. There is light, but this is not said to be as the best illumination possible. So what is required is you dig deep down, see only the areas, whatever is required, leave out the focus which is not required, or the field of vision is supposed to be a bit smaller. And that is the reason that in spite of giving the dye, we were unable to see. और जब हमने area of focus सही किया, तो ICG dye का mode off कर दिया गया था. So that will happen unless and until you use it more often. You will not get to know कि कहाँ पे क्या चीज करनी है and how does it focus. So this I have already talked about. See, once I started off, we were not seeing the dye. Once we have gone close, you can see the dye beautifully. So this is very, very important, that field of vision and the distance from the target area is very important. Interest ना आ रहा हो तो बाहर जा सकते हैं. भाई साहब, interest ना आ रहा हो तो बाहर जा सकते हैं. Okay, one more fallacy is that we are looking. The depth through which these dyes can shine through a particular tissue is said to be as only millimeters. When we say millimeters, let's say 3 to 5 millimeters. But in India, we get thick gallbladders, thick CBDs, and previous itni pain unko ho chuka hota hai ki it does contract and it does thicken up. Once it is thickened, no matter how good you have given the dye, no matter how close you are, you will not be able to appreciate the anatomy the way you appreciate in a thin-walled gallbladder or thin-walled CBD. So that is one of the fallacies of it, कि जिस काम के लिए यूज करना चाहते थे, कई बार वो काम भी हम नहीं कर पाते हैं. But at least this is the case of a Mirzzi syndrome. This is the case of a Mirzzi syndrome with stones in the CBD as well. And you can notice we cannot see the dye. And you will notice once we cut it off, the wall is more than 7 millimeters thick, not only of the gallbladder, but including the CBD was also more than 7 millimeters thick. So one that is so thick, no matter how good your light or the camera is, it will not shine through those thick walls. So that is one of the fallacies of utilizing it in certain selective cases. So in those cases, again, it is your experience which comes into the play rather than only the technology. So technology only helps you guiding better, but it cannot replace what your skill and your experience is. So again, I come back to one more thing, that why I'm trying to push it, because we get many cases of biliary duct injuries in general surgery, and our unit is managing many biliary duct injuries. We do a lot of hepatico-jejunostomies and after or maybe before PTBD, and that's why we know that whatever we are doing, initial pe jo dhakke lagte hain, they are more troublesome. Mark my words, people tend to leave those cities, move out with everything, one mistake and everything comes back to zero, rather even to negative. And sir will agree with that, that one mistake in the initial part of the career and life changes. No matter how good planner you are, that's why it is very, very aptly to say that rather than doing something, hop and jump and do the surgery, your optic system has to be state of art. Instrumentation कहते हैं कि बंदूक अच्छी अगर नहीं है और उसमें गोलियां आपकी पसंद की नहीं है, तो please don't go on a war, otherwise you are going to be scrutinized out there. So it is always better to have your own armamentarium, the nicest one available. And I do believe that it has a very good potential for a widespread adoption in our usual general surgery cases as well. Because this is one paper which I really like, that application in GI surgery, the future is bright green. Not just bright, it is bright green. And again, the Green Lantern was a wonderful character, and we all have loved those movies. Thank you all.
Any questions? Sir, very nice presentation, sir. Sir, I want to ask you, sir, what is you are said all cases of tuberculosis?
Yeah.
Is there any guidelines or it should be communicated on?
Well, again, I said, like the robotic era is there. We all are doing robotic surgeries. Whoever has that, they always start with a robotic lap chole, or robotic chole, not robotic lap chole. They start with this. Whenever we have a new car, सबसे पहले हम कहाँ चलाते हैं? खुले फील्ड में. खुले फील्ड के लिए लाए नहीं है, बट सबसे पहले हम खाली रोड पे चलाते हैं, खुली उस पे रोड पे चलाते हैं, फील्ड में चलाते हैं. Once we get our hands on, we get to know कितनी कार इधर काटनी है, कितना. Once we know the maneuverability of it, once we are adapted to it, then we can go into any of the bazaars. Same thing applies with this. Start with your lap chole and lap hernias. Start with them, see exactly how do the tissues stain. Can you really go in for those timings? Once you learn, kaun si cheez, how will it respond, how good you are in assessment, how your camera is functioning, does your whole team know about it or not, then you will start seeing in difficult cases as well. So aim is to start with the basics and then aim for the higher one, rather than aiming for a case which I shown, the Mirzi syndrome, कि हम सिर्फ मिर्जीज में देंगे और देने के बाद भी कुछ दिखेगा नहीं. उससे बेटर है हम प्रैक्टिस सिंपल से करें, and then so there are no such guidelines till the time it is non-sensitive, means sensitivity test has been there and that is okay. There is no harm in utilizing, if you have the system, 1800 rupees to 2000 rupees in that particular patient. There is no harm in that.
Thank you, sir.
Thank you. Yeah, please. Okay, again I said, if you are going to use for checking the vascular status and the perfusion, it is immediate, because it comes into the blood immediately as we given, it comes into the circulation, systemic circulation. So like I showed in that particular image, the colon one, you could see the whole of the omentum and the colon glowing beautifully. In those cases, it is always supposed to be given on table itself. So you keep up the sensitivity first, and then whenever you are ready to test that you really want to see the perfusion, ask your anesthetist friend, give him already 1.5 to 2 ml depending on the weight, you push it. And once that has been pushed, you put in your camera, on it your camera, and you will be able to see the vascularization or the perfusion status, whether it is of any of the vessels or whether it is in a hernia case or whether it is for the bowel. You will be able to see. Yeah, approximately. Approximately, the best is 2 ml is one of the safest ones.
When might we IVG in acute coli or emergency cases?
Always remember again, it is not about acute coli or elective coli. It is only about it. Suppose you are going in for acute cholecystectomy, it is an emergency surgery. If you give it at that point of time, the problem is it comes into the whole of the liver. And at the time when you are doing, you do not want to see only the liver. You want to see the biliary system. That biliary system, certain things are said. At times, you can say that like we use HIDA scan as well. HIDA scan is for at what rate the bile is flowing. In those cases, if the flow of the bile is good, it might be possible that during that 30 minutes or so, your gallbladder also will get the gyre. But what we have seen in our case series, that once you give it in the night, you don't need to see the liver. What you are focusing on is only the gallbladder and the extrahepatic biliary system. So in acute coli, if you have 4 to 6 to 8 hours, you give it. By the time the preparation is being done, that is going to help you better.
Sir, and if obese patient, dose will be same?
Yeah, dose will. It is milligram 0.1 to 0.5 milligram per kg. Depending on that, you can give it.
Sir, one question. If there is spillage of bile, then
Again, remember one thing. Till the time it is all contained, like I did show in the hernia cases, that out there was some spillage. So wherever the blood is going to spill, there it is going to become green. It is very difficult to decide whether it is coming from the bile duct or whether it is the blood which is there. Uska one of the best mode is flip between the normal mode and your fluorescent mode. So once you flip, the bile is going to remain green, but your blood is going to be red. So that is something which you can confirm on those cases. Difficulty will always be there, but your experience and your precision will improve over a period of time. There is going difficulty. Difficulty nahi hogi to surgeons nahi hogi.
Thank you, Dr. Indra, for nice presentation.
Thank you.
Thank you, sir. I would like to invite Dr. Dheeraj Palyan, sir, to please felicitate Dr. Vikas Singh, sir. I invite Dr. Shanti Swaroop, sir, to please felicitate Dr. Dheeraj Palyan, sir. Dr. Rishi Bhatia, sir, please. Dr. Sanjay Pandey, sir, to please felicitate Dr. Poonam, ma'am. Dr. Malika, ma'am, to please felicitate Dr. Anurag Pijalwan, sir.
From the time of Shushruta, basic surgeries like hernia has modified from open to keyhole surgery. Newer advances are bridging the gap between human touch and high-tech precision. So our next session focuses on bilateral inguinal hernia, ETEP, alias newer approach. The speaker of the session is Dr. Rudramani sir, who is a professor in RML Medical College, Lucknow. The session is being chaired by Dr. Sanjeev Kumar sir, Professor LLRM Medical College, and Dr. Sachin Yadav sir, Assistant Professor, JIMS Noida. Handing over the mic to Dr. Rudramani sir.
Thank you so much. Very good morning to all the ladies and gentlemen. And from the very beginning, I would like to thank the team of Subharti for inviting me again and again for these sessions. And it is very happy moment for me to being invited there and present my work. So today, I'm going to discuss about that bilateral inguinal hernia repair as ETEP as a newer approach. So ETEP has been there in the operative era for last approximately 8 years. But what is new about it? The new thing about it is that for bilateral inguinal hernias, people are not very much intended to take it as an approach. It has been a very hesitant thing among the surgeons that the bilateral hernia is not to be done in a single sitting, or to start with, they take up as one-sided because it is easy to do. But yes, this session is about ETEP, which makes it as easy as a unilateral hernia to be done with the settings of the bilateral hernias. So before further discussions, the anatomical considerations. All of us are well versed with the anatomy, and the only thing is to be thought about it is that the rectus muscle on the either side is enclosed into a sheath. One that is anteriorly, there is an anterior rectus sheath. Posteriorly, there is a posterior rectus sheath, and the posterior rectus sheath is midway between the umbilicus and the pubic symphysis. It ends up forming a curved line that is known as arcuate line or line of Douglas. The ETEP approach or preperitoneal approach are very much dependent on the preperitoneal fat distribution. It has been seen that it is very difficult to separate the peritoneum from the retrorectal area, but the preperitoneal fat is very much thick in the midline from the falciform ligament to the pubis and on the either side of the rectus muscles. So this anatomy helps us to go in between to make a preperitoneal fat, because in the lower half of the abdomen below the umbilicus there is a rich preperitoneal fat which makes it very easy to proceed forwards towards the inguinal area. One more anatomical considerations on the lateral side of the rectus muscle, when it is the plane between the posterior rectus sheath and anteriorly there is the rectus muscle. As Dr. Vikas sir has said, he helped me, they made it easy for me to demonstrate the anatomy, that on the lateral side there are neurovascular bundles, and this is known as lamppost sign because they are, when it is well dissected, they are vertical like in a street, multiple lampposts are there on the sides. This is of utmost importance because any injuries to these segments, they can cause undue bleeding in the limited space of the rectorectal area, or it may cause further loss of the, it may cause further weakness of the rectus muscle. So this has been the change in the positions of the ETEP versus ETEP, totally extraperitoneal and extended totally extraperitoneal port positions. So in the TEP, one camera port was at the level of the umbilicus and two camera ports were in the midline below it. But in the extended TEP, The camera port can be put midway between the linea alba and the linea semilunaris, 3 to 4 centimeters above the umbilicus, on either side of the midline in the cases of the bilateral hernia, and two other ports, one for the lateral entry and one just below the umbilicus to the side of the camera port can be there, and it is the ideal position of the ETEP. For the inguinal hernias, the port positions can be a little low as compared to the previous thing. I consciously put down this. Can I have a water, please? Can I have water, please? I consciously put it that the lateral port a little lower and the camera port a little lower as compared to the previous image that has seen a better visualization of the inguinal area. So in ETEP, what is the difference in the technique? This was the presentation which came into SAGES 2018 by George Darris, in which he demonstrated first the technique of the ETEP. So what he suggested, that the 5mm camera port can be put from the one of the lateral inferior ports, and the plane between the rectus, posterior rectus sheath and the preperitoneal area, that plane can be should be managed, and the release of the posterior rectus sheath should be just medial to the linea semilunaris to make it a wider space. But we can see that it is being dissected and the wider space is created. But with the advent of the technology and the better understanding of the preperitoneal fat patterns, the incision to the posterior rectus sheath or the release of the arcuate ligament can be on the medial side, and this has made our life very easy. So this is the difference in the optics. If it is a TEP, totally extraperitoneal, then the retromuscular tunnel that does not allow the light to proceed forward, and it is a narrow tubular vision. But in the case of the extended totally extraperitoneal approach, the medial release of that posterior rectus sheath allows our camera to stay backwards, one telescope to stay backwards, and the preperitoneal area which can be dissected, it can be right from the just below from the umbilicus to get a wider area, and it makes a wider space for the manipulation of our instruments. So the advantages: one, panoramic view. The whole lower abdominal area in the preperitoneal space can be seen well. Better instrumentation, your angles, all the angles for the laparoscopy can be managed well. It allows us to feasibility to attempt larger hernias. It allows us to feasibility of attempt bilateral hernias, and placement of better and larger mesh placement are there. Better and larger mesh placement is very much possible in the cases of the ETEP. So this is a case of ETEP in which we will be demonstrating how it has been done. It is the OptiView port is placed, and the white glistening ring is anterior rectus sheath, and posteriorly there is a muscle, and proceeding forwards. So a dissection is made in between the anteriorly pushing the rectus muscle, and the posteriorly that white glistening is the posterior rectus sheath. And proceeding forwards, that this is the areolar tissue just behind the rectus muscle. With the help of the camera, the telescope, further dissections are being made, and after the OptiView trocar removal, this is the space which has been created. We have taken ICG in it, and on the lateral side, as we are making the dissection with the camera, and on the now you can see that the blood vessels are there, and on the lateral side, the same view which Dr. Vikas has demonstrated, it is there. That on the our lamp posts are fluorescent green. Further dissections are made with the help of putting down one of the lateral ports with a 5 millimeter port, and gentle space management between the preperitoneal area and the anterior sheath is managed, and you can very well see that downwards there lies the pubic ramus. Single-handedly, the preperitoneal space on the opposite side can be managed well with a champagne sign. There is no vessel in between, and the preperitoneal area is all vascular. So small but cautious efforts. The space of radius, and coming to the space of the Bogros. The lateral, from the medial edge of the arcuate ligament, it is the dense preperitoneal thickened tissue that is being released for making a better space on the opposite side, that is right side in this case. Further simple small dissections are moving forwards and creating our approach towards the hernial area. So the position of the ports may, according to the body of the habits, may need a release of the arcuate line or may not. In the lateral side, we can see there is again a space, and gentle movements are making a good space for placement of the mesh. This is the area of the herniation, and we can find that a fat layer is going inside on the direct hernial area, or from the anterally it is said to be superficial, the inguinal ring area. A glistening layer can be seen on the superior part, and that is the pseudosac. And gentle tractions and the dissections are making our tissue to lie down, and it is making it better in the result. On the opposite side, putting one more port infraumbilically, on the opposite side, the dissection is carried between two instruments. The lower one is supporting the tissue, and anterior one is the dissecting the tissue. It is very important to not to injure that fascia transversalis, otherwise the epigastric vessels will lay down. So the epigastric vessels should not be, inferior epigastric vessels should not be denuded. They should be covered with their coverings and the fat. So this is further dissections in the coming to the space of Bogros. And the lateral dissections are extended with the help of two the tissues, with one supporting and traction and the counter traction mechanism. And you can see posteriorly that there is the area of the inguinal ligament. The hanging tissue over the instruments, that is inferior epigastric artery. And the posterior you can see that is the glistening sac. So the sac has to be reduced. Only the sac has to be reduced with the gentle dissections. And you can see that the sac is being tractioned backwards, and there is a big lipoma associated with it. And this dissection is on the lateral side of the inferior epigastric vessels, and this area is of indirect hernia. It is very important to know that if you are in a correct plane, then no energy devices are required at all. In a closed area, firing unnecessary energy is always detrimental. So a lipoma is being taken away from the sac, and in the left hand, in the Maryland, the sac is being taken backwards. Now you can see that it is with the lipoma, it is very well retracted back, and sac is being separated from the cord structures. Coming on the right side again, the lateral space is being created, and we can very well see that the Pockett's ligament anteriorly. And now it is we can see that the fat is pushing in between, attached to the pseudosac in the area of the direct inguinal hernia. And now it is being again dissected well to take all the peritoneal line free from any of the herniations. So you can wonderfully see that the triangle of the tomb. Medially, this is the area of the vas which is being dissected, and vas is being medialized. There is a medial turning of the vas, and there is the adequacy of the dissection. Laterally, there are the gonadal vessels, and this is the dissection where the peritoneal layer forms a straight line downwards. Coming on the left side again, the residual lipoma along with the cord, we have taken back down the sac, but there is a big lipoma attached to the cord, and it is being dissected. This lipoma was not fully reducible, so only one area where the energy has been applied, that is the burning and the division of that lipoma for achieving a better place, a better area for the placement of the mesh. The mesh, the big mesh that is 15 into 12 centimeters, the mesh is planned for one side, and we are going to place two meshes with a medial overlap. The curvature has been, the corner of one of the corners are trimmed to the lateral upper positioning. And you can appreciate that with this, all the panoramic view and the big space created, it is very easy to manipulate this big mesh, which is not possible in the conditions of the tap only. So medial coverage in the medial part in the space of the radius, and covering the triangle of doom and making it more lateral possible. So beautifully the mesh can be displayed up. One more for the left side. And with a medial overlap, the mesh is being placed, that is straight on the left side. So we can see that is a good medial overlap between the two meshes. The instrumentation, because the our telescope is far from the area of the dissection with a good illumination, and there is a wide area where the instruments can be manipulated, the mesh can be placed well. So now you can see the mesh, the medial overlap is being reinforced by the placement of the tracker. One on the left lateral side, one on the right lateral side, and one more in the medial, so that the mesh should not fall. So the restriction of tap has been changed, and in the condition of the E tap, because it is a wider area dissected and the better manipulation, both of the sides are well illuminated and can be taken from one side of the abdomen, because the release of the arcuate line below the umbilicus. So this is one thing which ETAP has made life easier, and the better placement of the mesh. So despite that, what are the challenges? One, access to the retromuscular planes. That balloons dissectors can be used for making the retromuscular planes, one, but with the help of the visiports, the layers are seen. It is important to note that with the pointed tip of the visiport, that posterior rectus should not be pierced down. Otherwise, it will cause the pneumoperitoneum, and the dissection will be difficult. For making it easy, the head end of the patient should be downwards, and our manipulation and the dissection with the help of the telescope and the visiport should be in parallel to the table itself. The placement of the lateral port, as we have already discussed, that it should always avoid the vessels. And in the umbilical port placement, it is always advisable that the medial release at the arcuate line should be beforehand. So the take-home message: we are moving from TEP to extended TEP, and life is going to be easier, and it should be adopted by each and every surgeon. The second message, that we all are laparoscopic surgeons, and we are going to be converted into e-laparoscopic surgeons, and that E stands for E, that is extended spectrum of cases. Thank you so much.
Excellent presentation, Dr. Abdulmani.
Thank you, sir.
You have well explained step by step ETAP technique. As you are dissecting too much in ETAP, so is there any experience, your experience regarding seroma formation? We are placing big mass, we are creating a big, dissecting big space.
Sir, yes, it has been reported in the literature that the ETAP technique has a more incidence of seroma formations. In our cases, it has been seen in 2 cases we have that seroma formation. Otherwise, in the rest of the cases where the dissection is not unintended overdo is not there, and it is to the appropriate placement of the mesh, the seroma formation in our cases it is not there. In 2 cases it is there, sir.
That's also good manage for the PE.
So seromas are one thing, that one thing it is to be understood, that they are non-infected contents. So the seromas usually they absorb over time. In the classification of the seroma, in the cases of the hernia, it has been seen that the seromas are to be intervened surgically only after all the conservative managements they are lost, they are exhausted, and that intervention should be only taken after 6 months. Otherwise, usually most of the seromas they resolve on its own.
I have two questions.
Sir.
First question is more placement for the camera.
Sir.
So is it between 9 postal frame and 9th frame and writers? We have to make some modifications.
So, sir, it is not that like a 9th rate to the umbilicus. It should be midway between the linea similis and the linea alba, and 3-4 centimeters above the umbilicus. Making it a little lateral will make life easier because the opposite side vision, it will be easy to manipulate the telescope, and the opposite side vision will be easy. If we put it a little higher, then we will turn up again into that the optics slide, that higher it is placed, the tunnel is longer. And if the tunnel is longer, then our illumination is going to be restricted.
About the second port, where you prefer it?
The second port just in front umbilically on the side of the camera port.
Sir, we will need to fix the mesh.
So there are many literatures in which there has been a debate about that the mesh should be fixed or not. But when you are, as sir has already said, that you are creating a bigger space, and if two meshes are like that we have placed, and there is a potential space to migrate, because it is the migration of the mesh is not about just that the placement and it will fold up. Within the literature it has been said that with the bladder contractions and distensions, with the abdominal movements, there is a play between the mesh and the tissues. So it is wiser if you are creating a wider space, then it is always wise to put tackers, 1 or 2, on the lateral side and the medial fixations. Thank you.
May I just clarify a couple of things? Number one, the seroma. We all talk about seroma. Seromas are not just collections of sterile fluid after any plane of dissection. Seromas, those seromas are supposed to be tackled which are symptomatic. And the commonest areas of seroma which need to be tackled in a hernia post-hernia surgery is the pseudo-sac place where the seroma forms. So it is those seromas which are anterior to the mesh, clinically palpable to the patient as a swelling. Those seromas only we are supposed to be concerned about. Something which is underneath, non-palpable, neither we will be able to get it, nor the patient is going to have any trouble. There is definitely going to be some amount of ooze of the fluid resulting in seroma. But whenever we seroma, it is always symptomatic, in which the patient is coming to you with a persistent swelling post-surgery. So whatever things we are doing, it is for the seromas which are palpable at the external ring and in a large pseudosac. And multiple things have been done, plication of that last pseudosac, or putting in a glue over that, or doing a gulla dressing over that. Those things can be done. But in spite of that, if it happens, wait and watch is one of the best things, and see exactly after a couple of weeks, reassure the patient, keep up the patient on an enzymatic preparation. Go in for a couple of weeks, you will see that it does reduce in size. If it does not, then it requires, under strict aseptic precautions, one aspiration can be tried. That is the line which we are trying to do, and that is which is supposed to be done. 1, 2. In regard to the mesh fixation, again, it is the personal preference, I would say, that whether you want to use the tackers or not, because again, using tackers has its own potential pros and cons. But what is required out here is, we do not place the tacker to fix the mesh. It is, or to reduce the chances of seroma. It is only once 2 meshes are going to be there, there is no harm in placing musculo-opineurotic tackers. Not on the bone, not on the nerves, musculo-opineurotic, only 2-point fixation of that large mesh. As far as the area of dissection is concerned, I would not rate that the area of dissection is more. There is some known as boundaries of dissection. And every hernia, no matter whether it is done by me or by you as the initial one, area of the dissection remains the same no matter who does it. So I hope we are clear about that as far as PGs are concerned, and as far the port positions, it is always extended, means we are just going in for the panoramic view. It is midway between the rectus. So that rectus, rather than saying muscle, we say that in adult human Indian population, 7.5 centimeters is the area from the midline up to the linea seminolaris on either of the sides. So if it is 7.5, 7 centimeters, we try to stay something around 3.5 to 4 centimeters from the midline. And if you go over there, you will 100% enter into the retromuscular plane, and you will be safe and sound, away from any trauma to the peritoneum or away from any of the trauma to the lateral neurovascular bundle. Yeah. Yeah. Always, whenever we place any kind of tatters or sutures, we are supposed to remain above the iliopubic tract. In other words, only above the level of the pubic ramus, and have a straight line from the pubic ramus laterally. We need to put any tatters or sutures above it, not on the pubic ramus. We need to stay maybe a couple of millimeters anterior to it or proximal to it. And similarly, on the lateral side, you need to be in the transversus abdominis muscle, belly, not lower down. So something known as, for the technical part, above the iliopubic tract has to be there. And once you are above it, no chances of any osteitis pubis, no chances of nerve entrapment, and your mesh is going to be, and patient also will feel less pain as well. Right? Thank you. Wonderful tooth.
Thank you, sir. I would like to request Dr. Sanjeev Kumar, sir, to please felicitate Dr. Rudramani, sir. I request Dr. Madhubala, ma'am. Dr. Madhubala, ma'am, to please felicitate Dr. Sanjeev Kumar, sir. Dr. Anurag Vijaywan, sir. Please felicitate Dr. Sachin Yadav, sir.
I request for paper and poster presentation. Please submit the PPTs to Dr. Teja and Dr. Shubham Gaur. Now moving ahead to our next seminar. Wound management by a surgeon is like mastering the craft, which embraces the patient's future. So our next session is by Dr. Harinder Sandhu sir on recent advances in diabetic wound healing. He is an associate professor in Department of General Surgery at HIMS Dehradun. The chair of the session will be Dr. Madhubala ma'am and Dr. Mohammad Aslam sir. Both are the pioneers in the field of surgery.
Respected chairpersons and colleagues and my seniors, and I bring greetings from Himalayan Institute of Medical Sciences, Dehradun, and I thank the organizing committee for conducting this program and consistently organizing this program year by year. So I have been allotted the topic of recent advances in diabetic wound healing technologies and treatment. So coming up on the topic, now we have changed from the passive dressings to the bioactive and intelligent systems. So which will include different types of technologies. So the learning objectives is the complex pathophysiology of diabetic wound ulcer. So we just deal with the biological system. We are not dealing with the molecular level, but what is acting at what is being done at the molecular level. So we should, and the another is the biofilm, which is an invisible fortress, which is developed on that diabetic wound by extracellular polymeric substance. And the other, which we'll be discussing, is the recent advances. What are the recent advances? So why the diabetic foot? Causes of diabetic foot. Diabetic foot is due to the vasculopathy, due to low vascular supply in the blood tissue, and the neuropathy, the altered biomechanics. So I now want to precise why diabetic wounds heal poorly. Why the wound of a diabetic is at stall. See, the key mechanism is microvascular disease, the peripheral neuropathy, and there is a persistent inflammation, decrease impaired angiogenesis, and there is a decrease in the reduced growth factors. And I have already told there is an infection and biofilm formation by the extracellular polymeric substance. And the high glucose levels leads to the advanced glycosylation and products which impair the cellular repair and regeneration. So the vasculopathy causes the tissue hypoxia and impaired perfusion. The neuropathy disturbs the sensory, motor, and autonomous neuropathy, and the infection causes the abscess, gangrene, osteomyelitis, septicemia, and the poor metabolic control causes the tissue hyperglycemia, and the altered food biomechanics, and the poor local immunity, easy friability, and dry and poor skin barrier. And the patient factor are also there. There is the adherence, reluctance, recurrence, poor local immune system, poor immune system. So coming up to the phase of wound healing, already we know the hemostasis, inflammation, proliferation, and remodeling. And what happens in diabetes in the wound healing process, there is a prolonged phase of inflammation, and there is a reduced fibroblast activity, and there is an impaired collagen synthesis in the diabetic wound healing. So already in the diabetic wound, we have an extended inflammation and fibrosis period, and that leads to delayed healing. So coming up to what are the therapies, which are the modalities which can be used in diabetic wound healing? First is the negative pressure wound therapy. We also call it the vacuum assisted closure. And what happens, it removes the exudate, it reduces the edema, and improves the perfusion, and it increases stimulates the granulation tissue, which leads to faster wound healing. So a patient with diabetic foot ulcer, if we apply a negative pressure wound therapy, it will decrease, as already in diabetic foot, there is an increase in oxidative stress, and it will decrease the oxidative stress, and it will promote the wound healing. So there is a decrease in the oxidative stress, increase in the proliferation, increased migration, and decreased apoptosis, which will lead to a good wound healing bed. So what are the evidences in favor of negative pressure wound therapy? Already there are various meta-analysis of 11 RCTs, which shows there is a high healing rate as compared to the conventional dressings. And the other is we have a reduced amputation risk if we apply a negative pressure wound therapy. And negative pressure wound therapy increases granulation tissue formation via vascular endothelial growth factor pathway. So this is already we have a negative pressure wound therapy already displayed in the. So this is a vacuum dressing which is applied to the wound, and it sucks the edema and decreases the edema. So coming up to the next therapy is the hyperbaric oxygen therapy, in which the patient is placed in a chamber in which he breathes the 100% oxygen at around 2 to 2.5 atmospheric pressure, and it will enhance the oxygen delivery to the tissue, and it will promote angiogenesis, improve the leukocyte function, and stimulate the collagen synthesis. So there are also RCTs which have showed hyperbaric oxygen therapy increases the higher wound healing rates, better granulation tissue formation, and 63% healing rate, better healing rates with hyperbaric oxygen therapy as compared to the controls in trials. So now coming up to the topical oxygen therapy, in which already the diabetic foot ulcer is at hypoxic state. So we have a topical oxygen therapy. We apply the device of topical oxygen therapy on the wound, and it delivers the oxygen locally. So it is a continuous oxygen. It has different types of topical oxygen therapies, in which we deliver continuous oxygen therapy or cyclical topical oxygen therapy, and it also improves the local oxygen tension. As already the diabetic foot is an hypoxic state, so it increases the oxygen tension, and it enhances the epithelialization. So now coming up to the growth factors. Now growth factors, we can have the platelet-rich plasma, the own plasma taken by the platelet-rich plasma of the patient's own plasma, and it includes the important growth factors, the platelet-derived growth factor, vascular endothelial growth factor, endothelial growth factor, fibroblast growth factor, and it stimulates angiogenesis. And fibroblast proliferation increased, and collagen synthesis is enhanced. So these are the platelet-derived growth factor. It also stimulates the mechanism of stimulate the fibroblast proliferation and accelerate the wound closure. Now coming up to the stem cell therapy. The stem cell therapy, and it includes the mesenchymal stem cells, and which are bone marrow stem cells, bone marrow derived stem cells, adipose derived stem cells, and it also, the same mechanism is it promote angiogenesis, it reduce inflammation and stimulate the tissue regeneration. So we can see that on the diagram, the mesenchymal stem cells, and they can be derived from bone marrow, adipose tissue, or can be derived from a placenta or by the umbilical cord. And there are different types of growth factors like vascular endothelial growth factor, fibroblast growth factor, and it macrophage. This is the important. This is the molecular pathology. The macrophages polarization. It increases the fibroblast proliferation, keratinocyte proliferation, and endothelial cell proliferation, which will heal the diabetic foot ulcer. So there are, now we have bioengineered skin substitute like dermal substitutes, artificial skin grafts, like we have a dermal matrix, dermal collagen matrix, and it can provide the extracellular matrix scaffold and promote the epithelialization. So there can be epigraft. These are the examples of the bioengineered skin graft like dermagraft, dermal collagen matrix, and these are used in chronic non-healing ulcers. So this is a nanotechnology in wound care. The nanotechnology, these are the nanofiber dressings. These are silver nanoparticles. These are drug-loaded nanoparticles. And it has also, first of all, it's an antimicrobial activity, and it is delivering the, delivering the drug in a controlled drug delivery form. So now come up with the hydrogel dressings. We have hydrogels, and this is very important in a diabetic foot ulcer. We should have a moist wound healing. There should be a moist wound healing. This is the concept of moist wound healing. So if the hydrogel, they have maintains the moist environment, it delivers the drugs or growth factors, and it promotes the angiogenesis. And hydrogel can also release the therapeutic agents on demand and occupies the wound microenvironment. So there are now we have extracorporeal shockwave therapy and the low laser therapy. These are used on the wound, and they have acoustic base and they also stimulate the healing. And by the mechanism is they promote the angiogenesis and reduce the inflammation and stimulate tissue regeneration. And trials have showed that there is an improved healing rates in the chronic ulcers. So now we have a gene therapy also. There are target genes which can be involved in wound healing. The vascular endothelial growth factor, which can be injected into the diabetic foot wound, and this can also improve angiogenesis and accelerate the tissue regeneration. Now we have smart wound dressings. The smart wound dressings, the sensor-based dressings, and the infection detection and the moisture monitoring dressings have been there, and it will detect how much what the pH is and what is the infection control. Bioburden is what is the bioburden, and that can be we can manage accordingly, and we can apply that smart wound dressings. So now there is a concept of artificial intelligence in wound healing, and now the artificial intelligence can classify the wound type, what type of wound it is, how it is monitoring how the monitoring of wound healing is there, and it can predict how the treatment outcome can be there. So now the change of concept is from the conventional diabetic foot ulcer management to the modern diabetic foot ulcer treatment. First of all, it's a multidisciplinary approach, and I would like to approach the general surgeon is the architect of the wound healing bed. If he is not having the knowledge of the molecular level, he will not be able to have a good wound healing bed. So first of all, there is a multidisciplinary approach. One should have a good glycemic control, and the surgical debridement still remains the gold standard. And the offloading of the wound, has to be done, and the infection control has to be done, and the advanced therapies can be used as adjunct therapies to the diabetic already established conventional wound therapy. These are not the recommended, but these have to be used as an adjunct for accelerating the wound healing and to prevent the amputation. The aim is to prevent amputation. So the treatment protocol, as I have already stated, it is the standard care which has already been we are using the debridement, the surgical debridement, infection control, offloading, and the advanced therapies has to be used, which have already been discussed, like negative pressure wound therapy, hyperbaric oxygen therapy, the biologics, the stem cells therapy, which can be used, and the hydrogels which can be used, and we can accelerate the wound healing. So these are the various modalities which have been used in wound healing. So what are the future therapies? Which are the future therapies? Are the 3D bioprinting, skin grafts, stem cell, gene editing, and regenerative medicine. So the conclusion is recent advances in regenerative medicine and wound healing technology have significantly improved the outcomes in diabetic wound healing and reducing the amputation rate and improving the quality of life. So the take-home message is we should have a good understanding of complex micropathophysiciology of diabetic wound. We should have conventional dressings. What is the disadvantage of the conventional dressing is conventional dressings fail in the molecular level. It is good at the biological level, but it fail at the molecular level. What is happening at the molecular level, which I have already explained, this is not able to explain me. And the emerging therapies are the negative pressure wound therapy, hyperbaric oxygen therapy, stem cells, tissue engineering, and the nanotechnology and the multidisciplinary care. Multidisciplinary care, we have to have a vascular surgeon which can vascularize the vascularity. We can then have a good plastic surgeon which can have good grafting and then can prevent the amputation rates. And the aim has to be to prevent amputation. Thank you.
Thank you, Dr. This was a very nice talk. Regarding the healing of any wound, one should thoroughly know the all phases of wound healing. And one important phase is formation of healthy granulation tissue. So this formation of healthy granulation tissue requires adequate blood circulation and infection control both. So I think whatever these high-five dressings we are using, we should always augment these dressings along with medical drugs, which are improving peripheral circulation, decreasing viscosity of the blood. Not only diabetic ulcer, but any non-diabetic ulcer due to varicose vein or arterial disease. One should add those drugs in the treatment.
Sure.
And one of the most commonly used drugs is silestrazole, which increases the viscosity of the blood, improves peripheral circulation. And along with this, one should use low-dose aspirin.
Yes, sir.
Thank you.
Any role of vascular intervention or after vascular intervention, any role of feedback?
So vascular intervention has a role in, because I have already said that there is a vasculopathy. So there is a decrease in blood supply in the wound. So if we have a good vascular surgeon which can vascularize the system or can put a stent, then definitely the wound healing enhance wound healing.
Don't have much pressure area.
Yes, sir. And that is the role of offloading also. We have to offload the wound. If we are not offloading the wound healing will not be in a proper.
Any role of nerve decompression, role of peripheral nerve decompression, posterior tibial nerve, common parietal nerve, anterior nerve, any role helps.
So low end. No ends.
How it helps discussion.
It's still in the trial. Yes.
So role of
Nerve decompression.
Sensation. It promotes the wound healing. So this is a new concept from plastic surgical part. Any question?
I think diabetes, the underlying pathogenesis is
Yes.
peripheral neuropathy.
Yes.
And this neuropathy is due to ischemia to the nerve.
Yes, sir.
So decompression.
Decompression neurotomy, decompression
Rather than
neurotomy.
decompression, it should be increase the
Vascular.
What about the shock wave therapy?
Sir, it is a low laser with low laser. We are using low laser. We just apply on the accelerate the wound therapy, and that it accelerates the wound healing. Sir,
How many time is it done per week or days? How is it?
Sir, cycles of laser therapy, sir. They
shock wave therapy.
Yes. So we after 2 weekly, bi-weekly, 2 weekly, we are using it. Sir, we can use it. Which are still in the trials, sir. These are trials.
What are the results? I just wanted to ask you about the results.
Sir, in some of the studies, these are shown that it is a good. It heals. It accelerates the wound healing. So these are all adjunctive therapies, these are all adjunctive therapies which can accelerate the wound healing. But still, the international wound guidelines in diabetic foot ulcer management still have the says about the conventional therapy, but these can be used in adjunct therapy to accelerate the wound healing and to prevent the amputation risk.
Many of these don't have a big evidence actually.
Yes.
Giving ozone therapy is being widely used.
Topical oxygen ozone therapy.
Yes. Said to be in a few series, but they
Large trials are not there, but costly therapies. These are the costly therapies also too.
Maybe the mic is not working. I will just raise my voice. But one thing has to be clear among the residents. Diabetic foot is not caused from outside. It is a wound which starts from inside the body.
It is a systemic failure, sir.
Yes. So you need to focus on the inside pathology first. Outside, only one thing is there, which is mandatory, that is offloading. Offloading and the correction of the proper pressure points. These two things, rest all will be an adjunct. But if you focus on the adjuncts, to focus on how the things are improving, things will come back again, rather in a much worse manner if you do not focus from inside. So what you see that's why it has been taken to be as tip of the iceberg, what you see as a diabetic foot. To focus more on inside, that why did it start to happen. That's why that idea about diabetic foot care is more important rather than changing only the medications. Thank you.
Thank you, sir. I request Dr. Mohammed Aslam, sir, to please felicitate Dr. Hernia Sandhu, sir. I request Dr. Vikas Singh, sir, to please felicitate Dr. Madhubala Gauna. I request Dr. Vikas Singh, sir, to please felicitate Dr. I request Dr. M.K. Maheshwari, sir, to please felicitate Dr. Mohammed Aslam Khan, sir.
Students for paper and poster presentation, please submit the PPT to Dr. Teja or Dr. Shubham Gaur, or either mail it to Subharti Surgery Update @gmail.com. So there is one disease in which it is difficult to decide when to operate and when not to operate. Superior judgment supersedes the need for superior skills. Yes, we are talking about tuberculosis, and that too abdominal tuberculosis. So a session by speaker Dr. Dheeraj Balyan sir, Professor General Surgery, LLRM Medical College. This session will be chaired by Dr. Vikas Singh sir, Dr. Amit Agarwal sir, and Dr. Arun Kumar sir. I hand over the mic to Dr. Dheeraj Balyan sir.
Very good afternoon. वैसे तो सब एडवांस टॉक्स चल रहे थे डॉक्टर ICG विकास बोस और bilateral E-TAP, then Sandhu with recent advances in diabetic foot management. So it might be some bogus topic according to the standard of conference. But this is very common, and as we are dealing in the resource poor country we are, and we are having a good number of all these cases in the public as well as private sector. So have to be very careful in practice, and very importantly said by Dr. Rishi Bhatia and Maulik, consent taken, consent किसको कब ऑपरेट करना है, कौन सा इन्वेस्टिगेशन कराना है, आप उठा के पूरी बैटरी ऑफ इन्वेस्टिगेशन लिख देते हैं. तो ये सब चीजें जरूरी है, खासतौर से ऐसे केसेज में. अभी मैं आपको अपना एक छोटा एक्सपीरियंस बता दूं कि एक्चुअली स्वेलिंग का पेशेंट आया 3 महीने पहले मेरे पास. उनको मैंने पहले से एडवाइस किया कि भाई ठीक है आप दवाई ले लीजिएगा. फिर उसने FNAC कराया और फिर मुझे ना दिखा के कहीं दूसरे डॉक्टर को कंसल्ट किया और उसमें कुछ स्प्रेड सेल क्वेरी करके उसने भेज दिया. बट फिर किसी डॉक्टर ने देखा, उन्होंने उसको ATT चला. ATT चलती रही 3 महीने. फिर मेरे पास आया दोबारा, मैंने कहा बायोप्सी कर देते हैं इसकी तो कंफर्म हो जाएगा. एंड हैपेंड टू बी इन्वेजिव इंट्राडक्टल कार्सिनोमा ब्रेस्ट इन मेल पेशेंट.
बस है कि सोब्राइटी और 3 महीने तक उसका कोई ज़्यादा एडवांसमेंट नहीं होता, फिर पूरा उसका ऑक्सीजन एंड क्लियरेंस एंड फॉलोड बाय केमोथेरेपी दिया गया। तो ADT का मिसयूज और ना यूज दोनों का दोनों ही चलता रहता है बिकॉज ऑफ पूर एक्सपीरियंस और ये डेफिनेशन वाइज abdominal tuberculosis whole GIT को इन्फेक्ट करता है, esophagus, stomach 1-2% and colorectal and less than 5%, but especially involving this small gut because of the abundance of lymphoid there. Peritoneum, momentum, solid organs like spleen, and every organ can be infected with tuberculosis in body, but in lungs and intestine more important. Tuberculosis is major health problem. 7 to 10 million new cases are recorded annually and 66% of death worldwide, despite development of this well-developed ATTs. After tuberculosis, common extrapulmonary manifestation of tuberculosis in non-HIV patients is 10 to 15%, and in HIV-infected patients, 50% patients have extrapulmonary manifestations of tuberculosis. Global burden of TB nearly 20 million cases. India has one of the world's largest TB load, around 26% of world tuberculosis cases, and estimated 0.6 million, 5 lakh around new cases of MDR TB worldwide in 2020, of which 50%, more than 50% are in India itself. Estimated incidence of TB in India was 2.7 million in 2022. The life risk of developing TB in healthy individuals is 5 to 10%, which increases in presence of coexisting HIV, undernutrition, and diabetes. That is very prevalent and very rampant in our country. Burden of TB in India is 22.6% of population over 15 years of age, and 36.8% in Vietnam, 36 Southeast Asia, 24 in China, 9.1% in Saudi Arabia, and 4.8% in US. And worldwide, TB is very common, not so uncommon in Europe or the United States. It's also there. Males are more likely to be affected with TB, and incidence increases, prevalence increases with age. The contact and use of public transport leading to increased exposure. States with the high TB infection rates include Delhi, you can say Meerut, Telangana, Uttar Pradesh, Punjab, Chandigarh, and Karnataka. Annual risk of TB more in urban areas compared to rural, and individuals with past history of TB are more likely to have a TB infection. Smoking and alcohol use are not to be associated with TB infection. And GITB, autopsy of patients with pulmonary tuberculosis presenting pre-antibiotic area was showing intestinal involvement up to 90% of it. In current area, it's around 15 to 20%. Extrapulmonary is affecting the intestines. In many resource-poor settings, the diagnosis, treatment, and reporting of infectious pulmonary disease take priority over that of the extrapulmonary disease. Limited access to diagnostic procedure precludes the confirmation of GITB. With those limitations in mind, the available data shows that the epidemiology of GITB varies widely across the world. GITB is predominantly reported as a disease of young adult, especially female, with mean age in the late third of early fourth decade. The gender profile varies, with India and Pakistan describing a female predominance, while Saudi Arabia and UK have an equal gender distribution. Majority of cultural confirmed GITB cases are caused by Mycobacterium tuberculosis. Zoonotic tuberculosis caused by Mycobacterium bovis still causes a significant proportion of disease. These are pathogenesis, Mycobacterium being presented with this alveolar macrophages, then unchecked bacillary proliferation lead to bacterium to multiple sites in the basic root of this extrapulmonary manifestation. These are the pathogenesis, actually molecular level, interleukin 2, interferon gamma, then tubercular sensitivity. Although this tubercular positivity Montuque test with ulcerated form is very much important in diagnostic. Otherwise, they are very non-specific. And any granulomatous disease in India is tuberculosis until proved otherwise. कई बार आपको नहीं मिलेंगी giant cells और culture भी positive ना है, but granuloma is there. It is tuberculosis until proved otherwise in Indian setting. Route of transmission is ingestion of contaminated milk or food, hematogenous spread by active pulmonary tuberculosis infection, solid sputum, direct spread from adjacent organ or retrograde spread from female genitals mainly affect the peritoneum and mesenteric nodes, and through lymphatic channels from infected nodes. Mycobacterium tuberculosis may infect the GIT via ingestion of bacilli in sputum from a focus in lung, lymphatics or hematogenous spread from active tuberculosis focus cells in the body, direct spread from adjacent organ or ingestion of contaminated dairy product on the repeat organ. By bovis is transmitted primarily by ingestion of the unpasteurized milk. अब pasteurization वाला milk आने लगा ज़्यादा तो इसका incidence भी उसका accordingly कम है. And can also be transmitted by inhalation of airborne particles from animal to human and rarely from human to human. The tendency of GITB to localize to the ileocecal region of the intestine is thought to be due to a बड़ा common question पूछा जाता है वाइवा में पीजी से कि ileocecal region में ही क्यों होता है? Because of abundance of the pia species there and low peristaltic activity, alkaline pH, presence of ileocecal wall stasis leading to accumulation of this bacterial concentration there in ileocecal region, and that's why it's affecting more in this area. Less peristalsis in ileocecal region than gastroduodenal area. वहाँ पर रुक जाता है सब जाकर तो अब incidence उस area की ज़्यादा होती है. The higher density of gut acidity impaired is already talked. When Mycobacterium bacilli are ingested either in sputum or in contaminated food products, they are entry into intestinal mucosa generated by macrophage which phagocytose bacilli. This is a picture of molecular basis or pathogenesis from the entry of bacilli into mucosa of the GIT, granuloma in submucosa, then caseation necrosis and spreading to deeper layers of intestine may form fibrosis or fibrotic mass in well healthy individual or may lead to ulcer formation in poorly fed or poorly nutrition जो पेशेंट्स होते हैं उनमें ज़्यादातर परफोरेशन हो जाता है जो आप तौर पे हम इमरजेंसी हम लोगों को डील करना होता है. Clinical presentation is abdominal pain mostly and weight loss, fever, night sweats, nausea, vomiting if there is obstruction and change in bowel habits up to 50% of the cases. And types of these tuberculosis in intestine is esophagus, gastric, colonic मैं बता चुका हूँ already, but more you see ulcerative, hyperplastic and strictures in intestine. So small intestine tuberculosis, 1/3 to half of patients with intestinal tuberculosis have involvement of a small bowel, abdominal pain, nausea, vomiting, abdominal distension, fever are the most common presentation. In cohort with GITB, presenting as an acute surgical abdomen, small bowel stricture accounts for half of the presentation of abdominal tuberculosis. The ileocecal area is most common site of with up to 80% of patients with intestinal tuberculosis having involvement of this site. The most frequent presenting complaint is abdominal pain again, which may be generalized or localized. Vomiting, weight loss, and diarrhea are also present in half of the patients. 20-25% of patients an abdominal mass is palpable in right lower quadrant, which can be mistaken for a malignant mass or an appendicular abscess. Predisposing factors are basically in this area are stasis of food, abundance of lymphatic tissues, and high absorption rate in this area. These are the transverse ulcers in the cecal area, and in ileocecal region again fibers in the secondary structure formation and leading to most likely obstruction in these cases. Ulcer is the most common form. Ulcers are caused by rupture of submucosa. In the cases lymph node transverse ulcers are present in tuberculosis, common in old age and malnourished people because of the poor immunity. Long-standing ulcer cause fibrosis and later stricture formation. Bowel adhesions are also common, and patient mainly presents with pain, diarrhea, blood in the stool, loss of appetite, and reduced weight. I think this is the progression of disease. With minor ulcer will not be detected. Ulcer disease will go unnoticed and untreated. The ulcer, coalition of ulcer, then leading to submucosal perforation and then cirrhosis up to the full perforation and leading to perforation peritonitis. Those cases are presenting in emergency. Hypertrophy when the organism is less virulent, seen in young, well-nourished individual. Fibroblast reaction in submucosa and subserosa causes thickening of the small bowel wall and lymph node enlargement, leading to nodular mass formation. It causes extensive chronic inflammation, fibrosis, and bowel adhesion, nodal enlargement, often presents with mass in right iliac fossa. When present as a mass, it can cause subacute intestinal obstruction. सायो बोलते रहते हैं हम लोग कि सायो है. Commonly seen in primary tuberculosis, like ingestion of this. Here are the pictures of the ileocecal and mesenteric tuberculosis and ileocecal tubercular mesenteric lymphocyte presenting as mass in right iliac fossa. In late phase, when ulcer heals by fibrosis in response to ATT or host immunity, it presents usually with features of intestinal obstruction, colic abdominal pain, abdominal distension, recurrent vomiting. Bowel adhesions and secondary infections are quite common. Perforation, 5%, though rare, may lead to peritonitis in the structural form of this intestinal tuberculosis. Peritoneal tuberculosis is most commonly affected in abdominal. Peritoneum is mostly affected in abdominal TB, more frequent in third to fourth decade of life, and females are more commonly affected. Other modes of because of this fallopian tube transmission, other modes of spread in female is hematogenous and lymphatics. Pathology in peritoneal tuberculosis is enormous thickening of parietal peritoneum with multiple tiny yellowish tubercles. Dense adhesions in peritoneum and omentum with content inside as a bowel looking like abdominal cocoon. Very common finding in emergency. A surgeon or GI surgeon, I think 3 or 4 months बाद एक बार देख ही लेते हैं cocoon formation in case of intestinal obstruction. तो कुछ करने को होता नहीं है उस टाइम. Multiple dense adhesions between bowel loops and between bowel and peritoneum and omentum lead to this cocoon formation. These are the pictures. Manifestations of this peritoneal tuberculosis may be acute or chronic. Chronic in the form of fat type like ascitic, plastic, fibrous and adhesive type, and purulent type. Acute type mimics acute abdomen, presents with features of peritonitis is due to perforation of rupture of this mesenteric tubercular lymph nodes. Ascitic or wet type is the distance of abdomen with dilated distension of abdomen with dilated veins in the parietal wall, the abdominal wall. Ascitic type reveals a stroke-like fluid from which AFP can be isolated. If we can hold this fluid for 3 to 4 hours, a scab और बन जाता है उसके अंदर, वो दिखता है white सा बना हुआ, वो एक diagnostic feature हो जाता है. With the experience, we can say the fluid of tuberculosis. Fluid is pale, clear, rich in lymphocytes and reveals increased protein content. This is plastic type, widespread adhesion, recurrent colic pain is the and diarrhea, wasting and loss of weight, mass abdomen and doughy feel abdomen. Differential diagnosis is always peritoneal carcinomatosis. And the purulent form is invariably due to tuberculous salpingitis. Presents as a mass in lower abdomen, containing pus, omentum, fallopian tube, and a small and large wall. Abscess gets adherent to abdominal wall, umbilicus, and may form an umbilical fistula. Patient commonly has got genitourinary tuberculosis. Then tuberculosis of mesenteric lymph nodes. Infection is usually through Pierce patches. Presents with generalized symptoms with pain in umbilical region, right iliac fossa and mass in right iliac fossa, or features of acute appendicitis. Often, wells of intestine get adherent to cagated this mesenteric lymph node, leading to intestinal obstruction. So cageating material may collect between layers of mesentery forming an abscess, and is called pseudo-mesenteric cyst. Massive enlargement of mesenteric lymph node due to tuberculosis also called tabes mesenterica. More common in children, presents with anemia, fever, loss of appetite, reduced weight, failure to thrive, palpable mass in right iliac fossa, which is firm and nodular. The tuberculosis of omentum, it usually occurs as a part of the other types of the abdominal tuberculosis. Rolled up omentum with thickening is characteristic. So these are the story of the presentation or what's happening with tuberculosis in abdomen, peritoneum, omentum, small bowel, mesenteric lymph nodes, everything is affected. And mostly there is a basically mixed presentation of these things. Isolated is very rare. If we are having omentum, then mesenteric lymph node is involved. The mesenteric lymph node is there, then small bowel, mucosal patches, submucosal patches, and going to these lymph nodes. So very common disease with a large number of differential diagnoses like tuberous mass, appendicitis, appendiceal carcinomatosis, primary carcinomatosis of peritoneum. So have to be very careful in evaluation of these entities. Investigation wise, hematological are non-specific, but with long durational illness lead to anemia, ESR, and raised TLC. Radiological has most of the time affected the pulmonary tuberculosis, so we have to rule out this pulmonary TB with chest X-ray and plain X-ray of abdomen just to evaluate the obstruction or perforation to show the gas under diaphragm. But now with the upcoming of the availability or cost effectivity of the CECT, so most of the time we are going towards CT scan with all parameters normal like urea and creatinine. So not wasting too much of time, we are getting good reports in CT. And CT के web slides 128 64 कितने होने लगे तो बहुत जल्दी we can pick up all these things. And बड़ा चक्कर ये है कि इसका कल्चर वाइज एंड FNAC में भी इसका सेंसिटिविटी बड़ी पुअर होती है, 3% के आसपास आता है अगर हम ये कराते हैं FNAC जैसे मोन्टुक टेस्ट. मोन्टुक्स इतना रिप्रोड्यूसिबल नहीं है कि आप किसी का पॉजिटिव आ गया तो आप उसको टीबी घोषित करके चला दीजिए. वेरी नॉन स्पेसिफिक बट अल्सरेटेड फॉर्म ऑफ दिस मोन्टुक्स टेस्ट इज वेरी सेंसिटिव एंड लीड टू diagnostic. The T-spot, TB test, and TB Gold, these are basically NTPC, National Tuberculosis Elimination Program, उनको support नहीं करता, but recent advances में आया है और लोग अपनी मर्जी से भी करा के आपके पास आ जाते हैं. This is this PCR is of diagnostic value and is also recommended by NTPC. Major limitations of this test is it give no drug susceptibility information, require QH10 bacilli from a given sample, especially 98 to 99%. Radiological access सभी को पता है कि gas under diaphragm and bowel descended bowel loops or air fluid level more than 3 are diagnostic of obstruction, and gas under diaphragm, this is suggestive of perforation. Then calcified lymph nodes and barium. With the advent of this upsurge of CT scan, barium studies are doing very less, but some academic values like hourglass stenosis and inverted umbrella or Lessner signs, they are usually asked in Viva with all teachers. जो हमारे मतलब सीनियर्स लोग थे रिटायर हो गए, अब उनके टाइम पे सीटी इतना नहीं था तो वो एक्सेस ही और बेरियम मील से ही डायग्नोसिस ज़्यादातर बनाते रेडियोलॉजिकल, तो पूछते हैं सब चीज़ें. और MCQs में बड़ा कॉमन क्वेश्चन होता है सर. Good neck deformity like with retracted fibrous cecum and dilated terminal area. Sterling sign, having of barium due to rapid flow and lack of barium in inflamed segment due to incompetent ileocecal wall. Hold up cecum, very common finding. जब आप ऑपरेट भी करते हैं तो सिकम हमेशा ट्यूबरकुलोसिस केस में आपको ऊपर ही मिलेगा, होल्ड अप मिलेगा, कॉन्ट्रैक्टेड बाउल भी इतना छोटी सी हो जाती है असेंडिंग कॉलन. So these are some findings. Then ultrasound features of the abdominal tuberculosis. Ultrasound is not so much of importance when small bowel is basically concerned. Now the perforation and obstruction by distended bowel loops and localized ascites and interloop ascites with alternate echogenic and echo-free area, the club sandwich appearance. CT scan and so mass, bowel wall, perforation and breakage, all these findings can be detected and diagnosed with CT scan. Circumferential bowel wall thickening, thickened peritoneum, ileocecal wall thickening, enlarged, necrosed, matted these mesenteric nodes, open with cold abscess, peripheral lip enhancement, typical of tuberculosis, and adhesions, and mesenteric thickening and nodules. All these findings, I think, सारी सी मिलती है जब tuberculosis abdomen का देखते हैं, but may mimic with carcinomatous lymphoma. They also have necrosis in the center of the lymph nodes and matted lymph nodes, but यहीं पे थोड़ा होता है कि कार्सिनोमेटोसिस है या लिम्फोमा है या फिर ट्यूबरकुलोसिस है. हिस्ट्री है, पल्मोनरी आपको मिल जाती है विद अदरवाइज बेस्ट इन्वेस्टिगेशन जो हम लोग सोचते हैं और अपना करते भी हैं, दैट इज डायग्नोस्टिक लैप्रोस्कोपी. वही सर का जो मेरे दिमाग में सबसे है वो कंसेंट ही घुसी हुई है कि कितना कंसेंट को लेकर हम लोग कैजुअल रहते हैं. मरीज से कंसेंट लेना तो बहुत ही कम होता है, ब्लैंक पेपर में साइन हो जाते हैं घर वालों को. कंसेंट लेने के बाद डायग्नोस्टिक लैप्रोस्कोप बिकॉज इज इन्वेजिव टेस्ट भी होगा और उसके साथ आप प्रोसीड भी करेंगे. ओटी लिस्ट में यही डाल दिया डायग्नोस्टिक लैप्रोस्कोपी एंड प्रोसीड. और उस प्रोसीड का साथ ना तो मरीज के घर वालों को पता होता है ना मरीज को पता होता है कि प्रोसीड क्या करें. तो ये कंसेंट लेने के बाद बेस्ट टेस्ट जो मुझे लगता है, तो मेरा मतलब मानना भी है, और दैट इज ये डायग्नोस्टिक है. आप वहां से पेरिटोनियम स्ट्रिप ले लेंगे, नोड्यूल दिखाई देंगे, लिम्फ नोड बड़े हुए दिखाई देंगे, सब कुछ आपको सामने मिलेगा और प्रूव होते ही फिर दिक्कत भी नहीं. अदरवाइज बहुत बार एटीटी का मिसयूज होता है कि चलो ठीक है ट्यूबरकुलोसिस की दवाई खिला दीजिए और किसी को फायदा मिलता है किसी को नहीं मिलता है. सो CCT देन इफ यू कैन डू, मरीज हो जाता, कोई ज़्यादा कॉस्ट भी नहीं है, रिस्क भी इतना नहीं है, डायग्नोस्टिक लैब कर सकते हैं. टेकन बाई फॉलोड बाई प्रोसीड में हो सकता है आपका बायोप्सी और आपको लगता है स्ट्रक्चर फॉर्मेशन है, कैन बी टेकन वेरी वेल विद लैप्रोस्कोपी. हर एक सर्जरी सभी लोग करते हैं तो कैन बी फ्लूइड का टैप कर सकते हैं. एनासाइटिक फ्लूइड abdominal tuberculosis is more than 2.5 gram protein level, SAG less than 1.1, lymphocyte predominance with counts as high as more than 4,000 per millimeter, AFB less than 3% केसेज में मिलेगा, ADA बढ़ा हुआ मिलेगा less than more than 95% and 98% sensitivity, specific gravity of more than 1.016, glucose less than 30, decreased pH and LDH more than 90 units per liter in ascitic fluid. Some there are Fluorescence criteria for diagnosis of GTB. Histology of specimen obtained by surgery or endoscopy shows tubercle with caseation. Operative findings suggestive of tuberculosis like stricture or transverse ulcer and fibrotic reactions there. Tissue positive for AFP staining and tissue culture reveals mycobacterium. Culture भी बहुत कम केसेज में आता है, 30% के आसपास. तो एक भी क्राइटेरियन में होगा तो we can start ATT. Then Logan modified this posture criteria and used response to ATT as a criteria to establish the diagnosis. These criteria hold true in present time. New investigative modality have enabled to establish the diagnosis almost all patients. Treatment कोई 5 ड्रग वाला, isoniazid, rifampicin, thambutol, pyrazinamide, streptomycin 2 months intensive phase and continuous phase for 6 months. In GITB usually 6 to 9 months का treatment WHO recommend करता है. Second line drugs are amikacin, cannabisin, then paraaminosalicic acid, ciprofloxacin, Oflox, Levop, clarithromycin, azithromycin, and rifabutin. In drug resistant cases, second line drugs are added. And use of steroids in medial tuberculosis, tubercular meningitis, yeah, basically extrapulmonary and extra GI, some abdominal tuberculosis also to prevent adhesions. You can use steroids post-operative. Surgical management, intestinal obstruction, hemorrhage, acute abdominal presentation like perforation, intraabdominal abscess formation, fistula formation, and uncertain diagnosis. Principle is same as usual in surgery. Gastrointestinal drainage via nasogastric tube, fluid and electrolyte replacement, relief of obstruction. The segment include the management of segment at the site of obstruction, distended proximal bowel loop, underlying cause of obstruction. Most of the time क्या करता है कि infected रहता है तब लोग स्टोमा निकाल देते हैं. And स्टोमा निकालने के बाद usually जो रिवर्सल किया जाए, ये पीजी के लिए बोलता हूँ कि ATT चलाने के बाद उसका जब ATT पूरी हो, उसके बाद उसका रिवर्सल किया जाए. यूजुअली क्या होता है कि 2-3 महीने के बाद ATT चलाई और उसको बंद कर देते हैं स्टोमा. इसका दोबारा फिर चांस होने की, क्योंकि मरीज का पूरा ATT का कोर्स हो जाए तभी उसको बंद किया जाए, ना कि 2-3 महीने दवाई खाने के बाद ही उसको बंद. कई बार क्या हो, मरीज फिर ATT भी छोड़ देता है, डिफॉल्टर हो जाता है और उसके रिलैप्स के चांस बढ़ जाते हैं. Ileocecal resection with 5 cm margin, strictureplasty. Single stricture friable bowel or multiple stricture or stricture within 10 cm of ileocecal wall, resection and anastomosis. और जो हम लोग रेजिडेंसी में देखते भी हैं, मैं थोड़ा बता दूं कि पूरा मोबिलाइज करने के बजाय इलियोसेकल एरिया को जहां पे वो होता है उसी को खींचतानी करके बाहर निकालने की कोशिश करते हैं. ऑल रेजिडेंट्स प्लीज, कभी भी जब एलियल का परफोरेशन है, भले ये टाइफाइड है या ट्यूबरकुलर कुछ भी हो या स्ट्रक्चर फॉर्मेशन, उसको मोबिलाइज करना सीख लीजिए. एलियल तब असेंडिंग कोलन का मोबिलाइज जब तक नहीं करेंगे आप, तो जब स्टोमा देंगे एक तो उसका भी रिसीव करने के चांस है. दूसरा, अगर आरे करना है तो भी वहां पर आपको बाउल की लेंथ छोटी पड़ जाएगी, तो उसको पूरा मोबिलाइज करके देन स्टोमा को बाहर निकालिए और वो पूरा ATT का कोर्स करने के बाद ही उसको दोबारा स्टोमा का रिवर्सल करिए. डर्टी केस है ज्यादा तो स्टोमा देना है. अगर डर्टी नहीं है, लोकलाइज कलेक्शन है, पेशेंट हेल्दी है, तो आप प्राइमरी रिपेयर भी कर सकते हैं. बट सेफर साइड रहने के लिए ज्यादातर क्या पब्लिक हॉस्पिटल में, लाइक वी आर डीलिंग विद RML and KG and मेरठ एंड सुभारती भी ज्यादातर पब्लिक तो अपनी वैसी आती है, तो यही ठीक रहता है कि आप उसको वो कर दीजिए, स्टोमा दे दीजिए. मोस्ट ऑफ द टाइम सीनियर रेजिडेंट्स और जूनियर रेजिडेंट्स आर ऑपरेटिंग ऑल दीज इमरजेंसीज. तो टू बी ऑन सेफर साइड स्टोमा देके उसको बढ़िया न्यूट्रिशन दीजिए. बाद में जब ठीक हो जाए देन रिवर्सल ऑफ स्टोमा. Management of acute type of peritoneal tuberculosis include this experimental laparotomy and omental biopsy or peritoneum biopsy. There peritoneum tuberculosis are there, तो peritoneal tuberculosis की भी एक peritoneum की strip लेकर उसकी भी biopsy करें. Prognosis wise, up to 3/4 of the patients with GI/TB respond well to medical therapy alone. However, 10 to 15% of patients will develop partial bowel obstruction, 5 to 10% will develop complete bowel obstruction, and 4 to 7% will suffer bowel perforation. 2 to 3% will have GI bleeding that require intervention, and 1 to 2% will develop fistula formation. And key complete ATT, anti-tubercular treatment चलता रहेगा तो ज़्यादातर चीजें ठीक हो जाती हैं. In pediatric patient, the mortality rate is reported as 3 to 8%, being highest among those who present with intestinal perforation. In adults, the reported mortality rate ranges from 5 to 50%, with older age coexisting liver cirrhosis and delay of treatment being associated with a higher likelihood of this death. I think take-home message: abdominal tuberculosis need high suspicion to be diagnosed at an early stage. Any patient who has generalized ill health and altered bowel habits should arouse suspicion of intestinal tuberculosis. Early diagnosis avoids complications and unnecessary surgical intervention. Surgery is reserved for non-responders to medical management and in case of complications like hemorrhage, perforation, and bleeding. Resection of disease segment is preferred over conservative approach, and patients should be given complete course of ATT if medically managed. Thank you very much for listening.
Very nice presentation.
Thank you, sir.
Tuberculosis is very common in our center.
Yes, sir.
And it has a variety of presentation. And very, very difficult to diagnose. You have presented very well on the genital abdominal tuberculosis. But any comment about the genital urinary tuberculosis?
Genital urinary. Genital is basically bladder का और इसका इन्वॉल्वमेंट ज़्यादा रहता है एंड वो सर एटीटी का ही ऑलमोस्ट एटीटी का ही रोल आ जाता है, अदरवाइज उसमें कुछ ज़्यादा ये सब जो हमारे कॉम्प्लिकेशन जो एब्डोमिनल वाले रहते हैं उतना ज़्यादा नहीं होता, अर्जेंसी फ्रीक्वेंसी एंड देन फिर वही आप बता गौर करिए, कोई कमेंट?
Genitourinary tuberculosis, primarily to diagnose, will be only in cases in which known history of tuberculosis is there, because usually that goes in with the hematogenous route, and those patients are either treated or they are already having the tuberculosis. They are more prone for those, and once it is there, he's right about that. They usually present with unexplained frequency. So once other things have been ruled out as far as any of the general surgeons, and still there is persistent frequency, then final, and there is a history of tuberculosis, you must take care that urinary AFB can be taken up, and maybe it comes out to be as positive. As far as tubercular, for all the residents, remember one thing which I found while I'm missing something. There is something capital Gola formation. That is very, very indicative of abdominal tuberculosis. History of recurrent abdominal distension, especially postprandial, and there is borborygmi sounds, means hearing of the peristaltic waves that can be heard by the person sitting next to the person, especially in females. Anyone having thin, because usually abdominal walls are thin or atrophied in such patients. If those, and there is a recurrent history of abdominal distension, if that is there, that is one of the suspicion areas. And once you have a suspicion, in today's era, a good quality CECT or a diagnostic laparoscopy should be done as the earliest, or else you will be tackling with the complications, and complications means at least ileostomy is supposed to be there, because those patients are automatically so low immunocompromised that doing an anastomosis in an emergency setup might be not a good decision to make. But it was a very elaborative presentation.
Quite,
it was good. It was good. It was good.
अच्छा जेनाइट यूरिन का दूसरा ये है कि कंटीन्यूअस फ्लो जो यूरिन का रहता है तो स्टेसिस ना होने की वजह से तो वो चलता रहता है, जब कम 1 to 2% आई थिंक केसेस आर abdominal.
Sir, what is the role of CBNAT in confirmation of diagnosis? Can we start CBNAT consultation in case of abdominal? After CBNAT what हमारे यहाँ पे हो रहा है, CBNAT का क्या रोल है?
कोई ना सर, वही है ना सर, ब्लू नाट का 80 days 98 to 99% बताना उसका रोल है, बट फिर भी सर कहीं ना कहीं उसमें आई जाता है कि मिसयूज होता है. जैसे पेशेंट का मैंने बताया उसका CBNAT पॉजिटिव था, अब वो उसको छोड़ नहीं सकते, वो था malignancy.
But as far as the empirical therapy is concerned, usually in Indian scenarios, if there is a clinical strong suspicion or clinical finding on table or clinically, otherwise also or intraoperative, you can go in for giving in. Once other things have been ruled out, other things means query malignancy or inflammatory bowel disease, once they have been ruled out, you can go in for empirical anti-tubercle treatment. If CBNAT comes out to be positive or any nucleic acid test, they come out to be positive, that will be an objective evidence. Otherwise, to refer a patient to a DOT center, and suppose even if it has come out to be negative as far as the nucleic acid or any biochemistry tests are concerned, if we write strong clinical operative findings suggestive of tuberculosis, they start off. But for that, surgeon needs to write that and only then the dots persons will be starting off. Otherwise, they don't start off. No. Remember again, dots person. That's what I'm saying. Dot person.
Empirical treatment give rise to the resistance.
Right. Empirical, what I mean is, suppose you go in and you find there are studded with tubercles. Suppose you take it out and you send it for histopathology and it comes out to be, let's say, FB negative. Even then, because you saw the caseation or those tubercles inside, you can start ATT and that patient has to be registered for the dots, even if the CB knots comes out to be negative. I'm saying in those cases.
डायग्नोस्टिक लैब का सर यही बड़ा एडवांटेज है, आपको टिश्यू मिल रहा है, टिश्यू में
what we discussed in 2020 still holds true in 2026.
Definitely, sir.
And what we have discussed in 2015 still holds true. We, most of the time, we are not able to see microvascular tuberculosis.
Definitely.
That's the directive.
Definitely, sir.
Yes, we can see granulation tissue, granulomas, epithelioid granulomas, or caseating granulomas in very few percentage.
Agreed.
Most of the time, even today, we have to start even with gamma interferons, what is TB gold, PCR, all what we are having, but still, we have to start.
Definitely, sir. Because you give it for initial 2 to 3 months and you re-evaluate the patient. That is one of the best evidences.
लंबा अब कोई एम्पिरिकल देने का सबसे बड़ा है कि लंबा इलाज चलता है 9 महीने का, तो टीबी नहीं है उसको 9 महीने खानी पड़ेगी.
Yes, the patient will have all the rebounds. Patient in partial obstruction will come to again and again after 110 days.
No. I tell you, that's something. Dot center do comply if the operating or the surgeon under whom the care is, if they write strong clinical, the word is supposed to be strong clinical or operative findings suggestive of tuberculosis. If you write it and send it to the dots, they comply with it because they never go in for negating your diagnosis. They are either, usually the patient that come over there is either with the CB-NAT test or with the sputum positives. But abdominal tuberculosis or extrapulmonary tuberculosis is very difficult to prove on paper. And that's why strong clinical suspicion is an indicative of starting ATT in such patients.
Suppose a patient is coming in for the or formation is there. You want to put on a medical treatment. How long you want to keep a medical treatment? Whether it is arrangement can be asked.
इसके लिए सर गोला फॉर्मेशन सर रिस्पांस बेस हो जाएगा 3 वीक यूजुअली ATT सर
एक्सप्लोर करने का आप क्या सोचते हैं? आपने शुरू किया, अब जैसे डॉक्टर साहब बता रहे थे कि रिपीटेडली रेगुलरली कमिटेड सर्वे टू हॉस्पिटल.
So may I answer that question on behalf of him, sir? A gola formation simply means that there is some kind of luminal narrowing. That could be because of a omental band, a peritoneal band, or a stricture anywhere. If it is there and the patient has been having recurrent pains, it is always better that rather than starting these patients on medical management and patient has visited emergency multiple times, have got a Ryle's tube and that has drained, let's say, a biliary or a feculent content, that is very much indicative, yes, this patient is there in something known as subacute intestinal obstruction. Somehow the current literature says that SAIO word has been taken off. Either it is symptomatic or either asymptomatic. If it is symptomatic, you need to go in for a CECT or a diagnostic laparoscopy and then proceed forward accordingly. If it is a possible stricture, you can get away with only doing a stricturoplasty and then continue or follow up the patient with your ATT, anti-tubercular treatment. But if you feel that the strictures are tight enough and the ICJ junction is thickened, it is always better to go in for a limited right hemicolectomy. That is the bare minimum which is required. Sir.
सर सर्जन है तो फिर तो अब गोला बना हुआ है, सर्जन है तो
नहीं गोला मीन सर मैडम हर बार खाने के बाद अगर हो रहा है
खाने के बाद भी सर्जन
तो इंडिकेशन
नहीं करेगा
सर डेफिनेटली सर बिल्कुल
गोला तो सर अपने आप ही कह रहा है कि सर्जरी कर दीजिए थैंक यू वेरी मच
Very enlightening session. I request Dr. Amit Agrawal sir to felicitate Dr. Dheeraj Balyan sir. I request Dr. Poonam Gupta ma'am to felicitate Dr. Vikas Singh sir. I request Dr. Harinder Sandhu sir to felicitate Amit Agrawal sir. I request Dr. Dhanesh sir to felicitate Dr. Arun Kumar sir. Surgery is ever evolving, and these type of conferences help us to integrate that knowledge and share this knowledge to many more people and to make the world a better place. With this, we end the sessions, and now I request everybody to proceed for the lunch. After the lunch, there will be session of paper and poster presentation. Paper presentations will be here, and poster presentation will be in the LT on the same floor from 2:35 p.m.